Hello, everyone. I will start my presentation.
Hi, you can give us a few minutes and
Oh,
we'll present you.
mhm.
How are you this morning? We're
Hello.
going to be waiting for a few
Everyone.
minutes.
Thank you for the invitation. I'm okay. Just waiting for this very nice conference that you organized.
Yes, we're going to have quite a few people, so we're very excited to start in a few minutes. I think
Yes,
we'll wait maybe like until 4 more minutes just in case
sure,
everyone else needs to join.
sure. Mhm.
Well, good morning or afternoon from wherever you are joining us, and thank you so much for joining today. It is my pleasure and great honor to welcome you all to the first day of the NeuroCon 2025 for the neuroscience, neuropsychology, and neurobiology communities. We are very glad to meet again for this fourth edition of NeuroCon. I hope you're all ready to dive into this year's theme, the neuroscience of trauma, the brain under stress. The impact of trauma on human health and society is a pressing global issue, and the research in this field is evolving at an incredible pace. During the next 3 days, we will have the opportunity to explore this complex subject from multiple angles, including the intricate neurobiology underlying trauma and chronic stress mechanisms, the search for effective strategies for resilience and intervention, and how trauma affects behavior, mental health, and society across the lifespan. My name is Sofia Pavon, and I will be one of your hosts today. We have an exceptionally exciting program lined up for you today as we dive into the neurobiological perspective of trauma. Don't forget that after each speaker is done, there will be 10 minutes for questions you can pop in the chat below, and that certificates of attendance will be sent at the end of the conference on the condition that you attend at least 15 hours over the next 3 days, including breaks. So, without further ado, it is my honor to introduce our first speaker of the morning, Dr. Maria Magdalena Makarenko. Dr. Makarenko is a distinguished doctor in psychology, a clinical psychologist, psychotherapist, and an eye movement desensitization and reprocessing consultant, supervisor, and training with over 20 years of experience specializing in trauma and psychological trauma therapy. Her clinical work and research focus on critical areas like complex PTSD, dissociation, and the increasingly recognized link between adverse childhood experiences and autoimmune diseases. Her presentation, titled Unseen Divisions of Self Dissociation as a Trauma Related Survival Mechanism, promises to be fascinating. She will discuss how dissociation, initially a fundamental survival response, can become a key bridge linking trauma, mind, and body, contributing to long term physical outcomes like autoimmune disease. She will share empirical findings from randomized controlled trials on how targeted therapies like identity oriented psychotrauma therapy and eye movement desensitization and reprocessing can significantly reduce dissociation in patients with conditions like Hashimoto's thyroiditis. So please join me in welcoming Dr. Maria Magdalena Macarenko.
Thank you very much, Sophia. It's very nice to hear your words. And now I will share my presentation. So, today I will talk about dissociation, which is often an overlooked or unrecognized mechanism. And because of this, therapists may not fully address it in treatment, leading to a lack of progress. In the same time, medical doctors or physicians rarely consider dissociation when working with patients who present complex or medically unexplained symptoms. So we'll see during this presentation that although dissociation is often unseen, it is in fact highly prevalent across both psychiatric and medical populations. And this raises important questions, such as, could dissociation be one of the missing pieces that links psychological trauma with physical health? And if so, what might happen when we target dissociation in therapy? But let's start with defining dissociation. So from Pierre Janet to contemporary trauma theorists, dissociation has been described as central to the experience of trauma. Janet called it the very essence of traumatization. Peter Levine reframed it as a gift, a way not to be present when the situation is unbearable. Stephen Porges highlights its heroic protective function, while Braha and Kluft emphasize dissociation as the last option when escape is impossible. So together, these perspectives reminds us that dissociation is not pathology in itself, but the brain's best survival strategy in the moment of trauma. So as we look at this slide, we can see that dissociation is perhaps the best thing our brain can do during a traumatic experience, an experience that is so overwhelming that we could not survive or endure it without the help of this dissociation mechanism. But all these appreciative words we saw on the previous slide refer to peritraumatic dissociation, the one that happens during or immediately after trauma, and this is very adaptive. It helps us survive by numbing pain and by altering consciousness through the help of endorphin and dynorphin, which are the body's natural opioids that are producing states of derealization. So derealization, you don't realize what is happening. Or depersonalization, when you are detached from your body, you're detached from your feelings, your thoughts, like an external observer. On the other hand, post-traumatic dissociation, however, this is maladaptive. Why? Because it gets triggers long after the event by internal or external cues, keeping trauma outside awareness. And by doing that, preventing real integration and healing. Dissociation can sometimes manifest very directly. The patient may stop responding. The patient may appear absent, or they can fix their look, their gaze. But more often, dissociation is subtle, is hidden in silences, in the body, in the ways the patient distances himself from the emotional contact. There may be an incongruence between verbal and non-verbal expression, or in how language is structured. For example, speaking about oneself in the second or the third person. Like, you did that, or you are stupid, you are traumatized, or the girl sent the suffering, something like that. Or by choosing particular word, because for someone with chronic trauma, words do not carry the same meaning as they do for someone raised in a supportive family. Traumatized individuals have learned alternative modes of communication, ways that were safe then, but now they create difficulties. So, this data show that dissociation is not rare. It appears in 5 to 10% of the general population, but rates rise sharply among psychiatric patients, among trauma survivors, and even in medical staff that regularly are exposed to acute stress and trauma. So this supports the view of dissociation as a trans-diagnostic and a trans-contextual phenomenon that really deserves systematic clinical attention. So, like I said, dissociation is not limited to a few diagnoses like dissociative disorders or PTSD, but rather it functions as a psychopathological process that presents across many psychiatric conditions. And that means that whenever we are working clinically, dissociation may play a role. So let's see, because officially, dissociation has only one chapter in DSM, but in reality, we encounter it across many other psychiatric conditions. It is highly prevalent, as I said, in PTSD, in post-traumatic stress disorder, and acute stress disorder, where it can manifest as dissociative amnesia, when you don't remember what happened, derealization, depersonalization, and of course, flashbacks, which are discontinuation in the temporal and perceptual awareness. And this is an important problem with severe dissociative flashbacks, because they can be mistaken for an acute psychotic episode. And maybe we'll talk about more this in the panel today. Moreover, in borderline personality disorder, dissociation is often stress reactive and is sometimes mistaken again for mild psychotic symptom because of the paranoid ideation. So research suggests that these dissociative manifestations contribute to affective instability and also to self-injurious behaviors. Also, in major depression, we meet dissociation as a form of depersonalization, derealization, or emotional numbing. In eating disorders, is associated with compulsive behaviors and difficulties in body awareness. In OCD, we have dissociation in the intrusive thoughts and ritualistic behaviors. And in the same time, we need to distinguish, and it is essential to do that, to distinguish dissociation from psychotic phenomena. So how aware is a person on their experiences, and whether those experiences feel disturbing or natural to them, can help us distinguish dissociation in schizophrenia from actual psychotic symptoms like hallucination or delusions. So, dissociation is present to varying degrees across multiple psychiatric disorders, and this often overlooked presence has significant clinical implications, both for diagnosis and intervention. So this error may exacerbate the symptomatology or mask other clinical issues. So here is the risk, because psychiatrists, therapists, and also physicians often fail to take dissociation into account in their treatment planning, which can lead to therapeutic blockages. This mechanism has been described also in a variety of medical conditions, from chronic pain and fibromyalgia to gastrointestinal disorders like IBS or inflammatory bowel disease, and even in systemic diseases such as lupus and Hashimoto's thyroiditis. And clinically, this means dissociation can complicate assessment and treatment, and it may amplify and mask, as I said earlier, the underlying medical picture. So, when dissociation persists over time, unseen, untreated, it can have an impact also in the body, not only in the mind. To explore this connection further, we wanted to understand if dissociation connects trauma with the body, and whether addressing it in therapy could promote healing. So first, we conducted a mediation study examining dissociation, alexithymia, and anger as pathways between childhood trauma and autoimmune diseases. So we had 306 autoimmune patients and 292 self-declared healthy control, and they were included in the study. They completed self-report questionnaires regarding childhood abuse, alexithymia, dissociation, and anger. And the results of the structural equation models suggest an indirect relationship between childhood trauma and autoimmune disorders mediated by dissociation and alexithymia, but not by anger. And for us was surprising to see that the effect of trauma on anger was negative, indicating that association of increased trauma with decreased anger. This might be explained by the fact that dissociation and alexithymia, which is again another dissociative mechanism. So those two can inhibit the capacity to integrate emotions into conscious experience, restricting healthy defensive responses by keeping unpleasant emotions into unpleasant emotions and also unpleasant thoughts outside awareness. And in this way, anger as an unpleasant emotion could remain dissociated from consciousness. This could explain why anger was not a relevant mediator in the study. So, early childhood trauma form the basis for developing alexithymia and dissociation, and this defensive mechanisms, not the experience of trauma itself, may contribute to the development of autoimmune diseases. And I say that because research suggests that alexithymia, which I repeat is another form of dissociation, because the person cannot describe emotion, cannot understand what is happening inside them. So this mechanism is correlated with altered autonomic, endocrine, and immune activity. And this is leading to tissue damages, and is considered in research as being a condition characterized by a pronounced inflammatory state. So, alexithymic patients or individual, because not everyone is a patient, right, may have a weakened anti-inflammatory buffer capacity, thus increasing vulnerability to inflammatory process. The first randomized control trial it's about a trauma therapy, which is called identity-oriented psychotrauma therapy. And we wanted to evaluate this treatment effectiveness in adults with Hashimoto thyroiditis, which is a chronic autoimmune disorder correlated with early trauma. So we randomized 70 adults with Hashimoto to receive either treatment as usual or treatment as usual plus IOPT. We offered 10 group sessions, one session every 2 weeks, and outcome included thyroid peroxidase and thyroglobulin antibodies, along with dissociation, alexithymia, depression, anxiety, stress, anger, and quality of life. And we assessed the results at baseline, post-treatment, and 3-month follow-up. So the initial analyses are suggesting that IOPT was associated with reductions in thyroid peroxidase antibodies, alongside improvement in several psychological outcomes, including dissociation, alexithymia, depression, anxiety, stress, and anger regulation. However, sensitivity analyses indicated that the observed immunological effects, especially for TPO, thyroid peroxidase, were not robust across analytic strategies. So the psychological benefits were consistent and clinically meaningful, while immunological changes are promising but need replication. So the second randomized control trial, because we wanted to see if another trauma treatment can have the same results or different results. And we used eye movement desensitization and reprocessing. And we had also on Hashimoto, and we had 91 adults with Hashimoto. In this randomized control trial, we had 3 arms: EMDR, treatment as usual, and placebo. We had 12 EMDR and placebo weekly sessions. Unlike IOPT, which focuses on identity fragmentation, EMDR targets the traumatic memories, allowing integration through reconsolidation. So we examined the effectiveness of EMDR in improving psychological functioning and also modulating immune markers in adults with Hashimoto. The EMDR protocol focused on processing 10 distressing memories, 10 distressing or traumatic memories before the illness onset, including the period of development, adolescence, until 18 years old. And outcomes included the 2 main antibodies, the measure of depression, anxiety, just like the previous randomized control trial, and we assess it at baseline, post-treatment, and 3-month follow-up. The results. So EMDR led to significant improvements in dissociation, alexithymia, depression, anxiety, stress, trait anger, and emotion regulation, along with enhanced quality of life. And these effects were maintained at follow-up and generally exceeded the results of placebo or treatment as usual. A significant reduction in antithyroid peroxidase levels was also observed in the EMDR group, and between group differences at post-treatment and follow-up, although between group effects at follow-up did not remain significant after correction for multiple comparisons. So the observed reduction in antithyroid peroxidase may reflect early immunological shifts, but further research is, of course, very necessary to determine whether these changes are robust, are clinically meaningful, or sustained over time. So, bringing everything together across all 3 studies and the theoretical background, we can see dissociation as much more than a symptom. It's a core trauma mechanism that protects the psyche when the experience is too overwhelming to integrate. And dissociation can reverberate far beyond the psychological level. And data suggests that our data, suggests that dissociation may be one of the pathways linking trauma to mind and body dysregulation, including autoimmune processes. Clinically, this means dissociation should be recognized as a treatment target. We should address it in therapy, helping patients reconnect with the parts of themselves that once had to split off. Trauma psychotherapists can, of course, reduce dissociation, and this may restore more adaptive self-regulation in trauma-affected patients with chronic somatic conditions. And we see that as the dissociation decreases, markers of bodily stress and immune reactivity also tend to decrease. So, in other words, by addressing dissociation, we may also influence the body's capacity for regulation. Of course, saying that with caution, as we find preliminary evidences in our studies, and we need replications in larger trials. But in the same times, we saw that trauma psychotherapists may be supportive intervention in Hashimoto patients. And this is very important because it calls for interdisciplinary trauma-informed practice across mental and physical health. What was also surprising in our randomized controlled trials was that we discovered that over 96% of Hashimoto participants reported cumulative early trauma. And this is huge. Over 95, almost 100%. This is huge. And this is essential for us to work together. Trauma therapist, clinical psychologist, and medical care. Our studies support this integration of trauma-focused intervention in the treatment of autoimmune disorders, and I would say in the treatment of any other chronic illness. This is very important. Okay, so I will end with this. Healing begins with revealing the unseen, of course, unseen dissociation, unseen divisions of self, because it is the only way we can integrate experiences that would otherwise continue to affect both our psyche and our body. Thank you very much. I will stop sharing my presentation and I will be open for questions.
Thank you very much, Dr. Makarenko, for your insights. So we're going to move on to some questions from the audience, and make sure you're dropping them in the Q&A section so we can see them.
Okay.
So let's see. So from an evolutionary perspective, what kinds of environmental or as ancestral survival pressures might have forced or favored the emergence of dissociative mechanisms as an adaptive response to trauma?
Mm. Of course, we are talking about the events when the dissociation means existence of a traumatic event. So, from the evolutionary point of view, we can start even earlier. We can start with the intrauterine experience, intrauterine period, because that this is the place our life begins, in utero. So if in utero our environment, meaning our mother, is not so keen to meet the baby, maybe she's stressed, maybe she's also traumatized, maybe she doesn't want to be pregnant. But this situation for the baby is very dangerous, because it's a different situation where the mother doesn't want the pregnancy, and she's saying, okay, I will keep it, and is very dangerous and um, very present in the body of the baby, when the mother is going to do something against the pregnancy. So because we work also with this IOPT, which can many times can show us how awful, how dangerous was for the baby inside the womb. We can see the first situation that provoked us to split very early in the womb. And if we start with that, just imagine how can be the rest of our life, continuing with attachment trauma, continuing with sexual trauma, because if you are already splitted in the womb, of course you will just continue to do that. And why it's adaptive? Because you don't have a choice. If you don't split, you can die. So it's a dissociation. It's also a biological mechanisms that is helping us survive, really survive biologically, not only psychologically. Okay.
Thank you. That is really interesting. So we have a few more questions. How do you interpret the finding that the antibody results were not as robust as the psychological ones?
Can you repeat, please?
How do you interpret the finding that the antibody results were not as robust as the psychological ones?
Okay. Mm-hmm. Well, I didn't like that. I didn't like to see that we don't receive the same results as in the psychological symptoms and decreasing. But of course, we interpret like every time, the body needs more time to change. If you imagine this mechanism is so hard to change in a psychological level. So imagine this mechanism inside our body. How long a body, so how much a body needs time to understand that it is safe now to function well. So, sometimes we know that we are safe, but our body is trembling. So the body doesn't know is safe. So that's why, in the first place, I think it's about time. The body needs more time. And what my statistician colleague said, despite my clinical interpretation, he said, I think we had a very small lot. So we need to do that again in a larger trials. So because when the trial is very small, so many statistical things can appear, and the results don't stay too robust. So we have two interpretations, one clinical and one from the statistical point of view.
Thank you. And I guess that relates to another question that we have in the box, of how long does it usually take from a traumatic event to the potential onset of an autoimmune disease?
Sometimes many years. There are studies that are showing that can be over 20 years. Sometimes the patient could become a patient too quickly or more quickly, but many years. Because again, it's like you need to be stressed, and you need to live in a traumatic environment for so long in order for the body to say something, or because the body of course is saying something all the time, but sometimes when we don't hear, the language of the body can become more severe. So if we live in a chronic traumatic situation or chronic stress, of course, this will replicate into the body. So of course, we need some time for the body to make those chronic illnesses or the chronic symptoms. Mm-hmm.
We have another question. What inspired you to do this research?
Good question. Well, I was very intrigued of the autoimmune conditions, because I translated what is happening in an autoimmune condition, meaning that the immune system doesn't recognize his own body. So what is mine? What is mine? I have to attack what is different, what is not mine, and I have to preserve what is mine. This is the healthy immune system. But in the autoimmune system, this is opposite. And I translated the way we see the psychological mechanism. In dissociation, you don't recognize parts of you. And I wanted to see there is a correlation from this perspective. Exactly the way we don't, when you are traumatized and when we are dissociated and we don't recognize what is happening inside ourselves at the psychological level, there can be a link or not a link or a mirror inside the body. And so I started doing that. And because for an RCT, I needed many patients for the same autoimmune diseases. I chose Hashimoto because it's the most prevalent between autoimmune diseases. So I could have some success in bringing together 100 of patients. So
Yeah, that link is super important between mind, body, health.
yeah.
Can maternal trauma transfer in the uterus even if the mother wants the child?
Good question. I would say yes, because if the mother is traumatized, her nervous system is still responding to trauma. So the stress hormones and what is happening into the brain, into the body of the mother, can be felt through the placenta by the child. So even the mother can want the child, in the same time she's traumatized. So she may have a dysregulated nervous system that, of course, is transferred not because she wants that, but because they are two persons in one. So this is almost unescapable for the baby to stay there in the stress hormones of the mother.
It's super interesting. We have a couple more questions. So, from Irina, is it possible that recovering from dissociation feels overwhelming for the client? Feelings of fear in relationships and anger that are felt unbearable?
I didn't understand the question. Irina. Okay, I see the question.
Yes.
It is possible that recovering from dissociation feels okay. Feelings of fear in relation that are felt unbearable. Okay. Yes. My short answer is yes. That is why in trauma therapy, recovering from dissociation should be done very gently, because dissociation, we need to remember that it is a defense mechanism. So if we start to fight this defense mechanism, the client will start to fight back, and the patient will fight back with increasing the protective mechanisms. So the therapeutic approach, the golden standard of therapeutic approach in case of trauma and dissociation, means starting with stabilizing the patient. And regarding dissociation, that could mean grounding. That could mean to be for the clients to be safe into the therapy room, to be safe with the therapist, because sometimes, although they know they should feel safe in therapy, they should feel safe in the therapy room with the therapist, And they can say that even. But what you recognize from the behavior is that they don't trust you. So if they don't trust you, you cannot work on trauma and dissociation. You cannot work yet. So you need first to restore safety. Safety is the basis where the patient can be healed. If you don't have safety, you cannot go to the processing of anything. You have to stay here at stabilization. Okay, I don't know if I answered that.
Let's see. Yes.
Okay.
And now for our last question, unless anyone else wants to ask something else. Roxana asks, maybe this is not a personal focus of your research, but I noticed that many professionals are discrediting the diagnostic of dissociative identity disorder. What are your thoughts around that and the mechanisms of this disorder in general?
I wouldn't use this word, Roxana, discrediting. Indeed, DID is more rare, not absent, a more rare diagnosis, and in the same time, it's very complicated to recognize it. So, and I will say that more in a panel, because there is a real problem with this. Many times, students and psychologists are not trained in recognizing simple dissociation, not to say DID. So, of course, DID is a diagnosis. Of course, we can meet this diagnosis into our rooms, but we need to recognize it in order to can work with it. Otherwise, of course, you can say, no, it is too rare to work with it. Is not too rare to not to have a chance in this life to have a patient with the DID. So you need to be prepared. But I wouldn't use this word. So I would say we need to recognize first. We need to be trained first in our psychotherapeutic schools. Doesn't matter what that psychotherapeutic school are you in. It's a trauma approach, or it's an experiential approach, or it's clinical, doesn't matter. We need to be taught about trauma and dissociation in order to recognize, because you can work with an experiential, very soft, with drawing, with everything, and one DID patient could appear in your office. What do you do then? Okay.
Okay, well, I hope those were all the questions that we had for today. As you can see, there's a poll where people are giving feedback, which is really good feedback. So thank you, everyone.
I don't see the poll.
Oh, there's a poll.
Okay.
Down
Okay.
in the bottom.
Okay.
Yes. So they're saying excellent, very good, highly relevant clinical relevance, strong quality of evidence. And yeah, so make sure you're also, everyone is giving feedback for Dr. Maria Magdalena. Well, if there are no more questions, thank you very much, Dr. Makarenko.
Thank you.
And if anyone would like to hear more, Dr. Makarenko will also be joining us in the discussion panel on the neuro and psychological mechanisms of dissociation as a coping mechanism to trauma in an hour with some 2 other speakers. So thank you very much.
Thank you. Thank you so much, Sophia. And thank you, everyone, for questions and for being here.
Amazing. So now we're going to move on to Dr. Aline Nesmet, who's a highly accomplished professor of neuroscience at the University of Bordeaux and a team leader at the Neurocenter Magendie. She's a pioneer in the field, dedicating her research to the neurobiological basis of traumatic memory. Notably, she is credited with developing the first animal and mice model of traumatic memory, a major breakthrough published in Science. Her work continues to provide critical insights into post-traumatic stress disorder, and she is the author of numerous influential scientific articles and a recipient of 2 scientific awards. Her presentation, titled Contextualizing the Trauma Representation Prevents and/or Treats PTSD-like Memory, addresses the paradoxical memory alteration in PTSD, hypermnesia for the trauma, and amnesia for the traumatic context. Dr. Nesmet will share her latest findings, showing that a deficit in the hippocampus-dependent contextual memory can cause and sustain PTSD-like memory in mice. Crucially, she will present data demonstrating that promoting the contextualization of the traumatic event by activating the hippocampus or re-evoking the memory in the original environment can normalize this pathological memory. So please join me in giving a warm welcome to Dr. Aline Nesmet.
Hello. Good morning, everybody. Can you see my presentation?
Yes, we can.
Okay, perfect. So first of all, I would like to thank the organizers of this meeting, which gives me the opportunity to present and discuss some of our last data dedicated to the neurobiological basis of traumatic memory. So in the field of post-traumatic stress disorder, most preclinical studies in neuroscience focused on fear memory and the underlying amygdala almost exclusively. And in contrast, our work indicates that a deficit in the hippocampus-dependent memory might be at the core of PTSD. So today I would like to show you some of our data supporting this idea, and more particularly that contextual amnesia, which is dependent on hippocampal alterations at different biological levels, can cause the development and the persistence of PTSD-related memory. So this work is in line, in fact, with the dual representation theory proposed by Chris Brewin a few years ago. So such a work is first based on the fact that PTSD-related memory is qualitatively different from normal adaptive fear memories. What are the main differences between the two? I usually take the example of a highly aversive event. Confronted to a traumatic event like a terrorist attack, but also a military fight, bombing, or civil assault, depending on the person, and of course, depending on the distance from this event, different types of memory are formed. For instance, the exposure to two of this picture, the World Trade Center and Bataclan in Paris, which correspond to 2 different terrorist attacks, should automatically evoke the context of your day at least of this particular day, which was more than 20 years and 10 years ago, respectively. And now if I ask you to evoke the contextual details of this particular day, I guess that all of you should be able to describe this day in details. Why? Because you have strongly contextualized and thus strongly consolidated this event in your episodic memory system because of its strong emotional connotation. So this is a classical case of flashbulb memory, a classical case of normal, I would say, normative hypermnesia, which is also called flashbulb memory. It is an increased memory for an emotionally connoted event that is supposed to contribute to survival in an uncontrolled environment. However, with regard to such events, we kept, at least in my case, a good distance from it. But what happens for direct victims of such a situation? In that case, 25 to 50% of the subjects can develop a PTSD. And a cardinal feature of PTSD is a pathological memory. So what is traumatic memory? It is a paradoxical memory alteration, including both a traumatic hyperamnesia, which is an intrusive, strong fear memory, often based on salient trauma-related cues, and in parallel, a declarative amnesia for the traumatic context, or at least a deficit in declarative memory for other components of the traumatic event, and in particular for the traumatic context. So basically, the PTSD patient literally relives the trauma through flashbacks, re-experiencing all the physiological and the emotional feelings associated with the trauma without any control on this memory, without being able to represent it consciously, to talk about it properly. There is this dissociation between an extreme traumatic hyperamnesia, which is a non-controlled memory, emotional memory, intrusive and recurrent, and this deficit in declarative memory, in the ability to represent it consciously. However, so far, most animal models for PTSD focused exclusively on the quantitative aspect of traumatic memory, and in particular, the hyperamnesia. That is an increased and persistent fear reaction, which can nevertheless be adaptive per se. Or they focused on anxiety-like behavior and or on stress-related physiological changes. But stress is not necessarily a traumatic stress, and even a traumatic stress does not necessarily produce PTSD. So, in fact, we observed a major weakness of most models for PTSD. That is that almost none of them, distinguish between adaptive and maladaptive stress induced by biobehavioral changes. For instance, so the biobehavioral changes observed can be either aspect of a maladaptive behavior, a PTSD-related phenotype, or an adaptive response to stress. So, for instance, the fear conditioning model, it's an excellent model for studying normal fear memory for more than 1 century. And fear conditioning can produce a strong and persistent fear response, which is generally considered as an adaptive fear behavior that promotes survival. So how can we use it as such to mimic both adaptive fear memory and a pathological fear memory? In fact, it is necessary to define the boundary conditions in which stress leads to normal versus PTSD-like memory. So the first challenge of our team was to model the qualitative memory alteration of PTSD, and not only the quantitative component of fear memory. A few years ago, we developed an animal model in which mice were submitted to a contextual fear conditioning, in which a salient tone is presented, but never paired with the foot shock. And thus, this tone is not predictive of the threat, which is the foot shock. The tone and the foot shock are pseudo-randomly distributed. Immediately after fear conditioning, mice received either a corticosteroid or vehicle systemic injection. And because corticosteroid is the main stress hormone in rodents, when it is combined with a relatively high stressful experience, it is supposed to mimic a traumatic stress, a hyperreactivity of the HPA axis as it is observed in PTSD patients. And then 24 hours later, the quality of the memory formed is assessed in mice by measuring the conditioned fear responses expressed during the re-exposure to the tone in a safe context, and then during re-exposure to the conditioning context. So basically, control mice, so mice that were submitted to the fear conditioning but that received a saline injection and no corticosteroid, display a normal fear memory characterized by no conditioned fear to the tone. When they are exposed to the tone, there's no increase in the fear response, and by a relatively high conditioned fear to the context, in particular during the first 2 minutes when they are exposed to the predictive conditioning context. In contrast, mice that received corticosteroid injection developed a PTSD-like memory profile, characterized by this abnormally high fear response to the irrelevant tone, because I remind you that the tone is salient but not predictive of the food shock. So this increase in the fear response is maladaptive. And with a deficit, a significant deficit compared to controls in their conditioned fear to the predictive context. So these mice focused, in fact, on a salient trauma-related cue, and in this way, the model mimics the emotional or the traumatic hyperamnesia, while forgetting the traumatic context. And in that way, the model also mimics contextual amnesia. This model, which has been published in 2012, has two great advantages. First, it recapitulates the two pathological memory components of PTSD, hyperamnesia and contextual amnesia. And second, it systematically compares traumatic memory with normal adaptive fear memory. So, in fact, this model gave us the opportunity to identify very specific neurobiological alterations of PTSD-related memory. And we indeed have identified specific alterations at different neurobiological levels, from the system to the cellular and the molecular levels. And today I'm going to focus on the system level, so the level of the brain structures, but I will also present some data that we obtain at the cellular level and at the molecular level as well. So first, at the system level, we know that in human, PTSD is associated with hippocampal dysfunction, sometimes even associated with reduced hippocampal volume, together with an amygdala hyperactivation. As in human, we showed in our model using CFOS immunohistochemistry that PTSD-like memory is associated with hippocampal hypoactivation and amygdala hyperactivation. And interestingly, this hyperactivation was restricted to the right hemisphere, which is another observation done in PTSD patients. So now, the hippocampal hypoactivation is supposed to underlie contextual amnesia, whereas the amygdala hyperactivation may be responsible for traumatic hyperamnesia. And in this field, preclinical studies, as I told you at the beginning of my talk, have largely focused on the amygdala hyperfunction. And so the left largely unexplored the role of contextual amnesia and of the underlying hippocampal dysfunction in PTSD. However, some clinical studies indicate that contextual amnesia could constitute a cause of the PTSD-related traumatic hyperamnesia and of its persistence. So how would it work? Well, decontextualized, disconnected from the episodic context-based memory system, the traumatic event would be out of control and thus would be prone to be automatically evoked by any trauma-related cues in various contexts, even in contexts very different from the original traumatic context. So in that view, contextual amnesia and the underlying hippocampal dysfunction would constitute an etiological factor of PTSD-related memory and its persistence. And in summary, contextual amnesia could cause the development and the persistence of traumatic hyperamnesia. So, of course, it's very difficult to test this hypothesis in humans. But we tested this clinical hypothesis using our animal model that precisely recapitulates the two memory components of PTSD. And this study was published a few years ago. So specifically, using an optogenetic approach, we tested whether the inhibition of the optogenetic inhibition of the hippocampus, and more precisely of the dorsal CA1 neurons, by impairing the contextual memory of a stressful situation, because we know that inhibiting the hippocampus leads to a deficit in contextual memory. This could produce the formation of a PTSD-like memory profile. In contrast, in a traumatic condition, so in corticosteroid-injected mice, the hippocampal stimulation or activation would promote the contextual memory of the trauma, and maybe this would prevent the formation of PTSD-like memory. So Shamal Abed was in a postdoc in our lab at that time, did this experiment. She submitted mice to a bilateral injection of virus-expressing ARCH-T or channel rhodopsin into the dorsal CA1. Then mice received a bilateral optic fiber chronic implants. The dorsal CA1 was targeted because first it was previously shown, we previously showed that it is hypoactivated in mice developing PTSD-like memory. And second, because it is classically described as a key hippocampal subfield for both contextual and declarative memory. And then a few weeks later, 4 to 6 weeks later, some vehicle saline injected mice were submitted to an optogenetic inhibition of dorsal CA1 neurons, whereas some corticosteroid-injected mice were submitted to optogenetic activation of the dorsal CA1 during the contextual fear conditioning. And as usual, 24 hours later, we have measured the quality of the memory formed during our 2 memory tests. First, when mice are exposed to the tone alone, in a safe context, and then where they are exposed to the conditioning context. So, as I previously showed you, in control conditions first, so in mice that were not submitted to any optogenetic manipulation, as previously, vehicle-injected mice in black display a normal fear memory characterized by a selective conditioned fear to the conditioning context and no fear to the tone, whereas corticosteroid-injected mice in red display a PTSD-like memory profile characterized by an abnormally high fear response to the salient tone and by this deficit in the conditioned fear to the context. Now, vehicle-injected mice that were submitted to the optogenetic inhibition of dorsal CA1 neurons during the fear conditioning display a PTSD-like memory profile 1 day later. As you can see here in green, they display an abnormal fear response to the salient tone, which is an irrelevant cue, together with a deficit of their fear response to the predictive context. So they behave exactly as corticosteroid-injected mice. So inhibiting the dorsal CA1 during stress induces a PTSD-like memory profile. We then showed that in contrast to inhibition, in corticosteroid-injected mice, so in a traumatic condition, the optogenetic activation of dorsal CA1 neurons during the fear conditioning prevents the formation of PTSD-like memory. As you can see here, these animals in blue display a perfectly normal, perfectly adaptive fear memory profile with this absence of fear response to the irrelevant tone and with a relatively high and normal fear response to the context. So activating the dorsal CA1 neurons during a traumatic event, during traumatic episode, prevents the formation of PTSD-like memory. So this first experiment shows that contextual amnesia induced by the inhibition of the hippocampus can cause a PTSD-like hyperamnesia, and that, on the contrary, promoting the hippocampus-dependent contextual memory prevents the formation of traumatic hyperamnesia. So this is interesting, but as you see here, we manipulate the hippocampus during the traumatic stress. So in a clinical perspective, it is crucial to know, once PTSD has been developed, whether the recontextualization of the traumatic memory may cure this pathological fear memory. We thus reason that remembering or reactivating the traumatic memory in the traumatic context may promote a recontextualization of the trauma representation. The idea was to reconnect the traumatic memory, which is decontextualized, with its specific context, so its specific environment. We have thus replicated the same experiments. So the first phases are exactly the same. Mice were submitted to our contextual fear conditioning protocol. Then they received saline or corticosteroid injection. 24 hours later, we have assessed the quality of the memory formed during re-exposure to the tone, then to the conditioning context. But then on day 3, some corticosteroid-injected mice were re-exposed to the tone in the conditioning context, which is represented by the blue line here. And this exposure of to the tone and to the context was supposed to promote a putative recontextualization of the traumatic memory. So during this phase on day 3, as you can see, corticosteroid-injected mice still display the classical deficit in the conditioned fear to the context here, compared to the controls before the tone, and an abnormal increase of their fear response when the tone is presented. Okay. However, as expected, 24 hours later, on day 4, these PTSD-like fear responses are suppressed. And now a normal contextual fear memory is restored. As you can see here, these mice, these corticosteroid-injected mice now behave exactly as control mice. So they display a fully normal memory profile. So the recontextualization of traumatic memory seems to normalize it. In contrast, because of course we had several group controls. So in contrast, when on day 3, when re-exposure to trauma-related cues is only partial. So for instance, when mice are re-exposed to the tone alone in a safe context, or to the conditioning context alone without the tone, or both to the tone and to the context, but spaced out of 2 hours. In all these cases, the traumatic memory remains PTSD-like on day 4. As you can see here, we have this abnormal profile with this abnormal fear response to the tone and a deficit of the fear response to the context. So this data indicate that when reactivation of traumatic memory is incomplete, not allowing its recontextualization, it seems to contribute to its persistence, strengthening the original traumatic memory trace. And it's probably what happened in the real life when PTSD patients reactivate their memory. Generally, it is outside the original traumatic context. So this may contribute to the persistence of the pathological memory. We have next tested the hippocampal dependency of this curative effect. So we have replicated the same experiment, but some corticosteroid-injected mice were submitted to inhibition of dorsal CA1 neurons during the trauma recontextualization. You can see here in green. So as expected, this hippocampal inhibition fully abolishes the curative effect of such exposure on traumatic memory. Compared to the corticosteroid-injected controls in red, these animals in green still display the PTSD-like memory profile 1 day later. Okay, so inhibiting the dorsal CA1 neurons blocks the recontextualization-induced normalization of traumatic memory. Finally, I would like to add that the PTSD-like memory and the normalized fear memory induced by the recontextualization persists for at least 1 month in our experiment, at least. So this study indicates that at the system level, the optogenetic manipulation of the hippocampus can induce or prevent, depending on the type of manipulation, of course, the formation of the PTSD-like memory. What about the hippocampal manipulation at more elementary, more basic neurobiological levels? So first, at the cellular level, Eva Ducournau, one of my previous PhD students, who is in postdoc now, in collaboration with Dr. Keul, have identified specific neuromorphological alterations of PTSD-like memory in the hippocampal amygdala network. And you can see here an example of a dendritic atrophy in a neuron within the dorsal dentate gyrus in the hippocampus. So in an animal that developed a PTSD-like memory compared to an animal that developed a normal adaptive fear memory. In particular, 10 days after conditioning compared to normal memory, so PTSD-like memory is associated with a reduced dendritic complexity in the dorsal dentate gyrus and a reduced dendritic length. So here we use a short analysis, and Eva showed that compared to several other groups of mice, all submitted to various fear conditioning procedure. So for example, we have here animals that develop in black a normal contextual fear conditioning that is produced by the exposure to a CSUS unpairing procedure. We have also in green animals that develop a normal tone fear conditioning produced by a CSUS pairing procedure. In this case, the tone is predictive of the shock. And here in blue, we have even a potentiated contextual memory that is induced by the exposure to a CSUS unpairing procedure, but that use a very low food shock intensity. And this procedure is followed by corticosteroid injection, the same dose of corticosteroid that we use to induce PTSD-like memory. But in this situation, because the food shock is very low, in fact, the dose of corticosteroid potentiates an adaptive contextual fear memory. And compared to all these adaptive fear memory, you can see that only the PTSD-like memory profile here in red display this reduced dendritic complexity. So this result, because we observed this 10 days after fear conditioning, this result also suggests that such hippocampal neuronal atrophy may be involved in the persistence of PTSD-like memory. So on this basis, we wondered whether this dendritic atrophy may be causally involved in PTSD-like memory. So to our knowledge, so far, nobody showed a direct causal involvement of neuromorphological changes in memory. So we have addressed this issue in collaboration with Émilie Pacari. And first, we found that blocking the dendritic growth by inhibition of RAC1 in the dorsal dentate gyrus produces PTSD-like memory. As you can see here, so Eva injected an inhibitor of RAC1 30 minutes before the fear conditioning protocol. Then 24 hours later, we have tested the quality of the memory formed. And compared to these two basic conditions, mice that received the inhibitor of RAC1 display so that receive saline injection, but in addition, the inhibitor of RAC1 display this abnormal memory profile, PTSD-like memory profile. Reciprocally, blocking the dendritic atrophy in the hippocampus by inhibition of ROC prevents the formation of PTSD-like memory while promoting a normal contextual fear memory. So again, here we have our two situations. And here you see in corticosteroid injected mice that should basically display a PTSD-like fear memory. The inhibition of ROC, in fact, produce the expression of normal fear memory, memory restricted to, fear memory restricted to the conditioning context. So to our knowledge, this is the first study showing that neuromorphological changes in the hippocampus directly contributes to the quality of the memory form, here adaptive versus PTSD-like fear memory. What about hippocampal alterations and manipulation at the molecular level? So at the molecular levels, we obtained several findings. First findings was a downregulation of the MAP kinase BDNF signaling pathway. But I don't have time to describe this study that was partly performed by Marie Menson, who is attending the meeting, I think. So I'm going to focus on another alteration that concerns epigenetic alterations. So PTSD-like memory, we found that it is associated with specific epigenetic alterations. We know that normal fear memory is associated with plasticity-related gene activation through epigenetic mechanisms such as histone H3 modifications. And interestingly, deficits in contextual fear conditioning are associated with impaired H3 acetylation in CA1, whereas increased histone acetylation facilitates the formation of hippocampus-dependent memory to the detriment of simple cue-based memory. So in fact, altogether, this data strongly suggested that a switch from H3 hyperacetylation to hypermethylation in the hippocampus could underlie PTSD-like memory formation. And these different acetylation, methylation levels, in fact, leads to the repression, gene repression, or active transcription, so gene expression in different, of course, brain structure. So Chloé Boirab, one of my previous PhD students, in collaboration with Nicole Mons, validated this hypothesis. Specifically, they first show that different experimental conditions, all known to produce normal contextual fear memory, are associated with hyperacetylation of H3K9 here in the dorsal CA1, but that PTSD-like memory, which is produced here either by contextual fear conditioning followed by a restraint stress, or by contextual fear conditioning followed by corticosteroid injection. We have these two procedures, but these two procedures lead to the same PTSD-like memory formation. So PTSD-like fear memory is associated with a significant reduction of acetylation of H3K9, and with a hypermethylation, hyper-3-methylation of this histone in this brain region. So these observations strongly suggested that an imbalance between acetylation-methylation states of H3 may contribute to PTSD-like memory formation. We have thus next assessed whether these epigenetic alterations were causally involved in this pathological memory. And we indeed showed that blocking H3 methylation in the dorsal CA1 prevents PTSD-like fear memory formation. So injecting BIX, which is an inhibitor of histone methyltransferase in the dorsal CA1, as you can see here, immediately after fear conditioning in that case, prevents PTSD-like fear memory formation. In fact, in this traumatic condition, so in corticosteroid-injected mice, this injection produce the formation of a normal fear memory. As you can see here, these animals here do not display the abnormal fear response to the tone, and they now display a fully normal and relatively high fear response to the context. This effect is persistent and is particularly pronounced 8 days after fear conditioning, as you can see here. Finally, compared to the PTSD condition, this treatment fully restores the acetylation-methylation level of H3K9 in a dorsal CA1. As you can see here, there is an increase of the acetylation level, and the level is comparable to that one observed in controls. And this injection also significantly reduces the methylation level of H3K9. So in fact, this injection normalizes the acetylation and methylation level of this histone. So results from these 3 studies at the system, cellular, and molecular levels indicate that the hippocampus seems to be a pivotal brain structure, a key brain structure in the formation of normal versus PTSD-like memory after trauma. Now, because the hippocampus is a key target of the stress response, it is supposed to be especially vulnerable to the effects of developmental stress. And its alteration could be a plausible mechanism by which prenatal stress contributes to some psychiatric disorders. So we have tested first whether prenatal stress could predispose to PTSD-like memory formation in adulthood through, of course, hippocampal dysfunction and thus through a deficit in contextual processing. And second, whether specific epigenetic changes could be associated with vulnerability or resilience to PTSD. In order to test the first hypothesis, we have submitted pregnant mice to restraint stress according to a procedure which is routinely used in Muriel Keul's lab. And then the offspring was submitted to a behavioral procedure, which is a variant of our classical behavioral protocol. We had a constraint. In fact, we designed this protocol in order to produce both a normal fear memory in control, so in no prenatally stressed mice, but also a PTSD-like memory in prenatally stressed mice eventually. So specifically in adulthood, mice were submitted first to restraint stress during 30 minutes, then to our classical contextual fear conditioning 24 hours later, and then we have assessed the quality of the memory formed 1 day later during our 2 memory tests. So basically, control mice that were not subjected to prenatal stress display a normal fear memory attested by a fear restricted to the conditioning context and no fear to the tone. However, in contrast, prenatally stressed mice display a PTSD-like memory characterized by the induction of an abnormal fear response to the irrelevant tone and by a low or lower, at least, fear response to the context compared to controls. We have then investigated the potential epigenetic alterations associated with this traumatic memory. So similarly to what was observed in our original model in the dorsal CA1, PTSD-like memory is associated with a significant deficit in acetylation of H3K9 in the dorsal CA1, together with a strong tendency for an increased 3-methylation of this histone in this region. Then we look for a potential individual vulnerability to PTSD-like memory formation in prenatally stressed mice. And interestingly, Chloe found 2 subpopulations. As you can see here, 1/3 of mice displays a resilient profile characterized by a normal contextual fear memory here that is comparable to the profile observed in control mice. And the other 2/3 of mice display a vulnerable profile with a high fear response to the tone and a very low fear response to the context. So this hyperamnesia, traumatic hyperamnesia, and contextual amnesia. Finally, we know that H4 acetylation is generally considered as a marker of contextual or spatial learning. And we observe that a post-trauma, 1 hour post-trauma, hyperacetylation of H4 in both control mice and in a subgroup of corticosteroid-injected mice, as you can see here. So this observation might indicate that such epigenetic change could be a marker of resilience in a traumatic condition. In that case, the mice would develop a contextual fear memory, whereas a low level of H4 acetylation would lead to contextual amnesia. But of course, we have to test this. So this result reinforces the key idea that the ability to contextualize a traumatic event might reduce the risk of developing PTSD. So to conclude, I would say that whatever the neurobiological considered so far, the manipulation of the hippocampal alterations we observed at the system, cellular or molecular level can prevent or even cure PTSD-like memory. So for instance, activating the dorsal CA1 neurons during stress promotes the formation of a normal fear memory and block the formation of a PTSD-like memory, but also promoting the dendritic growth in the dorsal dentate gyrus, activating the MAP kinase signaling pathway in this region, or inhibiting the hypermethylation of H3K9 in favor of its acetylation. All these manipulations can prevent PTSD-like memory formation and favor the formation of a normal fear memory. So altogether, these findings indicate that normalizing or stimulating the hippocampal function promotes the contextual memory of trauma and thus prevents, and in some cases can even cure, traumatic memory. On this basis, one of our main challenges now is to bridge between these different neurobiological levels in order to get a more complete picture about the neurobiological dynamic that specifically underlies the formation of these two types of memory. So the key issue here is thus to determine whether a specific change at one level is necessary and sufficient for producing a specific change, adaptive or maladaptive, at a lower or upper level. For instance, in a top-down approach, is the dysfunction in the hippocampal amygdala network necessary and sufficient for producing the altered neuromorphology and the epigenetic dysfunction specifically associated with PTSD-like memory? And what about the reciprocal process in a bottom-up approach? So answering these questions will allow us to identify specific neurobiological dynamics and different neurobiological dynamics underlying normal versus PTSD-like memory. So to conclude, I would say that the combination of a stressful situation and corticosterone or restraint stress can produce PTSD-like memory in mice and distinguish it from normal fear memory, importantly. Contextual amnesia, which is induced in our experiment by inhibition of dorsal CA1, can cause PTSD-like hypermnesia. Reciprocally activating the dorsal CA1, which promotes the contextual memory, prevents the formation of PTSD-like memory. Trauma recontextualization can cure PTSD-like memory, restoring a normal and persistent fear memory, and we found that this cognitive process is hippocampus dependent. Third, at the cellular level, we found that dendritic atrophy in the hippocampus, in the dorsal dentate gyrus, is causally involved in PTSD-like memory formation. Fourth, altered epigenetic mechanisms in the hippocampus, and in particular the hypermethylation of H3K9 in the dorsal CA1, underlie PTSD-like memory formation. And finally, prenatal stress predisposes to PTSD-like memory formation, and it is associated with altered epigenetic mechanisms. So these findings open up prospects for translational research, and they have also first therapeutic implications, because having shown that recovery from PTSD-related hypermnesia depends on recovery from contextual amnesia, these findings appeal for reorienting therapeutic approaches of PTSD from maybe an excessive focus on the amygdala-dependent traumatic hypermnesia to the overshadowed contextual amnesia and its underlying hippocampal dysfunction. Therefore, we plan to develop a translational project, a translational approach. And this is my last slide. In collaboration with psychiatrists and psychologists, we plan to test first the preventive effect of a context-based narrative anticipation of trauma, and second, the potential curative effect of recontextualizing traumatic memory. So based on our more recent findings in mice, these two perspectives imply a reassignment or reassignment of the traumatic representation to its specific context. So with its specific place, date, and sequence of events in order to promote a narrative-induced integration of the trauma in the episodic memory system. And in fact, the ultimate objective of this memory, I would say, episodic episodication or re-episodication is to regain control over this memory, thereby suppressing the traumatic flashbacks, because we know that the episodic memory is a controlled memory. So the idea is to regain control over the traumatic memory in order to switch from a PTSD related memory to a normal episodic fear memory, a memory that is certainly painful, but at least that is integrated in your episodic memory system, so that is controllable. And finally, I would like to thank the member of my group, in particular, Aline Marie-Guettot, but also, of course, Shamal Abed, Eva Ducournau, Aza Selami, Chloé Boirab, and my past and present collaborators on the different PTSD projects. And I thank you for your attention.
Thank you so much, Dr. Aline Smith, for your incredible insights. We are now going to move on to some questions from the audience, so make sure you drop them in the Q&A box. So we have a few. Firstly, since mice are quite different from humans, what would be some intermediate steps before these results can be confidently extended to PTSD patients?
Well, right now we try to test the hypothesis in healthy subjects with psychologists. The idea would be to test first this hypothesis that a dangerous context or a context, yes, in which the subject feel a potential danger is going to alter the memory processing, the contextual processing of the information, and thus produce I would say not a PTSD-like memory profile, but you see a profile that would a memory profile in which the subject would focus on some trauma-related cues, simple cues, to the detriment of the background context. Okay, so this is the first experiment, and a second experiment consists in promoting the contextual processing of a situation. So, for example, by the exposure of the subject to a video and then to in a discussion, the idea is to induce or to produce the episodication. It's a new term, but episodication, you know, the question relative to the what, where, when, how. So the idea is to favor the contextual and the episodic processing on the information with the hope that the subject will be able to process in a second step to process a traumatic information in this way. So this training is supposed to favor to prevent the formation of a PTSD-like memory and to favor the formation of a contextualized and normative fear memory. So this is the intermediate step between animal studies and studies in clinical studies in patients or in at-risk populations.
And related to that, in an ideal world where there's no barriers in science funding anything, what would be the best therapeutic or psychiatric applications of these findings?
Well, it would be, everything would be focused on one concept, the contextualization or recontextualization of the traumatic representation. So you can imagine in a therapeutic perspective first that the exposure of a PTSD patient to when it's possible, of course, to its original traumatic context directly or using virtual reality and the reconstruction of this context through virtual reality. And during this re-exposure, the evocation, the idea is to combine the contextual re-exposure and the evocation by trauma-related cue, control, of course, but the evocation of the traumatic event. And the idea is to reconnect the abnormal, pathological, uncontrollable, recurrent, intrusive memory of the traumatic event with its specific context. What I mean by context is its environment, so the place, but also the date, the temporal window, and the sequence of events during this day. So in fact, the idea, what I mean by recontextualization is the re-episodication of this traumatic memory. Because at least according to some clinicians, main difference regarding the memory, when you compare a PTSD patient and a victim of the same traumatic event, but who did not develop a PTSD, is one of the main difference is the quality of the memory formed. So the PTSD patient displayed this uncontrollable, recurrent, intrusive traumatic hyperamnesia, but at the same time, he or she presents this deficit in declarative memory. In contrast, the victim of the same trauma who did not develop a PTSD will be able, it will be painful for sure, but he or she will be able to talk about this traumatic event and to talk about the context, to talk about the event, the details of this traumatic event. And then he can stop talking about this event. And so the main difference is that the second person developed an episodic memory of the traumatic event and control this memory. So the idea is to switch from an uncontrollable traumatic memory to painful but controllable episodic memory of the traumatic situation.
Thank you.
And I would like to add that the idea is not at all to suppress the traumatic memory. I have even the feeling that we know that we know how to suppress a memory in mice. But I have the feeling that first, from an ethical point of view, this is a big problem to plan to suppress, even if it's a traumatic memory. The idea to totally suppress a memory in a subject is a problem per se. And second, I have even the feeling that if we could do that, the symptoms could be worse. Because if our hypothesis is right, it is because the PTSD patient cannot properly remember from an episodic point of view the traumatic situation that he or she developed these PTSD-related symptoms. So in this view, suppressing the traumatic memory artificially could in fact increase the symptoms and could worsen the situation. It's a hypothesis, of course, but in the logic of our hypothesis, this could be observed.
Thank you. So Kieran asks in the chat, given that some develop PTSD and most don't, why are some traumatic events processed within their context leading to an adaptive response and some become traumatic intrusive memories? What is the biological underlying difference for this difference, meaning to related to the event itself, but to the person who experienced the event?
So if I understood, I don't see the comment in the, maybe here. Yes. Interesting question. This is the whole question, in fact. This is the whole issue. You know, it's a probably very old pathology, PTSD. But in a way, the systematic clinical and studies in general regarding PTSD are very new. They are not very old. I mean, the systematic studies were developed in the 60s. Okay, so we don't know a lot from a biological point of view. We have a very clear, the clinicians have very clear now clinical picture of the pathology, but from a biological point of view, it's the very beginning of the studies. So as I showed you, we have some indication regarding the level of activation of the hippocampus, the amygdala, the prefrontal cortex as well. I didn't talk about the prefrontal cortex, but we know that the prefrontal cortex dysfunction as well. We have some data regarding some epigenetic mechanisms. So we know that the expression of some genes, but we have to define the target genes now. But we know that epigenetic mechanisms can be transmitted from generation to generations. So we have different results like this, but I would say that it's the very beginning. And all what I can say today is that why some people develop PTSD and why other people did not is the result of interaction between an internal individual vulnerability or resilience, the impact and the intensity of an external threat, traumatic event, and of course the way the individual is going to process the traumatic event during the traumatic event, and of course after the traumatic event. So the way the clinicians take the individuals in charge. But we don't, so far, it's very difficult to say that some people are going to develop a PTSD, or of course, we know that some people are more at risk than others. But I would say that it's too early to make a clear statement regarding this difference.
Thank you. Well, I hope that answered your question. And if no one has more questions, we're going on to the last one. So, do you know of any other examples of psychiatric conditions where these neurons are physically atrophied or affected like these?
So yes, we know that, for example, in some neurodegenerative pathologies like Alzheimer, we can observe an atrophy of not only the hippocampus. It's a more massive atrophy of the brain. But we observe at the beginning an atrophy of hippocampal neurons as well. In fact, we think that this atrophy, or at least this dysfunction of the hippocampus, would be at the core of this psychiatric disease, and this could explain the deficit in the episodic memory of the traumatic event. So what we call by episodic memory is the ability to contextualize, in fact, the event. So the person in Alzheimer's disease, for example, they are going to forget the episodic reference of their life. So where they are, what are the sequence of events of the different episodes, and of course, at the end, they lose everything. They forget everything, including their own identity. So in the PTSD, the common points between this pathology is a main deficit in the declarative memory, okay, which is dependent on the hippocampus. So because we developed a deficit in declarative memory, it seems that this is in favor of a more implicit, uncontrollable, intrusive memory. Alors, it can be procedural memory in other disease, and it is a traumatic hypermnesia, emotional memory in PTSD. Okay. It seems that there is a balance or an imbalance between the ability to declare, the ability to represent, the ability to control memory, and the more uncontrollable memory. I'm not sure. I'm
Very
totally
much
clear,
for Oh, so we do have another question. So Kieran would like to ask if contextualization is also connected to dysregulation, like in CPTSD. So I
like
guess,
in complex PTSD, I guess
yeah.
it's complex PTSD. Connected to decontextualization, of course, connected to dysregulation, like in complex PTSD. I guess yes. We have to evaluate. We have to assess this. The experiment I have presented today and the case I have in mind, you're right, refer more to simple PTSD. But we can extrapolate. We have to test. We have to assess this. I don't have clear answer on this point.
That's okay. Well, if there are no more questions,
Okay.
thank you so much for your insights. We are actually getting ready for the discussion panel. I think we're just having some issues with one of the speakers, so we might take a 5-minute break while we're waiting for one of the panelists. But thank you so much for your insights,
Thank
Dr.
you.
Aline.
Thank
It was
you.
very, very great. Thank you.
Thank you. Bye.
Okay. Well, while we wait, we're just having some issues with one of the panelists. Oh, yes, and we have the poll for feedback for this last call. If everyone can answer the poll on the screen while we wait. Okay, so we're still waiting for another one of our panelists, but we're going to start presenting. So welcome to our discussion panel on the neuro and psychological mechanisms of dissociation as a coping mechanism for trauma. Let me share my presentation here. My name is Sofia Pavon, as I have already presented myself, and along with Isabella Gianta, we will be taking you through the panel today. Today, we will be exploring the phenomenon of dissociation, a psychological and neurobiological response that can occur in the face of overwhelming or traumatic experiences. In this context, dissociation refers to disruptions in the normal integration of consciousness, memory, identity, emotion, perception, and behavior. It can range from mild detachment to more severe alterations in reality and identity, often seen in individuals exposed to chronic or acute trauma. Understanding dissociation is crucial not only for research, but also for improving clinical approaches and support systems. In this panel, we aim to unpack the underlying neural circuits, psychological theories, and adaptive versus maladaptive functions of dissociation as a coping mechanism. We're honored to be joined by an incredibly knowledgeable panel of speakers. Today, we have three highly respected experts in the field of trauma and dissociation. We'll introduce them briefly, and then they will each share a short opening statement. For the next couple of hours, we will delve into the neurobiology, clinical challenges, and profound human experience of dissociation. Please hold your questions until our audience Q&A, or submit them at any time in the Q&A chat, as we will be monitoring it and address as many as we can towards the end of the discussion.
Thank you, Sophia, so much for the introduction, and I'm going to head on to presenting really briefly the panelists that have joined us today. First, joining us from Germany is Professor Dr. Inga Schelinski. As a full professor and licensed psychological psychotherapist, her research at the University of Bundeswehr Munich is focused on the profound impact of childhood maltreatment on mental and physical health. She is a leading voice in understanding the neurobiology and treatment of dissociative symptoms, and today she's going to be challenging us to think critically about how we currently assess the neural correlates of dissociation. Next, we will welcome Dr. Judith K. Daniels. Dr. Daniels is a scientist, practitioner, and professor of clinical psychology at the University of Groningen in the Netherlands. Her expertise lies in post-traumatic stress disorder and dissociative disorders, with a primary research focus on the long-term consequences of childhood trauma, particularly maladaptive forms of emotion regulation. She also heads the research department at a specialized treatment facility for complex PTSD, bridging crucial gaps between research and clinical practice. And finally, we have Dr. Maria Magdalena Makarenko. Dr. Makarenko is a clinical psychologist, psychotherapist, and EMDR consultant with more than 20 years of practice specializing in psychological trauma therapy. Her research highlights the critical role of dissociation as a central pathway linking trauma to long-term outcomes, particularly the surprising connection between the childhood trauma and autoimmune diseases. And once again, thank you very much for being here, and we're really excited for the conversation ahead.
Thank you, Isa. So, to start us off, could each of you briefly share your background, what led you to become interested in the topic of dissociation, and perhaps a bit about your research in maybe a couple of minutes? So, Professor Schelinski, welcome. Let's start with you.
Thank you so much for the invitation and the ability to present here. So this brings me back quite some time. So I finished my PhD in 2013. And for me, in the end of my studies in psychology, I was very interested in trauma and how this affects individuals, because I noticed along the time that my family background was a little bit different, because my grandmother decided not to repeat trauma, like in violence. So I was growing up in a very open environment, but I noticed that the society is not talking about this topic too much. So I was very glad to get into the group of the university in Constance with my PhD parents, Thomas Albert and Maggie Schauer, that also have a major conceptual paper for dissociation, and also used the term shutdown dissociation, which is probably also a little bit known in this community. And so I was very happy to get this topic and to do research on trauma as well as dissociation. And we were focusing on like physiological responses. We used the trauma interview. We used also MEG to get some idea of the magnetic activity of the brain. And I was very much excited, but in the end of my PhD, I was still like puzzled by, it is the trauma exposure itself, or is it also really the dissociative symptoms that remain? And it was still too early to conclude, but maybe I will also learn something new today. Thank you.
Thank you. Now, Dr. Makarenko, so can you tell us what led you to become interested in the topic of dissociation and what you found in your research?
Thank you, Sophia, for the question and for the invitation, and also thank you, Isabella. Well, I was interested in trauma, in healing trauma and dissociation, because I had very traumatic background, and I wanted to become a psychologist to talk to. I said in my adolescence, I said I want to become a psychotherapist in order to talk with adolescents. So dissociation for me is so essential in the treatment of trauma, because sometimes it is very difficult to identify it, and that is why the treatment of dissociation and trauma could be very provoking. The dissociative experiences always complicate the clinical picture. So the assessment of the dissociation becomes essential for right intervention plan, therapeutic intervention plan. Yeah, for me, trauma is so spread in this society. So it is crucial to look at it, because also trauma has some very intriguing and important consequences into the psyche and also into the body, as we said earlier. Almost the majority of the lab that I was doing the research for had over 95-96% multiple exposure in trauma in their early life. So as I said earlier, this is striking, this is huge, and it should make ourselves specialists to work together in order to see the complete picture and to help, to really help the patient, because sometimes they are going to us, to therapy, but they also have medical issues, and sometimes they are going to to the medical staff having psychological symptoms, psychiatric symptoms. So we really need to go together and to understand the human being as being one, psychic and the body. And I'm emphasize that because for so many years the scientific world started to divide the human being, the medical things and the psychiatric things. No, we are one. So if we don't function at the medical level, something it means about our psyche, and vice versa. If we have, for example, depression or anxiety, something is happening into our body. So let's look together at these things. Thank you.
Thank you. And now, Dr. Daniels, you're here. You haven't missed anything. Could you please tell us a little bit about your background and what interested you about the topic of dissociation?
Yes, sure. And sorry about the late arrival. Somehow Zoom wouldn't accept any Dutch email anymore. So yeah. Background. Well, I, as a young student, was really interested in PTSD. That was still at the time when we thought that critical incident stress debriefing could actually be used to prevent PTSD. I got very excited about that. And then, as you all know, it turned out that we really can't. But that's why I got into this field. And then I actually took a year off from university and went to Chile and worked with survivors of the Pinochet regime. So people who had been tortured. And of course, they described all forms of dissociative symptoms. So I became very interested in what might be going on with them. And of course, at the time, we also had the OSA review had come out showing that peritraumatic dissociation is a big predictor of developing PTSD after a traumatic event. So I got very intrigued. After my PhD, I went to Canada and joined the lab of Ruth Lanius, who then published one of the influential models in 2010. And as most of you will know, we failed to replicate that model. So I have deviated from her understanding quite a bit in the last few years, but that's where I started using neuroimaging to look at processes associated with trauma, but also specifically with dissociation. And then I went on to head a study on depersonalization disorder. And I thought that was a unique opportunity because I thought dissociation is such a mixed bag. We mean so many different things when we use that term. And I thought it might be really good to look at only two sets of symptoms, or I actually think it's one set of symptoms. We call it depersonalization and derealization. But I think for most patients, we see that they go hand in hand. Sometimes people only have one form, but in my experience, that's rare. We ran a neuroimaging study on DPD. And having done that and having seen, I personally interviewed all the patients that we included. And it was really interesting to me because their etiology differed so widely. And looking at their structural brain imaging, my takeaway right now at the moment would be that they are actually a really different group. They show similar symptoms, but I think they're really not comparable to other patients with dissociative disorders. But as always in science, I would like to see a replication done by a different lab before I believe anything for sure, right? And now I'm still in the process of studying dissociation. I'm also heading the research center of a clinic that is highly specialized in complex PTSD and dissociative disorders. So I also see the practical side in my work a lot. And you asked whether we have an experience that could, like a metaphor we could use to describe dissociation. I think really there are so many different forms that I would find it hard. I think for lots of people looking through a plexiglass, being so disconnected from the world is the main thing they suffer from. But then, as you know, it ranges all the way up to feeling like there's different personalities living in one body. So I think exactly the spectrum makes it so very interesting and also so relevant to do some more research in this realm.
Thank you so much. Do any of you also have a different either metaphor or image or how you see dissociation?
I can maybe go ahead. I don't have a good metaphor, but I just would like to point to something because I think this is a very hard topic to discuss also with the scientific field. There's a lot of like tension. I attended the International Conference for Dissociation last year, and at the one hand, I felt very comfortable with the group because they were looking at trauma in a very wide and broad aspects that I don't see from some of my community, that I just still believing it's a one incident thing, that there's a one car accident which is relevant for the PTSD. And I have never seen this in my research. Maybe I looked at very different samples. I don't know where to find this population. So I felt very comfortable, but I noticed that this community also is very like, there's a lot of tension with the concepts. And you have to be very cautious about this. And then there's the overall society, which makes it very difficult because this is like the society, as what Maria Magdalena was mentioning here. I really want to point this out again, that there's a high trauma load, especially childhood maltreatment. In Germany, half of the population is affected. And there's something very human to silence about this experience, not to talk about this. And this reflects a lot on also how we do research. So it's a very broad metaphor maybe to bring here, and all the challenges which comes along with it to really look at dissociation, to look at the field and find a common ground, or to openly discuss this topic.
Thank you for the questions. It's another provocative. So you have so many provocative questions here today. Describing dissociation as a metaphor, or using a metaphor. Thinking about that, I have an image of a island. Like the mind would be a continent or an archipelago, and after the psychological flood, trauma, overwhelming stress, bridges become islands. You know, bridges become collapsed, and the islands appear. So for me, the island is the dissociation. And this is very interesting and very, very clear image for describing dissociation like that in the picture, with one picture. Yes.
Thank you.
Thank you. Very nice and interesting metaphors, everybody. Now, for the next couple of minutes, we have some short questions, which you can see on the screen, just to kind of set the scientific and clinical foundation of dissociation. And whoever feels like they want to pop up with an answer, feel free to do that. We are aiming to answer them all. And let's start firstly with what actually happens in the brain when someone dissociates.
So you want to start with the easiest question, right?
Yeah.
I wish we knew.
I think also I would agree that this is not a simple to answer question, because there have been a lot of research, but this is highly corrupted by all the challenges in the field. So we have conceptual unclarities. We have not a common agreement on like, what is a dissociation? So I was also focusing on derealization, depersonalization mainly, because this is something which is present quite a lot, but there is also a lot of other types of dissociation. And because I think it was in 23, we were on a conference, and I was the person that was moderating this panel And the people that presented there presented null results. Like they have not replicated what was found before, even so they had really good reasons for their hypothesis and they couldn't find anything. And we were kind of like, yeah, that's good that we report this, but it feels so inconclusive. And I think this is how this question still remains. And but I would like to add something, because out of this symposium, we started a discussion and also were really motivated to do something for the field of research. And Sarah Danbock, who was a very good, very motivated young researcher. She's now also a PhD and now at the university in Mannheim in Germany. And she was like, we need to write everything down what we have. So we published a methodological primer to summarize what kind of research designs we have, what kinds of questionnaires. We also briefly summarize the theories that are out there. We didn't combine it or converge it, but we just list everything. And also the challenges that we face, like study characteristics. Is it childhood maltreatment based? Is it more something else based, like torture or human trafficking? Or is it an intersectional exposure of all these different types that augment itself? So this is what I would encourage maybe also young researchers to look at it, because I think Sarah Danbock did a really great job doing it, even so it's not like that we find really solutions, but we put everything on the table, what we had and what we could find, to help the field, especially the neurobiology, to improve and maybe to consider a lot of things at the same time in your study.
All right, so hopefully in the future we will be able to respond to this more clearly. Then what about dissociation serving as a survival mechanism during trauma, and how it might have helped us through evolution? Does anybody have an?
I guess to answer that, we need to start from the defensive cascade proposed by Kozlowska, which describes a chain of automatic reflexive response to threat, mediated by the autonomic nervous system. It is an ethological and neurophysiological model which can be applicable to both humans and animals. And these responses are oriented toward immediate survival. So dissociation is part of the body's survival cascade. So when facing threat, if there is time and energy, the system mobilizes through fight or flight. When neither escape nor defense is possible, for example, during overwhelming or inescapable trauma, the nervous system shifts into states of immobility and detachment. And this shutdown protects the organism from unbearable pain and unbearable panic. So as the cascade shifts into freeze, tonic immobility, and finally collapse, autonomic activation changes, right? From sympathetic to parasympathetic in dorsal vagal dominance. So within this immobilization states, dissociation begins to appear. So it's important to remember that the autonomic responses to threat are instinctive. They are not choosing through conscious deliberation. And I'm saying that because many trauma survivors experience deep guilt and deep shame for having frozen, believing that they should have done more to protect themselves or to protect others by fighting or fleeing, and so on and so forth. And in such cases, understanding that freezing is an automatic neuropsychological or neurophysiological response often eases the process of acceptance, the process of integration in trauma recovery. So, yeah, this is my answer regarding dissociation as a survival mechanism to trauma. But my colleagues could continue or could add.
Yeah, I would like to complement something, because this is something I think for a lot of people it's very hard to imagine. Why is this a survival mechanism? Why does it enhance the chance of survival?
Yeah.
And I just would like to give you an example for this, or maybe also 2 examples. As we already heard from Maria Magdalena, it's mainly something when it's something very overwhelming, when there's no way out. We would always try to run away or hide whenever it's possible to get out of the situation. But if you're like tortured, if you are in a very close, dreadful situation, or also there's a lot of like a person mainly also doing interpersonal like violence, we see it, a person with more power or more people that having perpetrate the event, it's very good for survival to show dissociation, to shut down all these overwhelming experience, as what Maria Magdalena said, the pain and also the anxiety. And also if you're injured, for instance, it's good, because usually when we are injured, we take care of it. We would prioritize this, but during a survival situation, there's no time for this. We have to get out of the situation as fast as possible. But I think the main issue actually that dissociation helps us, because if we get threatened, we also can have anger motivate us to show, to defend ourselves in that situation. And it can be not a good idea to fight with a perpetrator more powerful, or with an animal that is more in power. And when we show dissociation, at the same time, it's good, because the person may think that we are already dead. When we faint, we collapse, the body is just laying there. And this actually helps a lot of people to survive it. Even so you are injured, you will survive more likely the event than fighting with the perpetrator. There's also the idea of, someone told me that in Australia there are snakes, and men like to fight, and they are more likely to die from fighting with the snakes. Women tend to freeze and show tonic immobility, and they are more likely to survive an encounter with a snake. And I think this is a great picture to see that this is very useful to show it. And also from the animal, we know when they are wounded, because also a lot of dissociation comes out of when we are wounded, when we have open injuries. They fall when they collapse on the site of the injury, and this most likely block the wound from like losing too much of the blood in this situation where we have no time to take care of our wounds and do something about it. So just to give you a little bit of an idea how useful it can be in a situation. Thanks.
So I agree with everything that has been said, especially the shame that often results for patients out of their own dissociative reactions during a traumatic event. Where I disagree with the way you've portrayed it so far is a little bit that I think it is much more of a continuum. I think if we're thinking about being attacked by a lion and the lion is already on you, then I totally agree this is likely what will happen, that you go into full shutdown, there's no movement anymore. Your eyes are likely fixated, right? We have very good qualitative reports from rape victims, what kind of state they went into during the rape when they didn't see any chance for escape anymore. So there's no disagreement there, but I do think it's much more of a continuum, and I think it starts with much subtler forms of dissociation that are also very helpful for survival. And as we have a little bit of time, maybe I'll just tell you my experience with that. Because I once ran into a bear in a country where I didn't even know that there were bears. And we came around a bend, so it was very sudden that we looked up and saw that big bear right in front of us. And what I remember is I went into a state that felt totally rational and logical to me at the time. It was clear to me I have to get away from the bear, and it was clear to me you're not allowed to run. So I managed to control my impulse to run. But in my head, what happened was that I thought the main danger are the chocolate cookies in my backpack. So I went around the bend, and then I stopped and ate all the chocolate cookies. And in hindsight, I don't think that is quite so rational as it felt during that time. And I think this feeling like I'm all rational thought, that's what we often see in people that have derealization, right? That it feels like I'm only here, I don't feel any emotions, I'm not super stressed, I'm totally in control of the situation. But what you actually do is maybe not what you would normally do. And I would say that's already the spectrum of how dissociation can be a survival mechanism. So I would say this defense cascade model surely is helpful for very extreme situations. I think we see the survival contribution on a much lower scale too.
Yes, thank you so much for complimenting it. I think this, at least the Schauer and Elbert model does not state that dissociation is only present in the later stages, but also in the earlier ones. I mean, from the beginning on, you are usually having this dissociation from not being very, you literally feel the pain also in like when you're fighting or when you're on an active response side, or also the dissociation of the memory parts, contextual, and the hot memory stuff, which is mainly supported by the amygdala. This dissociation happens way earlier because it's so important to get out of the situation and survive this. Then think about where you are and about all the things that may not be necessary at this moment.
And
Thank
also,
you so much for your, I'm sorry.
I guess it is important to say that what is the history of the traumatic history of the person matters when we talk about dissociation. So if you have a tremendous history of trauma, chronic trauma, you may enter dissociation more rapidly than one that has protective family or protective mechanisms before the traumatic experience. So I guess this is important also.
Yes, I very much agree. And I think that is actually what complicates the study of dissociation so much, because often the way we've approached it is a little bit naive in the sense that we expect the reaction to stay the same over years. But if human beings go through multiple traumatic events or very much foreseeable, regularly happening traumatic events, there is probably all kinds of learning going on, and some of that learning might shift how one enters a dissociative state and what that feels like. But also, once people have developed the tendency to dissociate, maybe even after one very severe traumatic event, just by the time that we often see them, they have been dissociating for so long that I don't think that there's a good reflection of what happened during the first time that they dissociated. So I'm a bit skeptical about using too many factual descriptors here. So when you say this is how it is, I don't think we have any data that backs us up on what actually happens during the first time when people dissociate in a traumatic event. And everything that we measure afterwards is definitely, I assume, impacted by how long people have been using this mechanism. And that might also explain a little bit why our data doesn't line up so well.
Yeah, I think this is something very, very important, because I have learned so much from people that are affected by dissociations, and I've seen a lot of variations. For instance, one client, she had a very good family background. She was from Iran, and she was very active politically in her adulthood, and she got tortured very severely along a time. And she was highly dissociative when I met her. And I've seen very severe reaction. She was vomiting all the time when we had sessions. But I noticed, working with like anti-dissociative skills during the treatment, it was very easy to treat. It was easy to understand everything, and it was not as persistent as what I know when I work with survivors of childhood maltreatment that also have other traumatic experience on top of childhood maltreatment, that was way more likely to persist, was more challenging in clinical practice to address. But I also want to share one other story. I had a client, she was dissociated in all kinds of events that we were doing in our narrative exposure treatment, because we are looking at all the events building up along the life when we do narrative exposure therapy. And she was always dissociating in every single sessions. We had to work a lot with anti-dissociative skills, and it worked very well. And then there was one incident which was different, and she showed completely different reactions. So it was an event which was in her mid-20s. We had already addressed all the childhood trauma events, and we learned so much about her. She was always dissociating, and people would say she would also dissociate in all other events. But there was an accident event, and she was the one that was acting the most like she was active. She was doing something. She was slightly dissociating, but she was functional in this event back then, and also during the session when she was narrating and telling and sharing her experience with us. And this does not fit any research and anything, but I think this is a lot of challenge, so that I believe we should not just look at the phenomenon coming out, because I also know when you hide yourself, you're less likely to dissociate. But when you go out and have a life and meet with friends, you're more likely to dissociate as well when you're more stressed. So there's a lot of things going on that we have to consider, and this makes it complex and complicated. But I'm always very happy to learn new from the people that report their way of how they deal with it and how they get along with it, and also to be flexible about this. And maybe to add one thing, which I think is something which we still, because we like to agree on, oh, this is malfunctional, it's dissociation in daily life. And I think I really would recommend with every client to also look about what is good about it, because a lot of clients actually experience a relief in such a manner that they feel really euphoric sometimes when the dissociation kicks in. They're really like getting out of an overwhelming situation. There's a huge relief, physiologically, emotionally. And a lot of people really say this is something like, I feel like as if I'm on drugs. I feel like in a very good state. Even so, in a long run, they know this will take them 3 or 4 hours to get back to a normal life. But they're in the first and short term, it's highly rewarding. And this is something I think we have neglected a lot in clinical practice.
Thank you all very much for your insights and answers, and for sharing your experiences. And I think we already did a great job at setting both the scientific and clinical foundation of dissociation, which makes us move on to the next chapter of our discussion panel, where we'd like to engage with the audience quickly. Everybody in the audience, could you just drop down in the comment section what comes to mind when you hear the word dissociation? or have any of you, including the speakers, which we've already talked to, ever experienced Kalman's form of it, like intense daydreaming or derealization? And we're gonna maybe choose one or a couple of them to discuss about them, if anybody would like to share.
Well, maybe while we're waiting for participants to write in the chat, I'm intrigued by your question here. Daydreaming or derealization is what you put on your slide, right? And I think this question is like, is daydreaming, is absorption even a form of dissociation? It is included in some of the questionnaires, so some people have assumed it to be a form of dissociation. It's not included in the gold standard assessment, like the SCID that we use for diagnosing disorders that have to do with dissociation. And it seems to be so common in lots of healthy people that I'm wondering whether that is indeed a super light form of dissociation that is useful to include, or whether really that is leading us off track because it is such a common experience, even intense daydreaming in some people, that then don't show any other dissociative symptoms. So you're absolutely right to ask this question, because it is very much included in the instrument that is most widely used, the dissociative experiences scale. In my personal opinion at this moment, maybe I change my mind in 2 years, but at the moment I would say it shouldn't be there. I don't think it should, it's helpful to include that in the discussion, but who knows? I'm curious what kind of experiences we're going to hear about.
Yeah, maybe I can add something, because I feel I would agree also. I feel it's a really broad spectrum if we go from daydreaming to derealization. But I just asked maybe the question, could this be the correlate of our biological background, that we all can dissociate in like very overwhelming, stressful situation? And hopefully we do, because it will enhance our survival. That daydreaming could be one part where there's similarities of our biological background, that we all can dissociate in a situation. Maybe, but we don't know. But I would also agree, for now it makes it very, very broad, and I'm not sure if it helps the field to be as broad in the definition.
Thank you. We have one person who would like to share her experience, Raluca. She said, like being in the sunken place in the film Get Out, or experiencing the world through a foggy window where the fog is your internal experience. Thank you, Raluca, for your answer. Unless anybody wants to comment on that, we can move on to the next chapter, I believe.
So now we would like to take a quick deep dive into the specific findings of your research. So to Dr. Makarenko, you propose that dissociation mediates the relationship between childhood trauma and autoimmune disease. Could you elaborate a little bit on the theoretical mechanism that links these?
As I said a bit earlier in the presentation, of course, we need to still have a research on that to have, you know, in the scientific world, there are no conclusive evidence. There are also only hypotheses and proposal. But the way we we explained the link. So we wanted to see if dissociation, alexithymia, and anger could mediate, could be a link between early traumatic history and autoimmune diseases. So what the research is saying so far is that the dissociation and alexithymia could contribute with the altered autonomic, endocrine, and immune activity. So it's like when you have dissociation or alexithymia, your tissue, it's like your tissue is more damaged. It's like this condition of being dissociated is characterized by pronounced inflammatory state. So alexithymic or dissociative individuals have, according so far to the studies, have a weakened, or the studies shows us a correlation between these mechanisms and the weakened anti-inflammatory buffer capacity that is that can increase vulnerability to the inflammatory process. So of course, evidence is suggestive, not causal. Of course, we have plenty of limitation in our studies, as all these studies have. But dissociation and alexithymia may be plausible pathways warranting, of course, longitudinal testing. So in conclusion, studies are linking these mechanisms to the inflammatory process somehow. So we really need to go deeper into that and to see what is really happening. Of course, longitudinal research it's hard to do, but we really need to find a way to search and also to bring into the research some other biological mechanisms or something else to measure and to see what is the entire picture of it. How, from the psychological perspective and from this psychological mechanism to raise the inflammation. So what is happening here? And this we need a link, another link.
Thank you. In your research, you also talk about more subtle, indirect expressions of dissociation that fragment bodily awareness. And I would like to know if, so in patients with conditions like Hashimoto's thyroiditis, what are the most common clinical indicators or signs that this subtle body level dissociation is present? And how does recognize it change the therapeutic approach?
Sometimes the internal aggression is very subtle. When the clients lack the empathy towards themselves, they lack the compassion, so they don't do good things for them. This is a subtle mechanism that is not so obvious, as if plan dissociation it is, So you really need to see how the person, what is the relation of the patient towards themselves. If you treat yourself good or if you treat yourself bad, this could be a sign of dissociation. You know, it's like you internalize your first aggressors and you start becoming them. And you start to say to yourself things like, I am disgusting, I am fat, I am something negative. Just like your mother or your father said that to you. So you, during your development, you start to internalize what you received. If you received something good, you internalize that. If not, you will internalize the aggressor. So in therapy, we really need to decrease this self-aggression. And self-aggression could be very plain, could be like in borderline, like self-harm, which is very visible, but also could be very subtle, as you said, when we talk about failures in life, failures in academic world, failures in work, failures in relationships. Is like you don't allow yourself to be successful. And my question is, when I hear that, who didn't allow you to be successful? Who didn't want you to be alive in the first place? You know, because we start to bring in our lives this negative perspective, and this is very clinical, and this is very hard to also to research on that, to research on how do I treat badly to myself. This is very subtle, and of course, when I hear that, my mind is at a traumatic history of relationships. It is very different. The mechanisms are very different. If we talk about impersonal trauma, and if we talk about interpersonal trauma, and the results are very different. You know, the PTSD after an impersonal trauma could drop very quickly in 3 months. Studies are showing that. But if we talk about interpersonal trauma, chronic trauma, the symptoms are rising. So it is very important. When we talk about chronic illness like Hashimoto, I don't think about an impersonal trauma. I think about interpersonal and chronic traumatization. Yeah.
Thank you. And we have another question. So you presented findings that both identity-oriented psychotrauma therapy and eye movement desensitization and reprocessing significantly reduce dissociation in patients with Hashimoto's.
Yeah.
Based on your clinical experience, do you see a difference in how these two modalities achieve this reduction? What do they address differently?
In IOPT, we work with groups, especially. So it's very interesting because the patient may have an intention. What do you work today? Like the objective of the session. So we is another, you know, my study about IOPT and Hashimoto is the first randomized controlled trial ever. So we are so at the very beginning with this method. Clinically, we see results, but it's so important and so nice and profound method that really deserves a scientific light on it, you know. So it's like working with parts. If it's more familiar, working with parts, but instead of doing that work internally, you are doing that externally, using or helping with another people from the group that are starting to resonate with the words, are starting to resonate with emotions. And this phenomenon of resonance, it has been studied, and we saw from this research that the resonance is like neural connectivity. You know, if you stay with a person that has neural system and this is dysregulated, you will feel that. You will feel the dysregulation. And if I go to the therapy room, when you work with one people in the room, you know, in private sessions, you will feel what is dissociated in the psyche of your patient. So it's the same phenomena, you know. So the person who is working an intention is having a discussion with the parts. The person could recognize the traumatic experience or could recognize the mechanisms that the parts are open and are saying about. And they could start to integrate that information that what splitted, information that what dissociated. So there are, you know, I had a client who said, who are saying many times, my intention, my constellation was successful. And I always said, every intention is successful, even though you have integration or not, because you can start to see what was unseen earlier, you know. You can start to see the mechanisms. The mechanisms are masking the trauma. If you can recognize the mechanism, you can go even further to feel what is happening into the trauma field, into the traumatic parts. So we do integration like this in IIPT, and in EMDR, we work with traumatic memories. And again, you can solve a traumatic memory in one session, or you can solve it in many sessions, because it depends on the mechanisms. Again, you have a nice and safe background, and even though the trauma event was severe, even though you can process quicker than if you have another history of trauma, a chronic trauma. If you have a chronic history of trauma, your mechanisms become chronic. So that's why you can have blockages in the process. And that is why one session could be final. You can solve something, and there are memories that you can work several sessions, you know, because there are layers and layers and layers. So you have to you have to be very gentle with the mechanisms, not to activate anymore them. No. Mm.
Thank you so much for your answers.
And now moving on to our next panelist, Professor Inga Shalinski. I'd like to start by asking you a question regarding your study on female refugees, in which you showed that family violence has a stronger impact on depression, anxiety, and somatization than war-related trauma. How do you see dissociation potentially mediating or moderating this relationship between family violence and these psychiatric symptoms?
Thank you so much for your question. This was a study, I think, published in 23 from James Moran you're talking about, where we were looking at various types of traumatic experiences as well as cumulative trauma. And we had symptoms of anxiety, depression, and somatization in female refugees. And it was a very large sample that we had. And actually, we found out when we were looking what is the best explanation for the symptoms, there was a strong impact of interpersonal violence that was present there. Unfortunately, we have no idea of dissociation because this was not part of the study, but it could be, because I know that when you face interpersonal violence, that this is more likely to be involved with dissociative, like paratraumatically involved with dissociation, so also more likely to be part of a more complex picture of what people have experienced. And I was very glad to do this research with this group, because I know that many fields look at these different samples and always believe, oh, we have a refugee, there's only war that has been happening to them. And war always comes along with a lot of packages. There's a package of childhood maltreatment. There's a package of intergenerational trauma, usually in conflict and post-conflict areas. And there's a lot of other things that are potentially relevant, which I really would highly recommend in clinical practice to really look at the full picture as best as you can with the clients, and not just focus on one specific aspect, because it's maybe a difference also what we agreed on earlier. Dissociation pathology may not be the best indicator to start from there when you have variations in your sample. You have one that has dissociations out of chronic childhood maltreatment. There's another person that have just recently been in situations which has been very overwhelming, such as torture for a limited time in their lives, but based on a very good childhood and caring parents. But when we just look at the phenomenon of dissociation, it may not help us, as we know. And I think it's always a good start to disentangle the experience, and also to accept that experiences can be very much also intersecting, like creating interaction upon each other. I think Gomez, she did some study about the cultural betrayal, and she's like, when you have a within group, like the Black community in the USA, for instance, they have increased childhood maltreatment, because this is a highly stigmatized group, and there's a lot of pressure on this group, a lot of more poverty, which creates a package that is quite heavy. And when there is something happening within this loaded within group, and the way out of it would be to seek treatment, this is a kind of like betrayal to the culture, and this augments PTSD, for instance. And that's why I'm really much in favor to look at the experience of people rather than just focusing on the symptoms. They are relevant for clinical practice, but I know that this can be misleading when you just look at the symptoms, because you have to understand the symptoms considering also the etiological background of it. This is what I would take out of the study, even so, like, I cannot answer the question with the dissociation if this is a mediator, but this could be. But we have not looked at it in this study.
Okay, thank you very much. Moving on to the next question. You outlined that aversive triggers like script-driven imagery, are unspecific, whereas perceptual or VR-based inductions may be more selective. For trauma-exposed participants, which experimental paradigms best isolate causal effects of dissociation on downstream outcomes without co-manipulating stress or effect? And what manipulation checks and ethical stoppings rules do you consider essential?
The question towards me, correct? It was a quite big question. So I have to put it maybe into some parts. This is maybe most likely from the methodological primer, where we have looked at very different study protocols and research designs, and also signs when we provoke dissociations. With triggers, for instance. One of the most commonly used is to confront clients with like their own experiences, having like a script that is read to them, or it's like an audio which is presented to them. And I was actually in charge also to work it out, to look at what is necessary in the laboratory, because this is a good question also from ethics committee, most likely. Some also completely say this is impossible to do research. I also had been confronted with different universities being very critical about this, which I think is also very difficult, because it creates a kind of agreement on silencing. We are not looking at them, and I think we have to look at this phenomenon. We should do more research about this. That's why we have stated a little bit of the methods that we used in clinical practice. Even so, I have to say we have very little research about how good are we and when do we use which method. It's more based on clinical expertise than in being informed by research, how we select what type of like technique that we use to regulate dissociations that may also be happening in laboratory, like when we do research with the clients. And what was your last part of the question? Do you want me to give also some examples of what you can do, or
the ethical stopping rules that you would consider essential?
Yeah. I think it's always like when we want to evoke dissociations in the laboratory, it should not exceed like daily life levels of the person that they experience, for instance. But it may happen. And then I think we are in responsibility to take care of the situation. For instance, if there's a person suffering from derealization, sometimes like it's unable to know how to get from one room to the other room. They may be also not well aware of their bodies, but in the laboratory doing provocative sessions, they would collapse and faint for a moment. This is like they should immediately stop this session with this client and take care of the situation to get this person back into the room, being prepared for this. Maybe also have a nurse or a doctor around. Usually those clients that show these signs, they have been very well examined from the medical part. They have a lot of protocols about this, so we should stay calm, but we have to stop this here and also maybe reconsider like what talk about maybe also later on in another session with this person again, how this happened, and also try to learn about this. And if this is happening more often, you should not do this research design, this is for sure, but you have to train this the study team quite a lot, that they are comfortable with dealing with the situations, because this can be very challenging for the team, because you can easily feel stressed when you see another person, for instance, fainting in front of your eyes. You feel stressed about this, but at the same time, we know the best is to stay calm, because if you feel stressed, this person that has fainted will be encouraged to faint maybe more and to remain in this situation, because it implies for them there's stress going on. I should maybe protect myself from that. So we should be calm, support them to come back, and use all the techniques that has been described so far, and also use techniques that the clients maybe have found for themselves to to get out of dissociations.
Thank you very much. Very interesting topic and very important for the research that we're gonna have to do in the future. One last question for you, Professor Inga. As the field struggles with heterogeneity and inconsistent biomarkers, if you could mandate 2 moderators that every dissociation study must measure or report to enable cross-study synthesis, what would they be?
I think one moderator may be sex. So there's a difference. I think women tend to be more likely to dissociate, and also children. So the age as well as gender could be something that would act as a moderator. Even so, I've seen like single cases where I would say like, I feel like men are even more affected, but it's always hard if you look at the backgrounds to really have the same etiology of experience. And even so, we know when we have the same experiences can be very different from both perspective. When 2 people would be exposed to a car accident, it could be very different. And it's also informed by our previous experiences. So that's why it's quite complex. But I think one main mechanism which is mainly more suitable, or maybe more true or more applicable for clients with childhood neglect, because this is the most, like in our studies, we could find that neglect is actually the most common risk factor when we look at psychiatric patients. And this is most likely related to affect regulation difficulties, because they have not had the caregiver like providing them, guiding them in affect regulation, other than maybe dissociate as a survival tool in their childhood. And in like psychiatric patients, we see it often in combination, affect regulation difficulties, neglect experience, and dissociations. So I think this could also be maybe more a mediator, maybe, than a moderator, I would say. Thank you.
Thank you so much for your answers. And now we have some questions for Dr. Daniels. In your Enigma meta-analysis, you found smaller total and subregional cerebellar volumes in PTSD. So because cerebellar structure and function seem modifiable, which cerebellar targets and outcome readouts would you prioritize in a neuromodulation or neurofeedback trial aimed at specifically reducing dissociative symptoms?
I don't think we have the background knowledge to answer that question, I'm afraid. It's an interesting thought, but I mean, what we identified was in PTSD patients, and it's all kinds of PTSD patients pooled together. So we have a lot of veterans. We have some people with severe, chronic, very much predictable childhood trauma. Predictable, I mean, it happened at a predictable, right? Every predictable time point every Wednesday night or something. So yes, we do find these changes, which is encouraging for understanding PTSD. I'm not sure that it is very helpful for understanding dissociation specifically, but it's such a broad background. And yeah, correctly asking, well, shouldn't we then use neuromodulation techniques? That is definitely something I think our field should explore. But then you indeed need a really good background to choose your target region. And I'm afraid at the moment, I wouldn't have any confidence that we know how to do that. Sorry for the frustrating answer. That's unfortunately the typical answer in this field.
I think that's something that's very, I see a lot in the neuroscience area, that I think researchers are very able to identify the gaps and acknowledge them in a very humble way, that we don't know everything. So that's also very important to acknowledge that we still have a lot of work to do. So you found that a notable minority of individuals exposed to extreme and multiple forms of childhood maltreatment did not develop dissociative symptoms. How would you explain these resilient cases? Could we investigate something about them, their neurobiology, or a protective psychological factor? And could we use this information for further treatment?
If we can use it for further treatment, I don't know, because those are the people that are highly resilient. But I do think this is maybe a gap where we still have an opportunity to learn something that we haven't looked at very much yet. So we have known about how crazy resilient we as a species are. Like humans are just very resilient. We also know a little bit about what keeps people resilient in terms of underlying brain processes, although I don't think we're very sure on these either, but we have a little bit of background knowledge. But this specific group that actually has really extreme exposure and never developed dissociative processing, that's a very interesting one. And indeed, that is something that we should study, which implies you need a really big sample to find them. It's not easily studied, especially if then you want to do some neurobiological research. But I think it might be worth doing, because they really might open a window into how how you survive such severe, repeated, predictable traumatizations without relying on dissociation. So I think it might be very worthwhile, but also tricky to do.
What are some of those preliminary findings that you say about the neurobiology? Could we hear a little bit about those?
You mean about dissociation specifically now?
Yeah, so you said that there are a little bit of background, and we would just like to know a little bit about that, even if it's not fully supported.
Yeah, but that's then not the resilient subjects. I'm now then talking about the subjects that are actually showing dissociative symptoms. And I think it helps to zoom out and think about what is our methodological approach? How can we even open a window into this, right? And what we have done in most studies was a simple correlational approach that you measure self-report and then you correlate it with something that you can measure, like brain activation or physiological responses. And I think that is so tricky, because then you're relying on a really useful self-report, and I have a lot of questions about how good those are that we're currently using, and that the alignment between the self-reports that we use is so low, even when they claim to measure very similar constructs, that I think has limited us in the past. So in one study, we actually, in the study that my former PhD student Joachim Mertens published recently in 2022, 2023, our original idea was to actually look at the PTSD subtype with dissociative disorders and compare to patients without dissociative symptoms. I think we used, if I remember correctly, 6 dissociation measures, and they aligned so little, even the ones that conceptually should have been really close, that we had to abandon this approach. So that's why I'm currently quite hesitant how well we're equipped to look at dissociation using all these different measures. The alternative, of course, would be to look at variance in the dissociative experience itself. And then again, we tried to facilitate that also in one of the articles by Joachim Mertens, where we had a pharmacological challenge paradigm. So we actually gave patients a pharmacological agent that was supposed to increase the amygdala sensitivity. And in this case, that didn't work, because the drug apparently didn't work. But that's, of course, one approach that one can use to try to increase or decrease the symptoms in a controlled way, to then be able to see what changes on the other end, right, on the level of brain activation or physiology, if that's what you're measuring. However, having said that, then the question is also, is that the same as naturally occurring dissociation? So currently you will see a lot of publications coming out about, for example, dissociative experience in drug trials. So ketamine, for example, or psilocybin. I think there have been quite a few publications recently that then look at the dissociative symptoms. And that is certainly instructive, because it is controlled in the sense by the substance. How well that aligns with the naturally occurring dissociation is still then an open question. And maybe to make it even more frustrating, we've tried to actually measure the naturally occurring dissociation in a patient sample, which is really tricky to do. But my PhD student, Sarah Beutler, who's located in Jena at the moment, she was fortunate enough to gather data in an inpatient treatment center where we could ask patients to wear a heart rate monitor and gave them a mobile phone with an app. And every time they actually noticed that they had just dissociated, they would press the app and then would stand still or sit still, depending on which position they were in before, for a minute, and then report on the type of symptoms they had. And then we tried to go back in the timeline and see how heart rate had actually, or heart rate variability had actually shifted from before their subjective experience of going into a more dissociative state to during the dissociative state. And the data is inconclusive in two ways. The patterns that we see vary drastically from going down 20 beats per minute to going up 30 beats per minute, which is a huge range. But we even see that it's not always the same pattern within one single person. So I think those are the two approaches that hold the most promise at the moment. And that's certainly where I would like to go if I could develop 5 more studies right now. I think that's definitely what I would like to do. Another option, of course, is pre-post psychotherapy. If you can really trigger dissociation well, like in a PTSD sample, for example, and see how that changes over treatment. But I think that approach right now seems more promising than using self-report questionnaires and a purely coordinational approach, which we've done many times, but I'm doubting that whether that's the best way to go.
Thank you. All of this research sounds so incredible and interesting. So one last question. Given that nearly all dissociative identity disorder patients were in the extreme dissociation cluster, while PTSD and borderline personality disorder cases were more distributed, how might these severity-based clusters guide assessment and treatment planning?
Well, the slightly provocative answer to this is, I think for those patients, you actually don't need that kind of assessment, because those patients will report all kinds of symptoms across the board. They are rather easy to identify. And treatment will, of course, then be targeting in kind of a personalized approach the main symptoms that are causing distress at that time. So in that sense, if you're asking about the assessment, I think you don't need the assessment for that. I think you need a good assessment for coming to a diagnostic categorization, but then you wouldn't want to rely on a self-report, but rather use a structured clinical interview, because then you can use your clinical experience to actually influence on how certain answers are weighted. And that's something we can't do in self-reports. And I think that is where self-reports probably go wrong in the specific patient population. And when you ask about treatment, I think for treatment, the guiding principles are always like what causes danger, right? That's the first thing you want to talk about. The second principle is what is most open to change. So if you can get an early win by addressing something that seems easier to change than other symptoms, that's often advisable. And then, of course, going with what is the main priority of the client based on what causes the most functional impairment and distress. So I think those 3 rules of thumb still hold strong also for DID patients.
Thank you so much for all of your answers. So we're going to move on to a last section before the Q&A, just to quickly remind everyone watching from home to pop your questions in the Q&A. And so for the next section, let's talk a little bit about the applied perspectives and ethical considerations.
Yes, so we will move now into a very important part of this discussion, and I will guide you through a few quick questions. Let's start with, how does dissociation differ from altered states of consciousness, such as being emotionally numb or depersonalization, which we've already been through kind of?
I would say, and again, this isn't true for all patients, But I would say in the majority, the main difference might be how much control you have over the state. So often people ask, how is it different from a state I can go in when I meditate? And people that meditate excessively can enter a state that is quite unresponsive to external and internal stimuli. However, that is highly controlled. I would guess that on a neurological level, that's a very much central executive network function to control your attention to this degree. And I think for most patients, what we see is that they don't have that much influence over the dissociative symptoms, at least not at first. It's not true for everybody. Some people can also quite voluntarily switch them on, but then they're often also not so good at switching them off.
Unless anybody wants to compliment or give another answer, we can move to our next questions, which might be, what are some common challenges when approaching dissociation in therapy from your experiences as therapists? Or
maybe I can answer this question a bit. I think one challenge, as I have mentioned it a little bit, is that I think also from our background that we are maybe as humans tend to not address difficult topics. And I think this augments when we are faced with dissociations, also as practitioners, that can make us easily feel stressed. And I think this is a very complex situation. And I think what helps clinicians to work with dissociation is evolutionary understanding and the adaptive understanding of dissociations, because this gives us a normalization. There's nothing wrong with that person, just the extreme environments was difficult and challenging for the person. But the here and now, showing these types of responses again and again, is affecting their life and their goals and creating more symptoms. And that's, I think, is something that help us to overcome these challenges. But I know from my own community that still there is a lot of people, they don't believe in it. They're like just very strict about it. But I would more see it as also because it's so uncomfortable to look at these things that are present in our society, like all this high rates of childhood maltreatment, how people are like talking about sexual abuse, it's a taboo, and it's very difficult. There's a lot of silencing around these topics, and this also affects us as therapists. And I think this is what we need to learn to reflect, how this has influence on the way we also address this. Because I still know from trainings that there's a lot of like silencing also from our professional community, that are not like believing it. I have not been there. And when it gets really fragmented, because this is what we see in dissociation, a lot of people say like, I tried trauma-focused work, but it was not possible with this client. And I feel like I have not had this type of experience, because there's a lot of maybe different way also to approach this. And there's always ways how we can carry this kind of sessions as a psychotherapist. So it's a lot of also personal reflections. What can we contain of all of this? How can we stand very close to this person, supporting this process, and make them help to get a full picture of their experience and help them understanding their background and contextualized their experience.
I would like to add something, because Inga opened a very interesting topic. For me, one of the greatest clinical challenges in treating dissociation is not especially the client's fragmentation, but it is the therapist's internal response to it. So what we called countertransference, because dissociative clients often evoke intense and shifting emotional reactions. Frustration, helplessness, numbness, that sometimes mirrors their own dissociation. So mirrors the dissociation of the therapist, meaning. So because dissociation involves both withdrawal and sudden re-engagement, therapists can also oscillate between feeling deeply connected to the client and deeply disconnected to the client. So sometimes you really feel that you don't want to work with a client. You want to abandon the client. So if that is happening, you really need to think what is happening to you. One way you can think about what is personal in your history regarding this type of mechanism, this type of rejection, or this type of abandonment. But in another way, you should understand your reaction by being a part of the client's scene, traumatic scene. So the danger in working with trauma and dissociation is either to be involved, trying to save or to rescue the client from their pain and from their terror, or to withdraw, and so to activate your defense mechanism when you are faced to their emptiness or to their silence. So to be effective in the therapy room, we have to have a metacognitive, if you want, a metacognitive awareness of our own states, of our own ability to self-regulate, physiological, and of course to access supervision if you need that. And another major challenge in working with that is that many therapists simply don't recognize dissociation when it is in the room, And that is because most general psychotherapeutic trainings, whether it's CBT or experiential or psychodynamic, give little or no attention to dissociation unless they are explicitly trauma-focused. Yet, dissociation is not rare. So I said earlier about that. It appears across many diagnosis categories in anxiety, in depression, personality disorder, and so on and so forth, even in somatic and medical context. So the difficulty is that dissociation often looks like avoidance, inattention, resistance, or even compliance. So it is another way around. If you are too compliant, there is another mechanism, another dissociative mechanism. So it's easily misinterpreted. So without specific training, therapists can push their clients to process trauma, to process when their nervous system is actually in a state of freezing or collapse. So for me, recognizing dissociation, how it looks, how it feels, and how to intervene gently should be a basic competency for every therapist, regardless of theoretical orientation. Thank you.
Thank you very much for your elaborated answers. Those were really amazing to hear. And now moving on to the last question of this chapter. What about the methods with which we could reconstruct traumatic memories without triggering subsequent victimization? If anybody would like to answer that.
Can you clarify your question? Like, do you mean that the treatment is seen as destabilizing, or do you mean an additional external traumatic event happening to the person?
So I think what we mean with this question is that when in therapy and revisiting previous traumatic experiences, that these reconstruction of the dissociation and the traumatic experience does not re-victimize the patient in the sense of going through it. How do you tackle this reconstruction without them, I guess, dissociating or falling back into revisiting hurtful memories, if that makes sense?
Mm-hmm.
It's a quite challenging question, and I think it's maybe hard to balance out, because my experience is even so it's painful to go back and revisit the experience of a person. It's very hard to find a way out of like the dissociation without looking at the origins of the dissociations. So this always gets along with each other, but for sure we try to balance with our therapeutical relationship to be very close to the person, to hold and understand what happened to them, to hold them in the moment, not to overwhelm them with a lot of things, to have all these anti-dissociative skills that we are using to make it possible to stay active and to have a different type of experience along with the trauma-focused work, helps them to get over it. But I think we cannot take the responsibility for fully like stop once they set the door in our room, that they cannot just expect that the dissociation will appear from one day to another. And also like I had a client, she had very irregular behaviors that she acted out and get into other like very difficult situations, and that she later would also frame as a sexual assault that happened to her. And I think having like this kind of a high threshold to be able to access therapy, to say like you have to be free out of like any kind of drug use, any kind of like victimization that is ongoing, is a really big challenge. Because also having all the ability not to dissociate, it's not reachable for the people because it's so connected to the trauma. So we have to enable trauma-focused work and make this possible. And sometimes it may happen that there will be symptoms coming out. And also sometimes it happened to me also many, many times that symptoms, like we couldn't manage the dissociation as well as in other sessions. And it took us longer to get out of the states, but I think it's very still helpful to stay with the client, learn from it, and improve also the sessions from there. So that's why I would like not be open yourself as a therapist to do treatments, because this is something which is the most effective thing that we can offer our clients and help them to find healing from their past experiences, but not wait for a moment where they are super safe and have no symptoms of dissociation and have no tendency to victimize themselves. Because I think this is a state they cannot reach with this help, because they have a high building block of experiences, and we cannot wait for this. And this is actually more, maybe I would say it a bit provocative, an excuse not to treat and not being faced with all this unpleasant experience that happens in our societies, or what kind of things humans experience in the world. And this is something that we as a therapist should learn how to cope with, this shattered world war that we also get from the therapies, But this is something which should not be on the shoulders of the clients. It should be something that is on our side, that we are trained for. What Maria Magdalena also was saying, that we should include this more into our trainings, because it's so commonly widespread, but we do not really get prepared unless we do maybe a training or we get interested in this.
I'd like to add something regarding what is the most effective way, to treat trauma and dissociation, lowering the risks, is through the phase-oriented approach, which has become the gold standard in trauma therapy. The first phase is the stabilization in safety. So in that phase, we teach grounding, we teach emotional regulation, and body-based skills to expand the client's windows of tolerance, for them to tolerate more or more diverse emotions. So this phase may take months or even years in complex trauma. And then if you succeed to do this first phase, you can go to the second phase, which is trauma processing, and you will do it gradually. This gradual exposure without flooding or without re-traumatization. So we really need to find ways to work with clients in order to recognize them very safely in the present moment, with their body, with their emotions. And as I said, pendulation and titration, those are another important concepts in treating trauma and dissociation. So from alternating between small doses of traumatic material and moments of safety, to slowly rebuild tolerance for presence. And over time, of course, you can work with parts, you can work with whatever you was trained to work with. It doesn't matter the way, but the important thing is how you do the stabilization. And working with dissociation is in this part of phase one.
Maybe I have to add something here, because I would slightly disagree with a few things that have been said. I would not say that this is a gold standard, because we would also do a kind of phase-based treatment, but the phase is highly blended in with trauma-focused work right from the beginning, because I'm very much afraid that we are prolonging the suffering from people if we wait and stabilize forever. This is a highly term. And I'm very glad that in the guidelines in Germany now we've agreed on that we are not using the word anymore. We are agreeing on affect regulation, like to make it specific and not a big term that cannot be reached by clients, because we want to treat them with effective tools, and we have those effective tools. And I would also do like a phase, but my phase would be one session. We're talking about the biological background of dissociation, and we would, sorry, I was interrupted. I had a sign outside of my office, but shortly someone came in. So I think it's very, very important to, we do one session, we learn about the anti-dissociative scales, we prepare them, we go through what are early signs of recognitions, how do you deal with it, elaborate everything. But I would spend one session before I start trauma-focused work, because I know this is the mechanism how we can get out of this. And if I wait long time to start this work, they will suffer more, and it gets more and more chronic. And I think this is something we should learn, to be more open and be like, help people with those effective tools. And also, there's not really research really highly supporting this phase like treatment, because they're basically showing I'm prolonging because it lasts longer to be able to improve the outcomes. That's why we have to be very cautious, because I think this is actually maybe more re-traumatizing if we are not addressing what the trauma in the end, because this is a lot of things that I've learned from clients. They went from one treatment to another, and they have not been offered trauma-focused treatment. And they were suffering for years, for decades, and no one ever touched them. They were even not being asked about their experiences, so they haven't had it on the table. That's why I think it's so important this is the re-traumatization part, not to look at the problems and not have the trust that the person can do it and is able to have the capacities to tolerate it, because these are survivors. They can tolerate a lot. And if we are afraid to do it, they are usually not. They are open for this if you give them the framework and also tools to cope with dissociations in the treatment.
Yes, Inga, and thank you for bringing this up, because it's a newer perspective of treating trauma and dissociation. I was talking about the classical approach to the treatment, and of course, you don't have to stay too long on the safety and on the stabilization phase if you have resources in the client, if you have abilities, and you can have it depends on the severity and on the what kind of traumatic history does the patient have. I will start earlier with treating trauma if I will have a patient with impersonal traumatic events. Of course, I will start soon. If I have a different type of client with dissociation and everything and mechanisms that are chronic, I will stay maybe a little bit more like, I don't know how, depends again on the resources of the client, until I will see the client started to use something good for themselves, to be more careful in their daily life, and to be more attentive to the way they are sleeping, they are eating, and something like that, And so my first choice is to raise the protective factors, and that could be a while for some, could be one session for some people, or it could be some month for others. So it's important to have those both approaches, and thank you for bringing this up, because yes, there is not only one approach. So we have to choose the most the best approach for every client,
And I agree with that there is variance in how much of which approach might be needed in a specific treatment. Two things came to my mind that might be also helpful for listeners to know. On the one hand, patients who dissociate often seem a lot more functional and maybe also as if they're doing better than they really are, because sometimes the dissociation is kind of covering how deep the pain really goes. And at the same time, it's also true that when you take a step too fast, they're often very good at slowing you down. So sometimes their ability to dissociate is actually their way to stop you from going too fast. And in that sense, you also don't have to be so scared of being too fast. And we know if we, again, I think it very much depends on what we're talking about. If we're talking about PTSD with a few dissociative symptoms versus dissociative identity disorder, those are two totally different perspectives, I think. But we know from PTSD research that there's very little indication that you're actually making things worse if you're proceeding with trauma-focused work. There are a few clients that see symptom exacerbation. It's not very many, and for them it doesn't last very long. And we also know from research that the main reason why psychotherapists don't start the trauma-focused work is that they themselves don't like the feeling of feeling anxiety in their own body. We call that anxiety sensitivity. And we see a lot of kind of avoidance behavior on the side of psychotherapists to not implement trauma-focused work when it is indeed indicated. So this is an interesting field to navigate, where you have to think about both the therapist and the client. And I think in the past we have erred on the side of being overly cautious. And I would generally agree that it's better to go, but not in every case, again, not when we're talking about really complex cases with severe self-injury and so on. But I think in most cases, I would rather err on the side of being a bit fast and trust that my client will actually slow it down if it's too fast.
Very, very interesting perspectives and answers. Thank you very much to all of you for that. And we can go now to the section where we are opening the floor for the audience's questions, which we have been collecting via the chat below. And let's see. One of them would be referring to your own practice and research. What did you find out to be the most efficient therapeutic technique when it comes to treating dissociation?
I can maybe answer from my experience, but I have to say it's mainly based on CPTSD and PTSD, not so much on dissociative identity disorder. And I found it very helpful doing trauma-focused therapy to do bodily activational things, like to press the palms together, like pulling your arms aside. And I also do it always as a therapist. It helps me also to recover this, like a little bit from the stress that quickly arises when you see that your client is staring and is not as focused anymore during the session. And then, you do these techniques, or also from with the legs, you're pedaling as if you're on a bicycle. This is highly intense. Everyone maybe can do it right now, can test it. If you're on a chair, you have to hold yourself a little bit to do it. And this is something that is like making the body active again. And the second most effective method is smells. Our olfactory system cannot be shut down during dissociation, so this channel is always open. But I would highly recommend to use pleasant, not smells that are related to trauma, because in Germany we have this very, I don't know why, but a lot of people use ammonia, and this is a very unpleasant smell and has a lot of similarities for someone that was raped or something with any kind of bodily fluids. So that's why I would really use this with caution, but I would rather use like an orange oil, like vanilla oil, peppermint, something that is more pleasant and highly distinct from the trauma world, to create something they can reconnect in the here and now in the room, which is different, which gives them a sense of security, like safety. And these two techniques, I feel like they are highly like effective doing trauma-focused work, but there are tons of other techniques that can be used, like cold sensations, also like we use this kind of balls, which are a little bit like pointy, which you can like use as a massage, or there are rings that you can like slide down your fingers. There's all kinds of things. Music, one of my clients, she came back very easily with music. I just had to play something and she was like very quickly came back to the room. It should not be something from the time of the trauma. It should be something maybe more recently, like a music, like a song from more recently, not from the time of the trauma. We found out about this too. And yeah, I think this is the most effective techniques, but I would also highly encourage if there's someone in the audience to do research about this, because I would say like my knowledge is based on my experience with the clients. I learned from the clients, but there's not much research. When do I use what kind of technique and what is the most helpful way? Where is the most efficient? Like how fast get this person out of the dissociation? There's a lot of open questions in the clinical practice.
I think Sarah Dunberg actually started a study on this. I think it's currently running. Yeah. I want to add one thing just because it's so counterintuitive, maybe something that new therapists often really have to digest for a little bit. If somebody is very far, like if they're dissociating or if they're really switching, sometimes it's really not helpful to go into this therapist speak. And by that, I mean our voice. So go in low volume, super soft, very gentle. Often in those situations, you actually want to do the opposite. You want to speak quite forcefully, not too loud, but loud enough, very clear, short sentences, and very instructive. And that is often feels to clients more like the rope that they can actually still hear, that they can pull themselves back into the room on. So while the client looks like they might need a lot of help, your intuition to then become super soft and gentle might not be the most helpful one in that moment.
All right, thank you very much. The next question is addressed to Dr. Szaliński, but anybody feel free to answer. Regarding sex as a moderator, how do we distinguish whether women dissociate more due to biology versus socialization, trauma type differences, or the fact that freezing during interpersonal violence is often the only safe option? I wonder if you may think of these terms of generated social conditioning, and is there any way to differentiate between biological and anthropological factors? It's a long question, but you can also read it yourself in the Q&A box if it was kind of hard to follow.
I think it's a very interesting question, and I have not really an answer because I think there's a lack of research on this. Because as it was mentioning, I think we have to align the traumatic experience of people, which I think is very, very important. And I have just limited data that I collected over the years, and because it's less common that men report sexual abuse. And in my data, actually, I found the opposite. They had more dissociations than females that have experienced at least this trauma type. It doesn't mean that this is the same experience. But gender plays a role, and I'm not sure if it's also linked to the way we grow up. Maybe, yeah, it could be because men are more told to be active, maybe also more told to like push the other person maybe aside than a woman. You have to be polite, you have to be gentle, and maybe we are trained differently in this way. And also there's quite some biological differences. We are usually on average, men are higher than women are. So there are also maybe more capacity to do something about, like to change the situation, but we have not really well understood what kind of factors are like make the person higher or lower in the way they respond to it. And maybe it could also be the other side around when I now think about it, that men may be more likely upon a same traumatic experience will maybe more likely show dissociations because they're also more likely maybe to hear something, you should have done something about the rape because you're a man, why didn't you push this person aside? Maybe more likely than a woman. So they have a lot of more victim blaming maybe that they face from the society, but because this is something we are maybe less likely to look at. But we don't know how much this is. So at least I don't know a good study to refer to address this question, but there are maybe also some researchers out there that can do research about this.
Amazing, thank you very much. We've already kind of running late on time. There are 2 other questions which we could maybe answer very quickly. And then one of them is from Catrinel, and he wants to know if rumination is also a form of dissociation.
Well, rumination can become dissociative in function under some circumstances, like when repetitive thinking serves to distance oneself from emotions that are intolerable, rather to solve something, to solve a problem, or to stay with that emotion. Also, when the cognitive loop becomes automatization and detached from voluntary control, resembling absorption or trance-like mental repetition. And also when individuals report a sense of mental numbing or derealization that is accompanying their rumination cycle, like I can't stop thinking of that. I can't stop thinking of that. So, but I'm not really there, you know. So in these states, rumination begins to act as a cognitive avoidance strategy, like a detachment from the emotion, which aligns functionally with mild dissociative processes. But of course, DSM doesn't define dissociation as a doesn't define rumination as a dissociative mechanism.
Thank you very much, Maria, for your answer. And as we are approaching the ending of our session, the last question is referring to how do we close a very heavy session where we process trauma content without repercussions? About the closing of, yeah.
I think this is something we always, like, as maybe more proactive voices, really do not really do well enough to acknowledge this, because we are always evoking with this contents here quite a lot, because it's also affecting everyone in the sessions, and also very personally, even so it's very different how people respond to it. But I think, like, every healthy human being would respond to what we have discussed, and it's affecting us as humans. And this is something very natural, because we cannot just listen and feel nothing, because this would be actually something I would be worried about, if you would be here and listening and you would feel cold and not like feeling some emotional ups and downs. This is some like a very natural reaction. Our next reaction usually is to not acknowledge that we have been affected. The next step, which we always see in societies or groups that have been confronted with trauma, like basically anyone in the world, like any human, tend to avoid this and shift away. This is not a topic I would be interested in. Maybe I should take care of something else. Maybe they are wrong. Maybe they talked about experience that do not exist. Like, people have a lot of excuses that came out of this. This is very natural mechanisms that we know that this individual avoidance may step in when we do not acknowledge that this affects us as humans and hits us as human beings in a way. And we should not avoid this topic, I think. And we should have maybe been a little bit more cautious about this, even so it's a little bit like a balance, like if we should be cautious or not. It's also not clear from like, because if we are like saying you have to be cautious, there might be triggers arising in the session. Also, some other people feel like, I know also from a lot of people that because we see it in TV, they feel like it's not a good idea because then you get into a safety mode and you're not open for everything, and it maybe even trigger like responses to it rather than protecting it from this. So, but you see, humans are still like having difficulties dealing with like unspeakable topics because we are living in the society, and the society, like especially in Germany, they know a lot about silencing. And when we do it the other way around, it's always confronting us with quite heavy burden if you really start to look into this. So don't be afraid, and hopefully you can take some time, like what Maria Magdalena was also saying, for yourself, acknowledge this, and have a deep breath, and try to find something that you were here listening to this and confronting yourself with this topic, and maybe also not avoid too much about this topic, and be cautious also, or look around how people deal with these topics usually, and this would give you ideas about how humans deal with difficult topics.
Many times I send my clients home asking them, what is one good thing you're taking home with you from our today's session? You know, because that it's helpful for them to see that even the session was hard, they can have something good about them. And that could be, I could stay with some emotions, I could remember something very traumatic, or, you know, it doesn't matter what. What matters is that the client goes home with something good about them. And when the session is too hard, I'm working with anchors, and one anchor could be positive memories. So I will invite them to remember the most recent nice memory, and by doing that, immediately the body is changing, the emotions are changing, and this is safe for them to go home. Thank you.
I just have one thing to add to what was already said. And maybe again, that's a bit counterintuitive if you haven't been in this situation, but humor is very important in trauma therapy. And sometimes what we do in our offices is really weird. And then it's also really nice to have a laugh about it with our clients. And if you can do that at the end of a session, that's often a good way to part for the week.
Yeah. Yeah.
Thank you so much. So now we're coming to the end of our discussion. In one sentence, what is the one thing you wish more people understood about dissociation and trauma? Just one sentence.
I'm going to start so I have it easy. I would say that it's not something to be scared of, but it's a very normal human capability.
Yeah. Maybe open you up for this new like world for you as a new, more normal experience, protection, which also confronts yourself quite a lot.
Maybe I would say dissociation is protective, or it was protective in the first place. It is not a defect. So trust your own body and trust your own psyche that they really knows what to do in difficult situations.
Thank you. Thank you so much for all of our panelists for sharing your time, insights, and experience with us today. Your perspectives have helped us explore dissociation from multiple angles. And for anyone who would like to continue learning, we'll be sharing a short list of recommended readings and resources, including some of the speakers' own publications and talks. So thank you as well to our audience for your thoughtful attention and participation. We hope that today's discussion has sparked reflection and curiosity to keep the conversation going beyond this panel. So now we will be moving to a break and we'll be coming back for the second half of the conference at 2 p.m. Central European time. So
Thank you,
so much.
Sophia
Thank
and
you.
Isabella, for moderating this greatly. This was amazing how much you deep dived into the topic with us. And thank you
so much.
also for Judith and Maria.
Amazing having you here. Thank you.
Thank you.
Nice to meet you all, at least online.
Yes.
Bye.
Thank you, everyone. And thank you for all the so many little hearts that are coming to us. Thank you. Nice conference. Congratulations.
Thank you very much. Bye.
Thank you.
Good afternoon, everyone. Good afternoon, Dr. Paula Castellano. We're just going to take a few minutes to wait for everyone from the lunch break in case there are any late ones.
Thank
So
you.
just a few minutes and we'll start.
Thank you.
Great. So good afternoon, everyone, and welcome back. We hope you enjoyed your break and also the first part of the NeuroCon conference 2025, Trauma and the Brain Under Stress. My name is Luana, and together with my colleague Clarence, we'll be hosting the second part of today's program, focusing on the intricate neurobiology underlying trauma and chronic stress mechanisms. We have 4 more guest speakers joining us this afternoon, starting with Dr. Paula Castellano, who will present the influence of depressive traits and pain on health-related neural processing. She will be followed by Dr. Dylan G, presenting the developing brain under stress. Then Professor Richard Contrada will discuss about cognitive affective traits, psychopathology, and cardiovascular disease, the role of stress-related mechanisms. And we'll finally conclude the day with Professor Carmen Pedraza Benitez presenting Unraveling Stress-Induced Depression, Neuroinflammation, Neuroplasticity, and the role of sex and individual differences. Just to answer quickly a question from our box, how many hours do we have to attend in order to receive the certificate? So we are going to reward certificates of participations. If you attend more than 60% of the conference, that would mean roughly between 15-17 hours of participation. So just to respond to questions. And then, as previously stated, of course, there is the question box, and the last 10 minutes of each speaker will be for the Q&A. So don't forget to drop your questions and take the opportunity to ask our speakers about their findings, perspectives, or anything else that sparks your curiosity related to the presentation. It's going to be a busy afternoon, so let's get started. I now invite our first speaker, Dr. Paula Castellano. She's a psychologist and psychotherapist in training. She's a research fellow at the Department of Psychology at Sapienza University of Rome, focusing on psychophysiological indicators of depression. At the same time, she's a scientific collaborator at the Institute of Neuroscience, Université Catholique de Louvain, where she studies the relationships between psychological factors and pain. She earned her PhD from the University of Bologna, where she investigated psychological factors influencing health behaviors and the psychophysiological consequences of antibiotic misuse. Dr. Castellano will present her paper with the title The Influence of Depressive Traits and Pain on Health-Related Neural Processing. With no further ado, I'm pleased to give the floor to Dr. Paula Castellano.
Hi everyone, thank you. I share my screen.
Yes, yes. Everything is fine. I can hear.
Okay. Mhm. Okay, so tell me if you can see my presentation and if you can hear me well.
Yes, yes,
Okay.
everything is fine.
Okay.
Yes.
Thank you so much. Okay, so good evening everyone, and thank you for the invitation. It's a great honor for me to have the opportunity to present this study here at Neurocon. I don't know if you see my face, and probably you don't see all the slide. I don't know. I can.
Oh no, everything is fine.
Okay.
I can see like the entire.
Okay. So okay.
It's fine.
Perfect. So yes, just a short presentation of me, but you already did it. So I'm Paola Castellano. I'm a psychologist and also a psychotherapist in training. I'm currently working at the Sapienza University of Rome on a project based on the psychophysiological correlates of depressive rumination. And I start my presentation with this kind of slide just to describe why I'm presenting a work like this, because all my academic life it's based on the study of the combination between psychological and physiological aspects. And so starting from my master's degree in cognitive neuroscience, moving to my PhD on psychological factors involved in health and illness behaviors, and now my work in Sapienza, but also my collaboration with the university, University of Brussels, or the Université Catholique de Louvain. And the study that I'm presenting today is a study that I conducted there during my PhD. And it's not a study specifically related to trauma, but it's more related to affective disorders and affective vulnerability. That's because, as I told you, the mind-body interplay is the main research interest in my academic life. So today I will present findings from this study. That is a study that explore how depressive traits and their declination, so in particular emotional regulation, together with pain sensitivity, interact in shaping the way our brain process health-related information. The idea underlying this study is that our brain, so also the emotional states and the body, form an integrated system. So emotional traits, such as, for example, depressive symptoms or difficulties in regulating emotions, can modulate how our body reacts to the environment, including pain sensitivity. In turn, these physiological responses influence how the brain processes information related to health, to illness, or threat in general. So biases in this integration may contribute to emotional distress or maladaptive health behaviors. Therefore, understanding this interplay helps us to capture subtle or meaningful individual differences in how people respond to health-related cue, even in non-clinical populations. Our research is grounded in the biopsychosocial model of Engel that, of course, you already know, but I try to explain it a bit. So this framework posits that health and illness result from the dynamic interplay between biological, psychological, and social processes. For example, between the biological processes, we have age, sex, genes, so everything that come from our body and the way in which we are born. The psychological aspects include, for example, our personality, our fears, our emotions, so everything that is related to the deepest part of us, while the social processes include expectations from others, the stigma, relationships, beliefs of our peers or our families. So according to the biopsychosocial model, no single domain is sufficient to explain how people experience or maintain health, and changes in one single domain can influence the others. So this is really important because we cannot study just health in one of these domains, but we have to consider all of them. So for example, relating this perspective to our study, the emotional regulation and the depressive symptoms, which are the psychological components, the psychological manifestations, can shape biological responses such as pain sensitivity or neural activity. At the same time, the social context, the personal health beliefs influence how these experiences are interpreted and managed by people. So understanding these interconnections help us to explain why even among healthy individuals, so people who doesn't have specific diagnosis or manifestation, have also different processing of health-related cues. So it's important to us to understand individual variability, and we have to study these components in integration and not in isolation. So we know that mind, body, and brain are inseparable, and our work tried to uncover in such a way how their interaction shapes people's perception of health, even, I repeat, in healthy individuals. But why do we consider so important the study of health-related processing? First of all, we know that our brain processes countless external stimuli, even without our conscious awareness, so even below our conscious awareness. Among these, we can say that the health-related cues are really important because they can signal potential threats or opportunity for well-being. Moreover, we know that individual traits, such as, for example, anxiety, traits related to mood, or personality traits, perception of stress, can modulate the neural responses to external stimuli. And for example, we know that there is a greater emotional and physiological reactivity in front of emotionally salient stimuli in people with higher psychological discomfort. Of course, in this framework, health anxiety, which consists in an excessive worry and preoccupation with one's health, provides a useful framework because we know that people with higher levels of health anxiety tend to have also an heightened attention and stronger emotional and physiological response to health-related stimuli. And this is something really known in literature, but the neural mechanisms that are behind these responses are still little known. So for us, individuality has a big role. Psychophysiological traits, as for example anxiety, emotional regulation, impulsivity, and coping strategies, influence the attentional bias and emotional reactivity that people have in front of emotionally silent stimuli, including health-related stimuli. For example, we know that people with depression tend to have an altered attention and processing of those kind of information. But we also know that in case of emotional dysregulation, that is a manifestation even of depression, there is stronger illness-related responses. And also, for example, for physical traits, as in case of pain, we know that it can modulate the reactions that people have in front of this kind of information. So knowing that, yes, the brain can always process information from the environment, it's not enough for us because we know that the way in which each person is done, it's something that really modulates the way in which his or her brain process this kind of information. So in this study, we were particularly interested in how these dimensions interact in healthy individuals, that is in non-clinical population where subtle affective differences might already shape neural responses. So in summary, our study investigates whether the brain can implicitly detect health-related cue, and in particular, how these responses are modulated by psychophysiological individual differences. Now I will show you an overview of the experimental design, but then I'll go deeper for each step. So first, participants completed at home a set of psychological questionnaires, so they underwent a psychological assessment, and then they came to the lab and they underwent two experimental sessions in the same day. So first of all, we did a pain threshold assessment with a thermal simulation, and then an electroencephalography recording session together with a visual paradigm for the presentation of the health-related stimuli. That is the fast periodic visual stimulation that I will show you now in the next slide. We included just, as I told you, healthy participants, and at the end we had a sample of 41 participants, mostly female, with a mean age of 25 years old because they were students from the university. And of course, we excluded from the sample people with psychiatric or neurological diagnosis or with chronic pain, and with people who used medication in the previous 12 hours. So about the protocol, I want to show you before the fast periodic visual stimulation paradigm, because probably it's something that it's not known from everybody. So this is a visual paradigm employed, and it's a well-established approach in neuroscience for eliciting periodic electroencephalography responses to visual stimulation that are delivered at a fixed frequency. So traditionally, as you can see from these papers that I show you here, fast periodic visual stimulation is used to study rapid neural categorization of faces, objects, or semantic categories. So this is the first study, in which we applied the fast periodic visual stimulation paradigm to abstract categories, as for example the health-related stimuli. So the fast periodic visual stimulation task consists in a rapid presentation of visual stimuli at a fixed frequency of 6 Hz, so 6 images per second. And most of the images that you can see in this example, that is how the fast periodic visual stimulation task is usually conducted. So as you can see, with faces and objects. So most of the images are neutral, while every fourth image is replaced by an audible stimulus, so a silent stimulus that is consistent with the aim of the study. So for example, if you want to study faces, the audible stimulus, as you can see in the fifth image, is a face. And it is used to elicit a category-specific neural response. This periodic alternation allows the neural response to the audible category to be tagged and at its own frequency of 1.2 Hz, distinct from the general visual response at the base frequency of 6 Hz. Usually, the fast periodic visual stimulation paradigm is presented with different conditions. So we have often periodic condition in which images are presented periodically, but in an intact way. So as you can see, for example, here in the example, or in a non-periodic way, or a condition in which scrambled images are presented always periodically. Obviously, the use of scrambled images is to avoid any kind of confounding results related not to the content of the images. And always, as you can see from the images on the down part of the slide, the typical results report high response at the base presentation frequency of 6 Hz that is focused around the electrode P08, so in the occipital part of the brain, while for the scrambled images, there are always results that report a huge response around the electrode OZ, so in a more mid-occipital part of the brain. And so, as you can see, there is a response, not, for example, in the periodic presentation of intact images, not related just to the base presentation at 6 Hz, but also in the oddball presentation. So we see I don't have a pointer, or maybe I don't know if you see my mouse, but here we see a response at the point at the oddball frequency presentation, so at the presentation of the silent stimulus. In our study, we readapted the fast periodic visual stimulation paradigm, and we introduced the health-related images as oddball stimuli, always periodically embedded within a rapid sequence of neutral images. So also here you can see that every 4 images, there is the 5th image that is an oddball, so a silent image that in this case was a health-related image, consistent with the aim of our study. And the goal was to test whether the brain would generate a frequency-tagged neural response specifically at the presentation rate of the health-related stimuli, differentiating them from the neutral ones. The task consisted in this rapid presentation of images, but participants had some instructions because we needed to keep their attention on, of course. And so they saw a dot on each image, and we asked them to count how many times they saw the dot changing in red, just to keep their attention on. We weren't interested in knowing how much dot they counted, but it was just a way to keep the attention on. Also in this case, we had 2 experimental conditions. So a normal condition in which the images were presented intact, as you can see in the example in the slide, and then a scrambled control condition, where images were phase scrambled, always to be sure that any observed neural response was driven by the semantic content of the stimuli rather than by, for example, low-level visual features. And here you can see some examples of images. So we have examples from health-related images, then from the non-health related, so from, for example, what I mentioned as neutral images, and then the scrambled images. As I already mentioned, to better understand individual differences, we first assessed a broad set of psychological traits, so with a huge battery of standardized questionnaires. So we had questionnaires about depression, anxiety, perceived stress, motivational behavior, emotional regulation, impulsivity, and coping strategies. Together to this psychological assessment, we also had a physiological assessment because we assessed the pain threshold of participants with a contact at contact heat thermode, and participant underwent to 3 heat stimulations, starting from a baseline temperature of 32 degrees, and they were instructed to press a button as soon as the sensation became burning or pricking. Obviously, this psychophysiological assessment allowed us to link the psychophysiological traits to the neural response observed during the electroencephalography registration. And the reason why we decided to assess pain threshold is because pain threshold can be used as a sort of trait, so dispositional feature, and it is one of the most related to the illness field. So this is the reason why we assess pain threshold. Here, a rapid overview of the statistical analysis that I know that sometimes is the most annoying part, but also really important, so I will go a bit faster. So EEG data were pre-processed and then analyzed in the frequency domain. So we applied a fast Fourier transformation, a baseline correction, we identified significant harmonics, and then we aggregated them at the base and oddball frequencies. Then EEG data were analyzed, as I told you, with frequency domain analysis. And we identified the significant electrodes that also in this case, as in the previous studies that I show you, so those that typically use this kind of paradigm, we identified PO8 and OZ. And then we run a repeated measure ANOVA, 2x2 repeated measure ANOVA between conditions, so normal and scrambled, and electrodes, so PO8 and OZ. While regarding individual differences, first of all, we conducted some correlational analysis between the variables of interest, so the EEG response to the oddball, so to the health-related stimuli, together with the psychological and pain measures. Then after we had some significant correlations, we did some regression analysis to identify predictors between the variables of interest. And then we went a bit deeper with the moderation analysis, always to understand the real relationship between psychophysiological variables and neural responses. So I'm not asking if there are questions or something that is not clear, but if you want to interrupt me, feel free to do it in any moment you want. So moving to results. Okay, now I will show you first just the results related to the EEG part, so to the EEG response. So we can observe that there was a high response at the base stimulation frequency of 6 Hz in both the conditions. So this told us that the task worked because every time you present something periodically to a brain, the brain has a response. So the fact that we registered a response at the base frequency was the meaning that the task worked. But the really important part for us was that there was an high response at the frequency of health-related images only in the normal condition, and this response was focused in the right occipitotemporal region, that is the one responsible for the interpretation of visual stimuli, so also always around the PO8 electrode. So with this study, we replicated the results from the previous studies which used the same paradigm, but this was the first study in which the paradigm was used with an abstract category. So the first thing is that we can see that the brain has a response at the health-related images that is not present when the health-related images are not presented. So for example, as in the scramble condition. But then moving to the part that was more interesting for us, that are because we are psychologists, so we are interested in individuality. At first we just ran, as I told you, some correlation analysis that showed us few significant correlations. So we see that there is a positive correlations between the EEG response to the health-related stimuli and the depression scores. and no other significant correlations with other psychological conditions emerged, while the pain threshold seemed to be negatively correlated with the emotional dysregulation, and also with the motor impulsivity and the coping strategy of positive reframing. So from this kind of correlation, we can infer that people with higher scores to the depression questionnaire had also a higher response to the health-related stimuli, as well as people with a higher emotional dysregulation had also a lower pain threshold. But then we moved to some regression analysis because we wanted to understand the direction of this kind of correlations, of associations, and we found that depression positively predicted the EEG response to health-related stimuli. So we can see that the direction is that higher depression predict an higher response, while for emotional regulation, we see that an higher emotional dysregulation is related to a lower pain threshold. So it's something that can predict a lower pain threshold. But then we wanted to go deeper in these relationships between affective and pain-related vulnerability and neural processing. So we examined the moderating role of pain threshold, because we can see from here that pain threshold is related to emotional dysregulation, but emotional dysregulation is a manifestation also of depression. So we asked ourselves if, for example, there could be triadic relationship among them. So we went deeper with a moderation model, and so we examined the moderating role of pain threshold. And what emerged was really surprising for us, because pain threshold appeared to moderate the relationship between depression and the EEG signal to health-related images, but in a specific direction. So at low pain threshold, depression had no effect on neural responses. But at medium levels, the effect became significant. At high pain thresholds, depression was strongly associated with increased EEG amplitude. So we can see that participants with higher levels of depression and a higher pain threshold that are also more emotionally regulated, because I remember you that pain threshold was predicted by emotional regulation. So they tend to show a stronger response to periodically presented health-related stimuli, while in case of higher level of depression but lower pain threshold, this kind of response was attenuated. So this indicates that the influence of depressive traits on health-related neural processing is not uniform, but depends on individual pain sensitivity. So we imagine sort of psychophysiological bridge among depression, pain, and neural sensitivity to health cue. If we look again at the analysis that we have done, in the first step, we ran just a regression model, and we saw that depression predicted in a positive way the neural response to health-related stimuli. And together to that, emotional dysregulation predicted negatively the pain threshold. But when we include all of them in the same moderation analysis, and when we introduced pain threshold as a moderating variable in the relationship between depression and neural response, the picture became more complex, because pain threshold entered the model with a negative coefficient, and its interaction with depression significantly predicted the EEG amplitude. What this means is that pain sensitivity changes the way depression relates to brain response. So for individuals with higher pain threshold, that also have a higher emotional regulation, there is a increased neural response, a stronger neural response to emotionally silent stimuli as the health-related ones. While when the depressive symptoms are in combination with a lower pain threshold, so also with a lower emotion regulation, we have this kind of neural response that is in such a way attenuated. So statistically, this interaction caused the direct effect of depression on EEG response to flip from positive to negative when controlling for the moderator, which reflects that the overall relationship depends strongly on the individual's pain sensitivity. So this moderation in such a way suggested us that the neural signature of depression is not uniform, but rather modulated by individual differences in physiological regulation, such as, for example, pain perception. We can also imagine, for example, that emotion dysregulation lowers the pain threshold, and this reduced the ability to buffer stress, and pain weakens the neural responsiveness linked to depressive traits. So it was really important for us because we really saw a combination between psychological vulnerability and physiological sensitivity. This pattern can be this is really important because we have to imagine emotional dysregulation and pain threshold as a sort of affective sensory resource that individuals have. And this pattern can be interpreted through the lens of the allostatic load model. So if, for example, we imagine people affective and sensory resource as a bar, we can see that people with high pain threshold that are also more emotionally regulated, they have a sort of sufficient neural resource to be engaged in the neural response to something that is emotionally salient. So the fact that they have a higher pain threshold, so probably they feel pain later in time, they don't have their sensory resources all engaged, for example, in feeling pain or feeling emotions, because they are more emotionally regulated. So they have this space, they have enough resource to be engaged in the neural response to other emotionally salient stimuli. While in case of people with low pain threshold that are also less emotionally regulated, it's like if they don't have space to process other emotionally salient stimuli, emotionally salient information. So we infer that the reason why the neural response is attenuated is because they are enough engaged in other kinds of sensory affective stimulations, that is, for example, pain or their emotions, because they tend to have lower thresholds. So it's like if we imagine that people with lower pain threshold have a reduced emotional reserve, while in case of higher pain threshold, there is a possible reserve of emotional sensory results that allows for the processing of emotionally significant stimuli. So it's like if under high allostatic load, so high engagement of sensory resources, the affective and sensory systems are overemployed, leading to reduced neural engagement even in the presence of depression, that is something that activates the affective sensory system. So from this we can try to infer that the relationship between depression and neural responses to health-related stimuli is not linear, but it depends on the individual's affective and physiological regulatory state, and that pain threshold may represent a marker of residual affective sensory resources the capacity that allows or prevents the brain from engaging with emotionally silent information. So it's like if the cost of adaptation under chronic affective load may shape how the brain perceives and processes emotional cue. If we want to move this kind of idea to a trauma perspective, we can imagine like if, for example, it fits well with the idea that affective dysregulation and altered interoceptive sensitivity, that are both typical consequences of traumatic stress, can modulate the neural reactivity. So when the system is under sustained allostatic pressure, the neural response to emotionally silent information may become blunted. But when this capacity is preserved, even, for example, in presence of affective symptoms, neural responsiveness to emotionally meaningful cue may remain intact or even increased. So if we put everything together, our findings suggest that the neural processing of health-related information depends on the interplay between affective and physiological systems. Depression alone doesn't always predict stronger neural activity, but it does so only when individuals still have sufficient allostatic resources that are reflected by their pain threshold. So this aligns with models of allostatic load, which describe how chronic stress and affective dysregulation can deplete the body's ability to respond flexibly to emotion cues. So these kind of results in such a way support the neurobiological models of stress, emotion, and sensory integration. Of course, our study has also some important limitations. First, although we compared intact and scrambled images, we didn't include a control category matched for emotional balance and arousal, which means that we can fully disentangle health-specific effects from general emotional silence. So we are not sure that the response is strictly related to the fact that images were health-related or just emotionally silent images. Second, the sample size was small and our analyses were so far exploratory, so the findings should be interpreted with caution. And for future research, we also have we plan to extend this work to not only to larger samples, but also to more different samples, including, for example, clinical samples like affected by mood disorders or trauma-exposed samples. So future studies should use standardized control categories, even specific measures of health anxiety, because here, for example, we just used, for example, for anxiety, we used the trait anxiety scale, so a more general scale of anxiety, and also larger and diverse samples. And the aim is to integrate physiological, emotional, and neural markers to better understand how the allostatic load shapes the emotional brain responses. So in summary, our study, first of all, demonstrated that the fast periodic visual stimulation paradigm can be used also with abstract categories. But more important, we found, or we saw that depression modulates the neural response to emotionally silent stimuli, included health-related ones, through pain threshold. So this relationship depends on the individual's pain threshold. And we can interpret pain threshold as an indicator of available affective and sensory resources, consistent with the allostatic load framework. This means that, as I told you, individuals with higher depression and lower pain threshold may show a blunted neural response, while those with in such a way preserved affective sensory resources still display an increased reactivity. Overall, these findings bridge neural processing, affect regulation, and somatic sensitivity. So they offer new insight into how affective and physiological systems interact under emotional load, especially in conditions linked, for example, to affective vulnerability. So these findings for us highlights the importance of integrating always psychological, physiological, and neural perspectives in general in affective disorders research, but when we want to study health in general, because this is in such a way the idea, the purpose that lies behind all our studies, because as I told you at the beginning of my presentation, for me, there is no health without mind and body interplay, and the brain's response to health is not just neural, so it's emotional, physiological, and human. So humans are made both of body and mind, so we have always to consider both of them to move to even more holistic way of health. So just 1 minute to thanks people who allowed me to do this study. So Professor Giulia Liberati from the Université Catholique de Louvain, Dr. Chiara Leo from the same university, and she worked with me a lot on this study, and my PhD supervisor from the University of Bologna, Professor Michela Mazzetti. And thank you all for your attention. I hope that I stayed in time, and I'm here for any kind of question now or in future. If you have future suggestions, you can write me in every moment, and I will be happy to reply.
Thank you very much, Dr. Castellano, for your presentation, first of all, and for sharing your research with us here today. We're going to take a moment for a few questions from the audience regarding your presentation. We have some questions, actually. The first one would be, do you think that EEG responses reflect more of a trait level vulnerability, so stable over time, or a state effect depending on the moment and context?
I think that this kind of EEG recording that was related to the visual presentation of images, I think that it can be considered as a state feature, because even if we know that there is always a periodic response from the brain when we present periodically something, but I consider this kind of recording as a state feature and not a trait feature, even because I think that, I mean, I hope, as I show you in my findings, that it's really related to the specific vulnerability or conditions of individual condition of people. So I think that depends also on the kind of well-being in which people are in the moment in which they undergo the EEG recording.
Okay, great. So also related to the visual stimuli, I have a question. How do you ensure that participants interpret these visual stimuli consistently? Given, let's say, I'm not sure cultural, because I think the sample might be fully Italian, so I'm not sure, but let's say about personal differences in pain perception.
Yeah, the sample was Belgian, because I did the study when I was in Brussels for my abroad period during my PhD. For the health-related images, we did a sort of rating from a different sample. So a different sample rated images. So they had a scale, and they had to give to each image a rate of how much they considered them health related. So people who underwent the task, they hadn't seen the images before then the task. So, but we used a different sample matched in such a way. I mean, the age of the rating sample was quite similar to the sample which did the task. So I think that the generability of the health-related content is quite good. And you have also to consider that the presentation of images is really, really fast. So they don't have the conscious idea that they are seeing health-related images. But then we have seen that there is, in such a way, a signal in their brain that they perceived something.
Yeah, because I remember you said there were 6 images per second. So
Yeah,
actually, I was
really
thinking, oh
fast.
my, that's pretty fast. Yeah.
Yeah, a lot.
There is a specific, like, can we know the exact specific reason why it's 6 images per 1 second? For example, why it's not per 1.5 seconds? Is there a specific reason?
It is based on the standardization of the task. So the task is because they studied from the Rosion group, that is the group who created the task, that 6 Hz is the specific frequency of presentation in which there is a periodically response from the brain.
Okay, great. And also, for example, for future studies, do you plan to combine also EEG with other methods? I was thinking maybe fMRI or to get maybe a fuller picture of these processes, let's say.
No, we would like to combine more neuroimaging studies, more neuroimaging techniques, even because it could allow us to go over all the limits that we have with this study. So it could be a good way to be sure, for example, that the images are detected as health-related images, or to see, for example, which kind of areas are activated. For example, if areas are related to pain, I don't know, I imagine the insula or brain areas like this. Yes, it could be really useful to understand which kind of visual processing we are touching when we present this kind of images. So yes, we would like, and we would like to do that, of course, in different kind of samples, including also clinical populations.
Yes, for sure, of course. Then what would be the impact of these results from your research on future treatment strategies or maybe prevention, let's say?
Yeah, as I mentioned, we work with unhealthy populations. So the main aim was to, in such a way, sensitize these people on the fact that the health-related processing, so for example, also when we receive information in the health field, is not something just related to what can be seen physically, but also on something that happens deeper. So for example, in our psychological aspects. So the impact for us is that is to sensitize on the importance of consider health in a holistic way. So for example, if I imagine, I don't know, doctors working with patients, how important is to consider also the impact that kind of health information is having on the affective part of the patient, and not only on the physical aspects that can be more in such a way visible or, I don't know, assessed in a rapid way. So all my studies have always have the aim to try to give this kind of suggestion. So remember that also the psychological aspect is important when we talk about health.
Okay, great. Thank you very much, Dr. Castellano, again for your presentation, for being here with us today in the second part of the first day of the NeuroCon conference, Trauma and the Brain Under Stress. We'll now proceed further with our next speaker, even though we're going to have a short 5 minutes break. And I'm going to give, after these 5 minutes, the floor to my colleague Clarence, who will take it from here now.
name is Clarence, and I will be your host for this session. And it is my pleasure to introduce you to our next speaker, Dr. Dylan G. Dr. Dylan G is a professor of psychology at Yale University, where she directs the Clinical Affective Neuroscience and Development Lab. She earned her PhD in clinical psychology from UCLA and completed her clinical training and postdoctoral fellowship at Weill Cornell Medical College. Her research investigates neurodevelopmental mechanisms of early adversity and risk for psychopathology in children and adolescents, with a translational focus on improving interventions and policies that support youth mental health. Dr. G will present her paper with the title, The Developing Brain Under Stress, which explores how early life stress shapes brain and behavioral development and why individuals exposed to adversity exhibit diverse mental health outcomes. Everybody, please join me in giving a warm welcome to Dr. Dylan G. And Dr. Dylan G, the floor is yours.
Wonderful. Thank you so much, Clarence. Can you hear me okay?
Yeah.
Wonderful.
Doctor.
Thank you so much for the invitation to be here today. It's such a pleasure and honor. And I'm really excited to share some of our research on how stress affects the developing brain. So this work is really motivated by the fact that experiences that take place early in life can have profound influences on a child's development, from variation in the predictability of caregiving behaviors to exposure to traumas such as abuse or neglect. These environmental contexts in which we develop play an active role in shaping our learning and behavioral repertoires for many years to come. And as shown here, early adversity is unfortunately prevalent. As one example, up to 65% of youth are estimated to experience some form of major traumatic event by the age of 16. And we know that the brain adapts to these experiences. Adversity is one of the most potent risk factors for psychopathology. So among youth exposed to trauma, approximately 30% of those youth will go on to develop a mental health disorder. And yet, to me, the statistic has always highlighted that this is not a deterministic relationship. So not all children who experience trauma go on to develop a mental health disorder, which can tell us a lot about processes of resilience and recovery. Identifying sensitive windows of brain development and how alterations early in life can affect later brain and behavioral development can play a key role in understanding trajectories that are associated with risk and resilience in the context of stress and trauma. So given dynamic changes in brain development and neuroplasticity, we know that brain development is characterized by sensitive periods of heightened plasticity, when the developing brain and individual are more amenable to environmental inputs. And critically, this can present both increased vulnerability, but also increased opportunity. So we think of sensitive periods of neuroplasticity really as opportunities for the developing brain and the individual to optimally calibrate to their childhood environment. And so for individuals living in harsh or traumatic or unpredictable circumstances, the brain may adapt in ways that are really adaptive in the short term, but that can also confer later risk for psychiatric disorders. And so one of the goals of this work is to really understand the ways in which we can leverage that plasticity to promote resilience in real time. The last thing to emphasize here is that critically, we know that sensitive periods of neuroplasticity are both circuit and function specific. So different brain regions and circuit develop at different times in development. And so critically, when a traumatic event occurs or when a stressor occurs in development is going to matter in terms of its impact. So much of the work in the field has focused on what I'll refer to as cortical limbic circuitry. This is a brain circuit that's especially sensitive to early experiences, whether those are more positive and protective or whether they're quite stressful or traumatic. And one of the reasons is that this circuit is very dense with glucocorticoid receptors. when I talk about cortical limbic circuitry, I'm going to focus in on a few key regions. One is the amygdala, which we know is essential for detecting salient information in the environment. It plays a key role in emotional learning and fear expression. Another key region is the hippocampus, which is involved in contextual modulation of environmental stimuli, such as threat versus safety, and is involved in contextual learning and memory. We then look at various regions of prefrontal cortex and anterior cingulate cortex, such as the ventromedial prefrontal cortex, that play a critical role in processes like fear extinction and stress regulation. And when we think about the environment in which the brain is developing, it's critical to think about the brain as being embedded in its context. So we've drawn a lot on Bronfenbrenner's pivotal theory of ecological systems, which suggests that children are growing up in interconnected layers of the environment. So we can think about more immediate settings like families and school, to broader cultural, societal, and historical contexts, all of which interact to shape an individual's growth over time. And given this, there's substantial variability in factors like the developmental context in which stress or trauma occurs and the developing timing of that adversity in the nature of this very multifaceted environment. And arguably, one of the most critical contexts in which the brain is developing is in the caregiving environment. So caregiving plays a primary role in stress and resilience. And this kind of just shares a brief contextual model of how we've been thinking about caregiving experiences that can promote resilience in the context of adversity. So here we can think about exposure to stress or trauma during development that increases risk for mental health disorders, with evidence suggesting that alterations in brain and behavioral development mediate this link, particularly processes that are related to affective development, like emotional learning and regulation. Caregiving experiences play a key role in moderating the effects of stress exposure via relations with several constructs in this model. So, for example, caregivers can contribute to adverse experiences through perpetration such as maltreatment. These can affect brain and behavioral development, but they can also directly influence children's mental health in more positive ways. So we're often focusing on the role that caregivers play in moderating that association between stress or trauma exposure and brain development, in which case they can be very promotive of children's resilience by buffering the effects of stress or adversity. And critically, the context in which the brain is developing and the role of caregiver regulation is shifting a lot across development. So cross-species research has identified a potential sensitive period spanning infancy and toddlerhood, when caregiver inputs to the developing brain may have a particularly strong impact on the development of this cortical limbic circuitry that supports emotion regulation. Caregiver inputs that are predictable and that are associated with safety may promote healthy neurodevelopment such that caregivers are able to support emotion regulation via modulation of this circuitry in later developmental stages. And so when we think about a child's development of stress and emotion regulation, what we typically think about in developmental neuroscience is really a shift from greater external emotion regulation and greater reliance on caregivers to really more intrinsic or independent stress regulation as development proceeds. So it's critical to account for the maturational stage of the developing brain, as well as the individual differences in a child's environment when we're thinking about how to understand neurodevelopment and how to best target policies and interventions that can promote well-being among individuals who've been exposed to stress and trauma. So this figure illustrates just kind of a snapshot of a theoretical model that we've put forward for how variability in the childhood environment may inform risk for psychopathology. So, for example, for a given adolescent, developmental stage, early life stress history, and protective factors such as supportive caregiving can contribute meaningful information about a probable neural and behavioral response to a current stressor. For example, on average, an adolescent with substantial adversity exposure and fewer protective factors may be at higher risk for psychopathology versus an adolescent with similarly high levels of early life stress exposure, but greater protective factors or environmental factors that may help to buffer stress exposure. So taken together, we aim to leverage this knowledge of the developing brain and profiles of childhood environments to optimize interventions and policy to promote well-being. So the lab has 3 complementary lines of work that really focus on targeting the biological state of the developing brain in stress-related psychopathology. So the first, we're examining the role of early experiences in brain and behavioral development. The second, we're examining basic mechanisms of stress and emotion regulation and how these change across development. And the third, we're applying this knowledge to inform how we might be able to optimize interventions for youth, for example, based on their developmental stage or their exposure profiles. So I want to share some examples from each of these lines of work in today's talk. The first asks the question, how does early life stress influence mental health across development, and by what mechanisms? So just to kind of ground us in this literature, we know that early life stress alters cortical limbic circuitry and affective behavior. Cortical limbic circuitry undergoes a very protracted development, so connections between the amygdala and the hippocampus and the prefrontal cortex are continuing to emerge and to strengthen over the course of adolescence and even into young adulthood. And one of the kind of key findings that's been identified across species literature is that early life stress can actually alter the timing of cortical limbic development. However, a key limitation to this work is that in humans, this research has been largely cross-sectional, which really limits our ability to draw conclusions about longitudinal within-person changes across development. Increasingly in recent years, large developmental neuroimaging data sets have been particularly helpful for addressing these challenges. So this is a map across the world of the many regions in which we now have publicly available large-scale developmental neuroimaging studies. There's been a rise in these types of studies that examine both the early environment and brain development, providing rich opportunities for multi-contextual, person-centered research that can bring us closer to a better understanding of variability in youth experiences and neurobehavioral trajectories, including across different regions and cultures. Today, in this part of the talk, I'm going to focus on research that we've conducted as part of the Adolescent Brain Cognitive Development Study. This is the largest longitudinal neuroimaging study of youth to date. So we recruited a baseline cohort of over 11,000 children when they were 9 and 10 years old. And they were recruited and are being followed for 10 years. So at the Yale site, many of our participants are now turning 18. Some have gone off to college and entered the workforce. And importantly, participants were primarily recruited through schools using a multi-stage probability sampling method to ensure that the ABCD sample estimates as closely as possible the sociodemographic variation of the US population on sex, race and ethnicity, socioeconomic status, and urbanicity. So here, there's a couple of examples of this work that I want to share illustrating what we've been able to learn about the effects of early life stress and cortical limbic development. This first study is work that was led by Alexis Bryant, and she was really interested in examining how stress exposure relates to changes in cortical limbic connectivity and how those changes over time may mediate the effects of early life stress exposure on children and adolescents' mental health. So here we had a sample of over 4,000 children from the ABCD study who had resting state functional connectivity data that was collected at baseline as well as 2 years later, allowing us to look at longitudinal changes in brain development. We examined negative life events as a measure of early life stress exposure and used the child behavior checklist to examine internalizing and externalizing symptoms of psychopathology. And what Alexis found is a negative association between exposure to negative life events and changes in connectivity. Based on this connectivity pattern, we interpreted this to reflect a more mature pattern of connectivity, consistent with models of stress acceleration in the broader literature. In turn, this more mature pattern of connectivity was associated with lower levels of internalizing symptomatology, but not externalizing symptomatology. And this indirect effect is significant, suggesting that changes in connectivity of the amygdala and prefrontal regions may mediate the association between early life stress exposure and later internalizing symptoms. And here I'm showing results for the right amygdala, but we see very similar results for the left amygdala as well as for the right hippocampus. So this provides initial longitudinal evidence for alterations in timing of cortical limbic development. One possibility is that early life stress exposure may accelerate the timing of this circuit development in a way that may be adaptive in the short term. So some evidence for this is that these children who were demonstrating the accelerated pattern of maturation were also those who had the lowest internalizing symptoms. And so there may be something about this developmental shift in timing that could be adaptive in the context of more harsh or unpredictable childhood environment. But critically, there's a lot that we don't know about this. For example, potential long-term consequences. This is something I would be happy to talk more about if there's time in the Q&A. The second way that we've approached trying to understand the role of frontoamygdala connectivity in the developing brain as it relates to early life stress is by looking at the potential moderating role of individual differences in the strength of frontoamygdala connectivity among youth who have been exposed to various types of early life stress. This is work that was led by Ka Ip when he was a postdoc in the lab, and Ka was really interested in the effects of a very different type of stress. So here we were looking at deprivation, and deprivation that specifically occurred at the neighborhood level. And what Ka found is that frontoamygdala circuitry significantly moderated the effect of neighborhood deprivation on children's internalizing symptoms. So specifically, higher neighborhood deprivation was associated with higher internalizing symptoms at a one-year follow-up for youth who had more positive amygdala-medial orbitofrontal cortex coupling. So this is the group shown here on the right, where you can see a positive association between area deprivation and internalizing symptoms. But critically, when we broke down this moderation effect, we see that youth with a more mature coupling, so those on the left showing negative coupling, or those without significant coupling, were showing this potential buffering effect. So in these two groups on the left, what we can see is that there's no significant association between a disadvantaged neighborhood environment and internalizing symptoms, suggesting that something about individual differences in this important brain circuit may be helping to buffer the impacts of disadvantaged environments on children's mental health. So as a brief interim summary of this portion of the talk, a few key take-home messages. The first is that cortical limbic circuitry undergoes protracted development, and it's sensitive to early experiences such as stress or trauma. We have growing evidence that early life stress may alter the timing of cortical limbic development in ways that may be adaptive in the short term, but may also confer risk in the long term. And finally, individual differences in cortical limbic circuitry can buffer or exacerbate environmental risks. One thing that I want to point out is that here, there's still substantial variability in trajectories and mental health outcomes. So we think about this as a probabilistic relationship between early life stress exposure and mental health and brain development. So every child who's exposed to trauma is not necessarily going to show changes in brain development or mental health. And so one of the kind of key next steps in this area of work is to begin to parse that variability. So in the next set of studies, I want to share some of the work that we've been doing to better parse variability in the developmental timing of stress that may help us to better understand both neural and behavioral trajectories and outcomes among youth with significant stress or trauma exposure. So this is work that was led by Emily Cojodes and Lucinda Sisk, who were both PhD students in the lab. And here we recruited a sample of 120 young adults from the broader New Haven, Connecticut community. We administered a trauma interview that we developed called the Dimensional Inventory of Stress and Trauma Across the Lifespan, or the DISTAL. And this was specifically designed to ascertain nuanced dimensional features of stress exposure across the lifespan. So here, the critical measure that we used for this, for the next two studies that I'll share with you, was really the developmental timing. So we have very precise timing all the way from prenatal stress exposure to present day. Lastly, all participants underwent an MRI scan where they participated in scans that included diffusion-weighted neuroimaging that allows us to look at white matter tract connectivity, so a structural measure of brain connectivity, as well as a threat and safety learning fMRI task that allows us to look at functional activation in regions like the amygdala and the hippocampus when individuals are distinguishing between threat and safety. So on the right here, I show you just kind of an overall schematic of the task. So here in an acquisition phase, participants are learning to discriminate between a threatening and a safe stimulus. In the second phase of the task, we're then combining the threat and the safety stimulus to form a safety compound and comparing that with a novel compound to control for conditions such as external inhibition. What we did in this study was to apply latent profile analysis, which is a person-centered approach with the attempt to identify subgroups of individuals who may show more similar profiles of the developmental timing of their stress exposure. And we looked at neural activation in these 6 key regions that we know are critical to threat and safety learning as it relates to trauma-related disorders. So what did we find? So here we found that we were able to identify 3 robust subgroups that differed in the stress timing and threat to safety discrimination. And so just for the purposes of summarizing here, I'm showing a contrast of brain activation in these 6 regions for a contrast of threat versus safety during the fMRI task. And we were able to identify 3 subgroups, specifically a subgroup that showed lower stress exposure overall, higher activation to threat, and lower activation to safety. The second subgroup of participants showed moderate stress exposure, specifically in middle childhood and adolescence, lower activation to threat, and higher activation to safety. And the third subgroup showed higher overall stress exposure with very little threat and safety discrimination. So this third group looks very similar to much of the literature in this area, which has shown that stress and trauma exposure can interfere with the ability to effectively discriminate between threat and safety in the environment. And this is thought to be a core mechanism involved in post-traumatic stress disorder. But critically, when we looked at the mental health of symptoms of these 3 groups, we found that it was the individuals in subgroup 2 who were showing the lowest anxiety in adulthood. And so really interesting, it may be that in combination with exposure to stress during these specific time periods, the ability to successfully differentiate between threat and safety at the neural level is really important for promoting resilience. So far what I've shown you is very focused on the specific cortical limbic circuitry. We also wanted to understand broader implications, since we know that stress and trauma exposure can have wider spread effects on large-scale brain networks. Here we looked at structural development of white matter. We know from the broader literature that early life stress is associated with alterations in white matter volume, connectivity, and microstructure, and that these white matter alterations partly mediate the impact of stress on behavior and mental health. And critically, there's been evidence for divergent directional associations between stress and exposure and white matter connectivity across various studies. So here we had approximately 100 of the same adult participants who had completed the distal as well as the neuroimaging data collection. Stress exposure and white matter tract data were submitted to an analysis of sparse canonical correlation, and we repeated this process 10,000 times in an effort to increase the robustness of our results. Next, we examined the median correlation strengths and covariance that were explained from the resulting modes, and we examined how latent variants representing adversity exposure and white matter connectivity were associated with psychopathology. So in order to decide which canonical modes to examine, we looked at the total covariance that was explained by each canonical mode, as well as the correlation strength of each canonical mode. Mode 1 explained the greatest amount of covariance and had the highest correlation strength. So I'm going to show you the results from Mode 1 today. So before I jump into the results, I just want to orient you to this plot. So on the left, we have variables that are loading onto the stress exposure variant, which is highly correlated with the white matter latent variant here. I'll show the variables that load most strongly onto each of those variants, suggesting that these variables may be associated with each other. So first, on the left, the stress exposure loadings fall quite neatly between the ages of 3 and 8, suggesting that stress exposure at this stage, more than a particular year of age specifically, is linked with differences in white matter connectivity. Second, the loadings for the white matter tracts fall along a consistent pattern that seems to be distinguished by function. So these tracts highlighted in orange are involved in core sensory motor functioning, projecting from the brainstem, thalamus, and pontine nuclei to cortical regions. Conversely, the tracts that I've highlighted in purple represent corticocortical and corticolimbic tracts, connecting regions like the striatum to the orbital frontal cortex and frontal cortical regions across hemispheres. So taken together, these findings suggest that higher levels of adversity exposure during early childhood are associated with weaker white matter connectivity among corticocortical tracts, but higher white matter connectivity among sensory motor tracts. And these findings really suggest that the ways that stress exposure can impact brain development may diverge by tract function. Finally, we wanted to test whether any of the variants that we'd identified based on stress exposure and white matter connectivity were associated with mental health symptoms. So we found that the variant representing white matter tract connectivity was negatively associated with post-traumatic stress disorder symptoms, suggesting that these brain-wide differences in tract connectivity may relate to longer-term mental health following trauma exposure. So taken together, we see consistent with the broader literature that higher lifetime stress exposure is linked with weaker neural threat and safety discrimination. However, among individuals with moderate stress exposure during these specific periods of middle childhood and adolescence, higher ventromedial prefrontal engagement during safety and lower subcortical reactivity to threat may help to foster resilience by supporting individuals in successfully distinguishing between threat and safety in their environments. Finally, we show that stress exposure during preschool and middle childhood periods may differentially shape the development of sensory motor tracts versus cortical tracts. So taken together, these findings suggest that the developmental timing of stress and trauma matters in terms of environmental risk and resilience. In the last portion of the talk, I want to share a bit of work that we've been using to think about how we might begin to apply these findings from developmental neuroscience to better inform interventions that are tailored based on factors like developmental stage and environmental profiles of stress exposure. So here we focused on how we might begin to tailor interventions based on what we know about the neurobiological development that's associated with threat and safety learning, given the critical role of this process following stress and trauma exposure and in psychopathology. So just to provide some brief context about the landscape of psychosocial treatments, cognitive behavioral therapy and trauma-focused cognitive behavioral therapy are gold standard approaches to pediatric anxiety and stress-related disorders such as PTSD. And these are approaches that aim to reduce fear through gradual and systematic engagement with fear-provoking stimuli. Although evidence-based treatments, including in combination with pharmacotherapy, can be highly effective for many children and adolescents, a significant proportion of youth do not benefit sufficiently from the best current evidence-based treatments that we have to offer. And one thing that I've thought a lot about is that exposure therapy is really based on principles of fear extinction. And we know from research in both rodents and humans that fear learning and extinction undergoes marked changes throughout childhood and adolescence. So as one example, cross-species evidence shows that adolescence is characterized by diminished fear extinction. These findings highlight the potential for developmental research to inform approaches to optimizing fear reduction for specific developmental stages. So this approach is really based in the neurobiology that we know is underlying the importance of threat and safety learning and efforts to optimize fear reduction in specific developmental stages. The ventromedial prefrontal cortex and interactions with the amygdala play a critical role in fear extinction, and these undergo protracted development. This may relate to the patterns of diminished extinction during adolescence that have been shown in cross-species work. It's been proposed that safety cues, such as those in condition inhibition paradigms, may help to augment fear reduction. So here on the top, I represent a traditional extinction paradigm, and on the bottom, a safety cue that really explicitly predicts or represents safety that's separate from a threat stimulus. So these safety cues are overly trained to signal the absence of threat. And importantly, this type of learned safety really contrasts with the type of safety learning that's learned during extinction, when the same stimulus is conferred with competing threat and safety representations. So based on key distinctions between these types of safety cues, we hypothesize that safety cue learning may rely on different neural mechanisms than extinction in a way that could be leveraged to enhance fear reduction during adolescence. So because the hippocampus supplies critical information about the degree of safety or threat in the environment via direct projections to the basolateral amygdala and indirect projections through the medial prefrontal cortex, we hypothesized that safety cue learning would involve the hippocampus and may potentially bypass or augment this prefrontally mediated circuitry to work to reduce amygdala reactivity through these direct and indirect projections from the hippocampus. This work was led by Paolo Odriozola and Sahana Kribakaran, who were also doctoral students in the lab. And here we're using the same paradigm that I've already showed you with the goal to really understand the neural mechanisms that might underlie this process. So in the analyses that I'll show you next, we're focused on this condition where we combine the threat cue and the safety cue. This safety compound is never paired with the aversive stimulus, and the goal is that participants learn that the safety compound is effective in inhibiting threat or fear. So we had the really unique opportunity to collaborate with Heidi Meyer and Francis Lee on a cross-species investigation of the neural mechanisms of safety cue learning. We first examined whether safety cues reduced threat-like behavior and reactivity using galvanic skin response in humans, shown on the right, and by measuring freezing behavior in mice, shown on the left. As predicted, we found a linear decrease in threat reactivity across species, such that reactivity was highest to threat, lowest to safety, and intermediate to the safety compound condition, suggesting that the presence of the safety cue is effectively reducing or inhibiting fear-related reactivity, even in the presence of a threat cue. As shown here, we were really interested in interactions between the hippocampus and potential regions that might be involved in safety cue learning. So we examined hippocampal connections with the dorsal anterior cingulate, or the prelimbic cortex in rodents, the ventromedial prefrontal cortex, or the infralimbic cortex in rodents, and the basolateral amygdala. And in human participants, I'm showing on the right here that participants showed elevated connectivity between the hippocampus and DACC to the safety compound relative to the threat cue. In mice, Heidi and Francis used vibrophotometry and found a very similar pattern. So consistent with our findings across species, these results suggest that interactions between the hippocampus and the DACC may be important for this type of condition inhibition. Critically, we found that this type of safety cue learning did not depend on connectivity with the ventromedial prefrontal cortex or the basolateral amygdala, significantly differentiating this approach from more traditional attempts at fear extinction. So we next examined this in adults with significant trauma exposure. We found that safety cues were just as effective at reducing skin conductance response among adults exposed to trauma as they were among adults not exposed to trauma. However, the brain showed alterations during safety cue learning in regions that included the hippocampus, amygdala, and dorsolateral prefrontal cortex. We found that conditioned safety signals reduced skin conductance response in the overall sample, and although exposure to a higher number of traumatic events was associated with elevated skin conductance across all conditions, it did not differ between threat in the presence of conditioned safety relative to threat alone in a trauma-related manner. So these findings suggest that while conditioned safety signals may reduce fear in the presence of threat, even among individuals exposed to trauma, this neural circuitry involved in safety signal learning is in fact sensitive to trauma exposure. We next examined safety cue learning in youth with interpersonal trauma exposure. This work was done in collaboration with colleagues Keely McLaughlin and Steph DeCross at Harvard. Here we found that following trauma, both youth with and without trauma exposure successfully learned conditioned safety. And here we determined this using self-report of contingency awareness. So we found this to be very promising that even youth with trauma exposure were successfully able to learn the association between the safety cue and threat. A repeated measures analysis revealed a significant three-way interaction between trauma exposure and age, such that among older youth, those with interpersonal trauma exposure, shown here in orange, relative to those without interpersonal trauma exposure, shown here in blue, showed diminished left anterior hippocampal activation in response to the safety compound relative to the threat cue during the first testing run. And here I'm breaking this down just for purposes of visualization based on a median split of age, but all analyses were conducted on the continuous age-related data. So here we find evidence for age and trauma-related differences in hippocampal activation during safety cue learning in youth. We also examined potential differences in subregions of the amygdala and found that youth with trauma exposure exhibited more centromedial amygdala activation during safety cue learning relative to youth without trauma exposure across both testing runs. Lastly, there was a significant interaction between trauma exposure and age for connectivity between the hippocampus and the subgenual anterior cingulate cortex during safety cue learning. So among youth with trauma exposure, shown here in orange, hippocampal ACC functional connectivity decreased with age. By contrast, youth without interpersonal trauma exposure showed elevated hippocampal ACC functional connectivity with age, suggesting a potential alteration in age-related trajectories of safety learning at the neural level among youth with trauma exposure. Given these findings, we aim to test a moderated mediation model. We found here that hippocampal ACC functional connectivity mediated the association between interpersonal trauma exposure and post-traumatic stress disorder symptoms in an age-specific manner. So specifically among younger and older youth, so those below 12 years of age and above 17 years of age, but not among youth between 12 and 17, right hippocampal ACC functional connectivity during safety cue learning mediated the association between trauma exposure and PTSD symptom severity. Trauma exposure was associated with more PTSD symptoms, as we would expect, whereas trauma exposure was associated with more hippocampal ACC functional connectivity among younger youth. The opposite pattern was observed among older youth. So hippocampal connectivity was negatively associated with PTSD symptoms in older youth, but was not associated with PTSD symptoms in younger youth or in the overall sample. And so while there's still a lot to unpack here, this work suggests that these regions may play a critical role in mediating the association between trauma exposure and mental health at particular developmental stages. So we find that the circuitry supporting safety cue learning really differs from the ventromedial prefrontal amygdala pathways that have been implicated in traditional extinction. We think that this may have important implications for periods in childhood and adolescence when extinction is diminished and corresponds to weaker ventromedial prefrontal amygdala connectivity. And so we've put forward a model whereby we may be able to leverage knowledge of these mediational pathways, as well as potential moderators like developmental stage and trauma exposure, to better inform approaches to optimize fear reduction among youth who are exposed to trauma. This is work that we're continuing to explore. I just wanted to briefly share a future direction before I wrap up. So here we're really interested in thinking about how can we begin to target interventions for individual youth who have been exposed to trauma. So in this work, we're leveraging large-scale data from publicly available resources to apply normative models to identify individual level changes in cortical limbic circuitry development and testing the effect of treatment among youth exposed to trauma. So child and family traumatic stress intervention, or CFTSI, is an evidence-based approach to reducing PTSD and even preventing the onset of PTSD among youth who have recently been exposed to a traumatic stressor. This was developed by Steve Marins and Carrie Epstein at Yale's Child Study Center, and this work is in collaboration with Carrie, as well as Carla Stover and Taylor Ketting. So here, families receive 5 to 8 sessions after a recent traumatic event, and CFTSI really focuses on increasing reflective capacity to observe trauma-related reminders and symptoms, enhancing caregiver-child communication, and helping children and caregivers to develop coping skills. A number of trials have shown that children are less likely to meet partial or full criteria for PTSD following a successful course of CFTSI. However, we don't know the neurobiological mechanisms through which this treatment may be having its effect. So in this ongoing work, we're currently conducting MRI scans with children before and after they receive CFTSI to test the brain-mediated pathways by which this treatment may be helping to reduce PTSD. So taken together, in these studies, we see that early life stress alters brain development and affective behavior. We find evidence that developmental timing and the broader multifaceted context of children's environments matters in terms of thinking about the trajectories and the outcomes following trauma exposure. In particular, we've shown evidence that parsing variability in the developmental timing of stress and the nature of stress may be helpful for identifying subgroups of children with more homogeneous experiences. And these types of person-centered approaches may help to provide more specificity as well as to better delineate the neural mechanisms involved in stress and trauma exposure. Second, we find evidence that neural alterations during threat and safety learning seem to play a key role in linking early life trauma with PTSD and may be a prime target for optimizing interventions. And lastly, I've shown some preliminary work looking at how we might be able to tailor interventions based on neurodevelopmental stage and environmental profiles of stress exposure to help to augment the efficacy of interventions for youth who are exposed to trauma. And lastly, I just want to thank the many people who have contributed to this work, particularly my lab at Yale. They've been amazing to work with, and it's a real honor to get to work with them every day. I want to thank our collaborators who contributed to the cross-species and the SafetyQ learning work, as well as all of our funding sources, and you for your attention. And critically, I really want to thank the many participants and families that have contributed to this work. They've shared so much of their lives with us, and without them, none of this work would be possible. So thank you, and I'd be happy to take any questions.
Okay, thank you very much, Dr. G, for your insightful presentation and for sharing your findings on the developing brain under stress. Your work really highlights such an important topic that requires our attention and also continued research, truly providing valuable perspectives for both science and also practice. Okay, we will now take a few minutes for questions from the audience. We have one here from Karen, who asks, can you please explain how to adapt SafetyQ learning to therapy work?
Yeah, this is such a great and important question, and it's something that we're still working on. There's a lot that we need to do before we can really begin to successfully integrate this into clinical practice, but I would highlight a couple of ideas of where we see this heading. So one is that trauma-focused cognitive behavioral therapy and exposure-based cognitive behavioral therapy can be highly effective, but involve some component of exposure, which can be aversive. So of course, we tailor this developmentally, we approach it gradually in therapy, but there's aspects of it that are going to be aversive. And so one way in which we've thought about this is potentially leveraging SafetyQs to enhance the acceptability of treatment during these critical stages, as well as potentially to optimize avoidance or optimize approach versus avoidance during exposures. And so in the clinical literature, there's been some work showing that there's a really critical distinction between preventative safety signals and restorative safety signals. So preventative safety signals would be the type in which they prevent exposure to the feared outcome or the feared setting. Restorative safety signals, by contrast, allow people to experience the exposure and to experience the benefits of fear extinction while providing comfort and safety after the fact. And so if you're interested in this, I would encourage you to check out that literature on the integration of safety signals in clinical practice. And we, in particular, are really interested in testing how restorative safety cues might be helpful.
Okay, thank you so much, Dr. G, for the beautiful answer. We have another one here. At what developmental stages in the brain most vulnerable to stress exposure? And are those changes reversible easily?
Another great question. So a lot of work has shown that early in life is a particularly vulnerable time. There's some evidence that trauma that occurs earlier is worse, but increasingly we're seeing evidence that there's really these nonlinear patterns of brain development such that the type of trauma matters, and it seems to be a much more complicated picture. And so this is a long way of saying that there may not necessarily be a specific time period when trauma exposure is always worse, but it's likely to depend on the type of trauma exposure and the nature of the individual's brain. What we can say is that exposure to trauma during childhood and adolescence is naturally occurring during periods of heightened neuroplasticity. And so individuals at this time are likely more vulnerable to the effects, as we've seen in the literature, but also may have more potential for being amenable to interventions and for leveraging that plasticity for positive change. So some of the evidence suggests that, adolescence in particular can be a second sensitive window of development when the brain is especially susceptible to stress, particularly related to social stress, but also maybe this kind of second window for opportunity.
Thank you, Dr. G, for the answer. And we also have the next question. What individual differences were relevant to protect from the environmental risk?
Yeah, that's a really important question. I think some of the individual difference factors that we've seen be important are, I think of them as kind of different categories. So some of them are socio-ecological. They're factors that have to do with the child's environment. We know that supportive caregiving, parental warmth, are two really critical factors that can buffer against risk for psychopathology following stress and trauma exposure. But we also see moderating factors at the neurobiological level that suggest that individual differences in the brain and in how the brain is developing can also promote resilience. So here, just as one example, we find that individuals with stronger frontoamygdala connectivity have lower psychopathology symptoms following stress exposure. And one potential reason for this is that the prefrontal cortex plays this really critical role in regulating stress and amygdala reactivity, in supporting fear extinction. And so individuals who have this pathway that may be stronger as it relates to fear extinction and emotion regulation may really benefit from that in the context of resilience. In some of the newer work, we're trying to understand how this relates to threat and safety discrimination, but some of the findings that I showed today suggest that individual differences in the ability to discriminate between threat and safety are likely to play a key role in resilience as well.
Thank you, Dr. Chi, again for the answer. And we have another question coming. Were the changes in the white matter tracks correlated with functional connectivity and emotional or cognitive abilities?
Yeah, I'm so happy you asked that because that's actually what we're looking at now. In this study that I shared today, we actually only looked at the white matter. We looked at a couple of different metrics. And so we're really interested in how does that actually relate to the functional connectivity. And so right now we're using a metric called structure function coupling to better understand the extent to which functional connectivity is constrained by structural connectivity at the individual level. And what I can say so far is that we are seeing that structure function coupling exists for these key circuits in children and adolescents, but does seem to be affected by adversity exposure. So that's something that we're trying to unpack further. In terms of the cognitive differences or potential mental health differences, so we haven't looked at that yet, but we're hoping to use some of the data from the ABCD study where we have a much larger sample to look at variability in cognitive factors as well.
All right. Beautiful answer, Dr. G. We have another person asking and also saying, hi, Dr. G, thank you for the amazing presentation. Can you provide us with examples of safety cues that can be used in therapy?
Yes, great.
I think, yeah.
Sorry, go ahead.
You have already explained. Do you want to explain more on that?
I think what I would say is just that this is something that, we and many in the field are still working on and thinking about what is going to be most effective. But a couple of examples, because I think this is one of the hardest questions, is like, how do we actually begin to translate this? What are safety cues in ecologically valid settings? So one of the things that we have looked at is we just did a survey with children, adolescents, and adults and asked them about what people, what stimuli, what places they identify as safety cues in their daily life. And definitely among the most common answers for kids are caregivers. So not surprisingly, children are often turning to their caregivers as safety signals. When it comes to treatment, we're doing some work that's trying to look at how can we leverage caregiver presence to optimize fear extinction. We want to be careful not to interfere with fear extinction when caregivers are present. And then for younger children, certainly, kind of common childhood safety cues include things like stuffed animals, blankets. Adolescents have talked a lot about music and the role of peers. And then there's a lot of variability among adults. And so I think part of this answer is that it's likely going to vary and is something that individual therapists can work with individual patients to identify.
Okay, thank you, Dr. G. And maybe we will take one more question from the audience. Do you think sensitive periods can be reopened later in life?
I do. That is something that we don't necessarily know how to do instrumentally at this stage, but I think there's been a lot of incredible work in cross-species research, including work from Takao Hench's group, showing pharmacological interventions that can increase plasticity and reopen sensitive windows. I think for me, one of the ways I've thought about this in terms of human development is that the sensitive windows themselves may not be closing. There may be variability in the extent of plasticity across sensitive windows, but I think there's always room for plasticity. And in this type of work, I really conceptualize this as being about sensitive windows and the degree of plasticity, not about critical windows where there's a closing or kind of a period after which we can't intervene. And so I think it's important to emphasize that potential for intervention and resilience is always there. And in some of this work, we're looking at adolescence and adulthood as periods in which we may be able to use social support to really kind of promote healing and reinvigorate that plasticity.
Okay. All right. Once again, thank you so much, Dr. G, for the gorgeous presentation. We are really honored to have you here today with us. And we will now move on to our next speaker. But before that, maybe we will have a quick break.
Thank you so much.
We will see you again later. Okay. Thank you so much, Dr. G.
Hello, I think I'm here. Does anyone hear me?
Yes, hi, Professor Contrada. Yes, my name is Clarence, and I will be your host for today. So, and yeah, so hello everyone. Welcome back from your break. My name is Clarence, and I will introduce you to our next speaker, which is Professor Richard Contrada. Professor Richard Contrada is a health psychologist and professor in the Department of Psychology at Rutgers, the State University of New Jersey, where he is also a member of the Institute for Health, Healthcare Policy, and Aging Research. He has conducted extensive biopsychosocial research on cardiovascular disorders and related medical conditions, with over 100 publications supported by the National Institute of Health, American Heart Association, Charles A. Dana Foundation, and Fetzer Institute. Professor Contrada has served as co-investigator and project director of a National Institute of Health Center promoting health in African Americans and co-director of a National Institute of Health Mind-Body Center. He is also a fellow of the Society for Biopsychosocial Science and Medicine, the Academy of Behavioral Medicine Research, and the American Psychological Association. Professor Contrada will present his paper with the title Cognitive Affective Traits, Psychopathology, and Cardiovascular Disease, the Role of Stress-Related Mechanisms, which examines how stress-linked psychological factors like depression, anxiety, and PTSD contribute to cardiovascular risk. It is my pleasure to hand over the session to Professor Richard Contrada. And Professor, the floor is yours.
Thank you very much for a very warm and generous introduction. I'm very happy to be speaking with you, especially after 15 minutes of finding out that I still don't know how Zoom works. Let me see if my slides will work. I don't suppose by any chance you see my slides?
Yeah, we can see it, Professor.
Very good. All right. So going to be speaking about personality and mental disorders and their relationship to heart disease, with a focus on the mechanisms that may explain those relationships. And this is a talk that I put together with my former student and now colleague, Dr. Eric Fedorenko. So I'll give you an overview of the talk, and the talk itself is an overview. It's an overview of sort of the health psychology perspective on stress and its role in physical health. So after some background, we'll get into the epidemiology. That's the starting point for a lot of health psychology. Then mechanisms that explain or may explain how risk factors identified in epidemiologic research may contribute to heart disease. And then interventions, which make use of this information. The background here on me is that I was working in this area as a grad student and a postdoc, and then moved on to other areas of health psychology, and then was asked to do a review paper of the area. And it was an interesting opportunity to revisit the field. I hadn't been following it very closely. I found that the epidemiology had remained the same, both in terms of methodology and the findings in this area, and that the mechanism work was evolving in some pretty interesting ways. But the intervention work has been disappointing. So kind of a mixed reaction. After covering that, I'll talk about some developments and some of these possibly interesting new ways to think about mechanisms in this area. So first, a little bit about cardiovascular disease. These disorders were not very common in the early 1900s, but after that ascended to become a major factor in morbidity, death, disability, and quality of life in most industrialized nations around the world. And this happened in part because infectious conditions came under control, allowing people to live long enough to develop heart disease. Going forward, with most populations around the world aging, we can expect that there'll be more people spending longer periods of their lives with cardiovascular disease. So a big problem is getting bigger. There's a number of cardiovascular disorders. I'll be focusing on coronary disease because it's quite prevalent, and it's the basis for several of the other disorders. So the starting point is, the nature of the heart. The heart is a muscle, and like all muscles, it demands a lot of oxygen to stay alive and to do its work. And it gets that oxygen through the coronary arteries, which supply the heart itself with oxygen-rich blood. Coronary artery disease, also known as atherosclerosis, involves a narrowing of those coronary arteries and a reduction of the flow of oxygenated blood into the heart. And this happens because of changes in the blood vessel walls, because of inflammation, the accumulation of fatty substances, other materials, and actually a host of other very specific different kinds of biological mechanisms. Here you see a picture of the heart with the coronary arteries highlighted in red, and you can see they come off of the aorta, which is that major vessel up on the left that supplies the entire body with oxygenated blood, a good fraction of that going to the heart. Atherosclerosis, or coronary artery disease, is very complex. It has many causes, it's progressive, and it has many manifestations. Some of you may be surprised to learn that it is believed to begin in the first decade of life, and it can proceed for decades silently because it has no symptoms in the early stages. Those symptoms occur when the narrowing of those arteries and the reduction of oxygen supplied to the heart becomes severe enough that the heart is now affected, in which case we now have coronary heart disease. There are several forms of coronary heart disease. Some of them are listed here. Angina is a painful syndrome due to inadequate blood flow, which is referred to as ischemia. Myocardial infarction, or heart attack as it's commonly referred to, involves permanent tissue damage, whereas angina can be relieved sometimes and often without tissue damage. Cardiac arrest is one of several syndromes that can cause sudden death, which is what it sounds like, unexpected cardiac mortality for cardiac reasons. And heart failure is more systemic disorder. It occurs when the heart is unable to supply the body with oxygenated blood, and so the entire body is affected by inadequate circulation. So with the rise of cardiovascular diseases in the 1900s, epidemiologists began to focus more and more on the identification of variables that predict the future onset of these conditions. And these are known as risk factors. And you can see here 4 major risk factors that were identified early on, probably familiar to all of you. And then a long list of additional risk factors, and the list actually goes on. This is only a partial list. What happened is that it was discovered that even taken together, these risk factors can only account for a fraction of the new cases of heart disease. And so that led to a changing perspective and a wider search for different kinds of coronary risk factors. So these risk factors are known as the biomedical risk factors. And the next set are suspected psychosocial risk factors or protective factors. And heading the list is psychological stress. And it heads the list for 2 reasons. One is that this is probably the disease that is most strongly related to psychological stress, the physical disease that has that status. It seems to play a very important role. But secondly, psychological stress actually runs through all of these other psychosocial risk factors. So, all the more reason for it to receive a lot of attention. And just a note on terminology. These risk factors are referred to often as biomedical, but I think, if you look at these, you could see that there are obvious behavioral and psychological aspects to these variables. So there's a changing perspective now where not so much of a focus on what's biomedical and what's psychological, given the difficulties with that distinction, and instead of focused on what actually is modifiable and can help deal with the problem. So what is stress? It's been the subject of some debate and disagreement. I think of it as a broad research area or a complex phenomenon, so I can avoid the problem of defining stress as a specific technical construct, and instead refer to these four major components of stress, beginning with stressors, which are environmentally real conditions and events that set the stage for possible stress. And then some psychological processes that translate those events and conditions into a stress reaction, including cognitive, emotional, and behavioral processing and reacting to the perceived stressors, which then splits off into one path, which is a direct effect on disease. And so many of those risk factors we just looked at, even the biomedical ones, are actually influenced by stress. This other path is the one we're going to focus on, which is the biological path, through which psychological responses to stressors have biological consequences that influence disease. And of course, I keep saying disease, I mean physical disease as a health psychologist, but of course, mental disorders are as well identified with these processes or consequent to these processes. Also, part of the stress construct is that it is a multi-level idea, and it is therefore studied by multiple disciplines. So we could speak about global forces in the world that set the stage for some stress, macro-social and cultural factors in different nations and different regions, such as economics, changing gender roles, race, and ethnic issues that also set the stage, some of them reflecting the global forces just mentioned. And then we get down to where sort of the research is as far as health psychology, which is the environmental, psychological, and biological levels of analysis. So it's a multi-level idea and phenomenon. And to give you sort of the bottom line on some of the epidemiology, it appears as though environmental stressors do predict and probably cause coronary disease. And more specifically, it seems as though chronic stressors predict coronary artery disease, the slow developing disorder of those coronary arteries, whereas acute short-term stressors appear to trigger coronary heart disease, creating cardiac events in people who already have coronary artery disease. It's not a perfect mapping one-on-one, but the center of gravity does seem to point in terms of that kind of distinction. Here are some of the major chronic stressors that have been implicated as predictors and likely causes of cardiovascular disorders. I won't read them to you. I'm sure all of these are familiar, and especially childhood obesity, which is well represented by experts on the topic in this conference. And so this is part of the epidemiologic knowledge that we now have, that these are risk factors and problems for their influences on heart disease. Here's a sort of categorization of the acute stressors that have been implicated that seem to create cardiac events in people with artery disease. These range from minor daily stressors, sometimes called hassles, episodes of anger that people encounter in just everyday life, as well major stressors, such as bereavement, loss of a loved one, and even more severe stressors, trauma, with or without PTSD. So each of these three seem to trigger cardiac events in people with coronary artery disease. And as an example down below, you can see results of a study that showed that heart attacks often can occur shortly after an episode of just everyday anger. So here you see a greater likelihood of a heart attack soon after an anger episode, not so great a likelihood later on as the anger subsides. Now, the effects of stressors on cardiac risk vary from person to person. And so that raises the question of why. Why is there this variability? And this question has generated a lot of research on what is referred to as a set of stress moderators. Stress moderators are factors that either increase or decrease the impact of stressors. And these can be aspect of the person's social environment, or biological characteristics. Here are some of the best understood social moderators. Having a large number of social connections seems to protect against cardiovascular problems, whereas being socially isolated is risk enhancing. Getting into the quality of the relationships that make up a person's social network, it turns out that ambivalent social ties may be more risk enhancing than emotionally negative relationships. Having a sort of mixed emotional orientation toward one's friends and family seems to be more risk enhancing. And loneliness, which is the perception of being isolated when one is actually in fact not isolated, and also speaks of problems in relationships, is also risk enhancing. And last but not least, social support. Functions served by members of one's social network, including emotional support, tangible support, informational support, and the like, seem to buffer the effects of stressors. And you see an example of that down below, where heart disease itself is viewed as the stressor. And it, in this study and others like it, turned out that emotional support reduced the incidence of cardiac events in these patients. So it seemed as though it protected against the stress of the disorder. But our focus here is on personal moderators, and in particular personality and psychopathology, although there's a long list of these that we won't be able to get into. The idea that personality is related to physical disease is an ancient idea. It goes back to Hippocrates and Galen working in the 400s and 200s BCE, who together or separately, but in coordination theoretically, identified a number of emotional characteristics referred to as temperaments that seemed related to physical disease in their observations. And they're listed here. It's interesting that this is actually a pretty good start if you wanted to describe how people are emotionally. It's not a bad set of descriptors for that. In addition, it could be the table of contents of a scientific journal in health psychology, because all four of these characteristics are the subject of much research on psychological factors in health. Sadness or depression, optimism as a protective effect. Choleric refers to an easily angered temperament, which we'll be talking about, and being emotionally inexpressive has been studied as well. So Hippocrates and Galen were prescient in their observations. Others who came after had similar observations. So some of the prominent physicians of the 1700s and 1800s, of course, in psychosomatic theory, in the psychoanalytic tradition, there's a body of theoretical work on this possibility. In the more modern era, the mid-1900s, this notion was taken up by two cardiologists, Friedman and Rosenman. And so this begins sort of wave one of these risk factors involving personality. And it begins with the type A behavior pattern, which I think maybe is still a familiar idea to many of us, although not as popularly used in common language as it once was. Friedman and Rosenman made a number of informal observations in their cardiology practice in California, including the observation that the seats in their waiting room seemed to wear out only in the front, as though the patients were literally sitting on the edge of their seats out of impatience, waiting to see the doctor. And their worst patients made appointments early in the morning and parked facing out, presumably so that they can make a quick getaway and get back to work. Most of them were business executives. Here you see some caricatures of type A characteristics. Here you see the same for type B behavior, which is the more relaxed and easygoing counterpart to the type A pattern, which is not a risk factor. In fact, it may be protective. So the original concept was that these formed a coherent behavior pattern: excessive achievement striving, impatience, competitiveness, anger and hostility, and vigorous behavioral movements. And these were conceptualized, this pattern was thought of as a response to challenges and stressors. And in fact, it was best measured by a challenging interview. And it was found to be a risk factor, a predictor of coronary disease. But later work identified anger and hostility as the most damaging component of the type A pattern. And here it's important to note that hostility has something to do with aggressive behavior, but it's more about cynical attitudes, attitudes of mistrust, sort of negative worldview or mindset about people in the world. The evolving focus on anger and hostility then changed, and again, the concept was broadened to include other negative emotions. And so the term negative affectivity is used to describe the tendency for anger to cluster together with anxiety and sadness, and also to be related to the future development of heart disease. Another term that's rather similar is neuroticism. So now the focus is on cognitive affective traits in general. Most recently, there's interest in what's called dispositional optimism, which is a trait that involves a generalized expectancy for good outcomes, if you're an optimist, or bad outcomes, if you're a pessimist. And this is also a mindset like hostility, except it's a positive mindset, and it's more about the person's own future than about other people. So that's the list as far as personality factors, which we'll come back to, but now let's talk about psychopathology. So as it turns out, depression is the best established mental disorder as far as its relationship with cardiovascular disease, although anxiety is attracting a lot of attention, as is trauma and PTSD. They just sort of have come later historically as focuses of this work. Here you see results of a study I'll talk about briefly. This and other work identified clinical depression as well as subclinical depression as coronary risk factors. They appear to contribute to the initial development of disease. They're very common in heart patients, and they may also contribute to disease progression. And in this typical research design, patients who had had a myocardial infarction and a heart attack were followed, and the number of depressive symptoms predicted the length of their survival time after the initial heart attack in a very regular, linear fashion. So a couple of interim summary statements. These personality traits and mental disorders do appear to be cardiovascular risk factors. However, the fact that they co-occur, that they are often correlated, and the implications of their combinations and interactions have unknown implications. We know very little about this. In addition, we have to keep in mind that prospective associations, predictive relationships are correlational, and so third variables may be accounting for those relationships. And so the case for causality, which one would like to make to justify intervention and just to understand what's going on, would theoretically be strengthened by mechanistic research, research that answers the questions of how and why these prospective associations occur. Now, in health psychology, the term mechanisms has a particular meaning, and it especially did early on. It combines two different mechanism concepts. One is disease causation. In other words, we're talking about mechanisms of cardiovascular disorders, what causes them, and links to those disorders factors like personality and psychopathology. Another term for this is the etiology of the disease. So this is a biomedical concept for mechanism, but the term mechanism is commonly used in the life sciences to refer to a structure or system with a particular function, often an evolved structure or system. And that was less prominent in the way the term was used, with one big exception, early on in health psychology. And so when you look at mechanisms this way, you can sort them out into three general categories based on the final causal link. What comes at the very point where cardiovascular disease occurs. And so the first category, which is our focus, is the psychobiological category, where it is the direct relationship of stress biology to processes that cause heart disease in the first place or cause it to progress. That is the mechanism. So it's a psychobiological mind-body connection. And now we're referring to evolved systems of our bodies. The second set are health-related behaviors like smoking, diet, and exercise, where the link to disease that might explain the effects of personality or psychopathology is behavioral, smoking, diet, exercise, and the like. And thirdly, reactions to illness. These are also behavioral, but they come after illness has begun. And so you have behaviors like delaying seeking treatment when you have symptoms, or not following doctor's orders when you have a medical prescription. So those kinds of behaviors form a mechanism. So these three areas initially, and for some time, were rather separate and demarcated different areas of health psychology. So psychobiological mechanisms, this work has led to the realization that stress biology, while it's an evolutionary adaptation, it causes disease. It has this ironic negative effect of causing disease, even though it promoted survival early in our evolution. And here we're talking about the autonomic nervous system, the sympathetic adrenomedullary system, and the hypothalamic pituitary adrenal cortical system, sometimes referred to collectively as neuroendocrine systems. I'm sure you're all familiar with the autonomic nervous system, which has two branches. The parasympathetic on the left promotes the storing of energy and relaxation and digestion, so it's sometimes referred to as rest and digest. And the sympathetic on the right, so-called fight or flight system, which activates organs and systems and utilizes energy, mobilizes and utilizes energy. Autonomic activity often leads to hormonal activity. And here we're talking about hormones produced by the adrenal glands. We have two adrenal glands, one on top of each kidney. The inner portion is the adrenal medulla, which secretes adrenaline and noradrenaline, also known as epinephrine and norepinephrine. The outer portion of this same gland is referred to as the cortex, and it secretes cortisol. And so these are the stress hormones that are central to the mechanisms that we're referring to here. The fight or flight concept came to us, of course, from Walter Cannon, and it begins with a threatening event. This is a physical emergency in his work, transduced by the brain to activate the autonomic system, particularly sympathetic activity, the stress hormones. His emphasis was on the catecholamines, the adrenal medulla, and produces a set of physiological adjustments, as you see listed here, many involving the cardiovascular system. And Cannon's brilliant insight was to see that these reactions serve the function of supplying the vigorous muscles of the body with fuel, oxygen, and as well glucose, as turned out later, to support vigorous muscle activity that might be required to deal with a physical emergency, either fleeing from a combatant or fighting a rival or competitor. So sometimes we use the term fight or flight to respond collectively to all of these responses. So we have these two neuroendocrine systems that were adaptive in the short term, both evolutionarily and in our lives, sometimes when we have physical emergencies, that in the long term promote disease. The thing was, people weren't living long enough for the health damaging effects to develop. These processes can be studied in the field, naturalistic settings, as well as in the lab. In a typical laboratory study, the risk factor of interest, like type A behavior, would be measured initially at the beginning of a session or at a separate session. We would then establish the baseline physiology of the person. What are their neuroendocrine systems like at rest? Then a stressor would be introduced, and the elevation in, say, sympathetic activity would be a measure of stress reactivity. There are also protocols where there's a recovery period that follows, which is also of interest in this area. Here are some of the most common forms of stress that are induced in these studies: performance challenges, staging of interpersonal conflict involving the research subject, a speaking task, notably a standardized speaking task developed in Germany, the so-called Trier task, and emotional inductions that involve having the person recall or imagine an emotional episode and often to talk about it. Measures of stress reactivity include cardiovascular indices that you see there, the hormones that I mentioned. And it's important to note that most of them reflect heightened neuroendocrine activity. But heart rate variability is of a lot of interest nowadays because it reflects increased parasympathetic activity. So it's a healthy response, potentially, that counters the effects of sympathetic activity and adrenaline. Now, this is really sort of the core of the mechanism from a biomedical standpoint. Here are some of the pathogenic consequences of the stress response. At some point, you have to draw a line and say, all right, that was the stress response. Here are some of the sequelae of what comes later. And all of these connect directly to atherosclerosis, hemodynamic or cardiovascular changes in the heart muscle, and its electrical activity, inflammation, hematological events such as forming a clot, thrombosis, and effects on metabolism. So it is through these processes that the initial stress response, if repeated over a lifetime, can promote coronary atherosclerosis, and if they occur in a person with coronary atherosclerosis, can precipitate a cardiac event. And so there is, in fact, growing consensus that biological reactivity causes cardiovascular disorders. However, the role of personality and psychopathology is not quite so clear. It's promising, but it's not as clear. Interestingly, in some studies, reactivity in people with depression, anxiety in particular, is blunted rather than exaggerated. And both blunted, that is a small neuroendocrine response or cardiovascular response, both a blunted response and an exaggerated response, both of those have been linked to disease. So this points to the notion that we have neuroendocrine dysregulation rather than simply exaggeration. Here are some results from an illustrative study done early on. This was one of the first indications that anger and hostility may be the most risk-enhancing aspects of type A behavior. In the design, type A and B subjects were randomly assigned to interact either with a hostile competitor or a non-hostile competitor and to complete a number of video games. And here you see the results for systolic blood pressure. Now, the idea was that hostile competition activates two aspects of type A: anger, hostility, and competition. So we thought, well, that's where we'll see the biggest response among type A's. And we did. So over on the left, you see a pretty substantial increase in systolic blood pressure among type A subjects who were harassed. much more than that seen among type A's who were not harassed. That was as expected, but what we found was that there was no difference between type A's and type B's when they weren't harassed. These three are equivalent. And so simple competition did not distinguish type A's from type B's. It was only in the presence of hostility that occurred. So the same kind of pattern for adrenaline, which you see here, those three bars are statistically equivalent. In a non-laboratory study that represents a large number of these studies, something similar, not quite the same, was shown in healthy subjects engaging in everyday activities and hooked up so that their cardiac functioning could be followed. What we found was that when they were with someone talking to them, hostile people showed a greater heart rate increase than non-hostile people, but there was no difference when the subject was with someone but not speaking with them or was alone. So, loosely replicates that laboratory study, showing that there's something interpersonal about what arouses reactivity differentially in type A individuals. Turning now to studies involving coronary disease, that is, patients with coronary disease, as I've been mentioning, this work implicates stressors as triggers of clinical events and also can be done both in the lab and in the field. This was a study done actually in the hospital. Whoops. I don't know how to get the cursor going here, but here we go. So what you see here is that at baseline, before anything else happened, this patient showed a reduced flow of blood through one of the coronary arteries. It's not completely closed off, but coronary artery disease is present there. A mental stressor was introduced, and that blood flow was completely stopped. When the stressor was removed, once again, there was some limited flow of blood through that blood vessel. So obviously, pathogenic state that could trigger ischemia and angina and even a heart attack. Fortunately, none of that occurred in the study. And just one of many studies illustrating how stress can promote cardiac events, most likely, through this kind of process. The problem is that the blood vessels are changed by the coronary atherosclerosis process. And so rather than dilating, which is the normal response to stressor in those blood vessels, they paradoxically contract. Now, outside the lab, here's an example of a protocol that's been used. It measures the electrical activity of the heart and can pick up instances where the supply of oxygenated blood to the heart is not meeting the demands that the heart is placing on that supply. So the heart is deprived of oxygen relative to what it needs. And this is a case of silent ischemia if there's no symptoms. And so it's a dangerous situation for the person who doesn't know what's happening and doesn't have any cue to tell them they should relax, take an aspirin, which can help prevent a heart attack, stop doing anything if they're doing something physical, like shoveling snow, which is a common elicitor of heart attacks. And here you see the results of psychological assessments that were done simultaneously with the use of a diary, showing that ischemia was most likely to occur when subjects reported being frustrated, sad, or tense. So pretty strong implication that naturalistic everyday stress can promote ischemia and potentially heart problems. So with those illustrations and summaries, some caveats. Again, the co-occurrence of these traits and disorders, their combinations, interactions, and so forth are just unknown. And this is the major weakness of the epidemiology. We also don't know how best to conceptualize what elicits reactivity. The work is all correlational in humans and cross-sectional. So we don't know what comes first, the activation of personality or the biological activation. And so the link of reactivity to disease is actually mainly theoretical in humans. However, we do have some human work showing correlations where people who are strong reactors in these paradigms later develop more heart disease. And there's an animal model that's very well developed that shows that the experimental induction of coronary disease is possible if you stress animals, and you see it particularly among dominant animals, which very loosely might resemble type A individuals. So we do have some experimental evidence in animals, and it's all correlational in humans. Now, regarding the co-occurrence and combinations of these characteristics, there's very little work examining that. We did a study, a former student and I, Julia Batansky, looking both at aggressiveness and depression in a study where subjects were induced to experience anger. And what we found was interesting. Among those who were high in verbal aggression, the more depressed they were, the more of a blood pressure elevation they showed, exaggerated reactivity. Among those who were low in verbal aggression, the dashed line went the other way around, maybe an instance of blunted reactivity, because the more depression they experienced, the less of a blood pressure elevation they saw. So interesting possible interactions between anger and aggression on the one hand and depression on the other, but again, there's very little work like that. With regard to what elicits reactivity and how best to think about it, there's sort of two schools of thought. One is its stress, another is its emotions. Here you see results that support, looking at different emotions. This line is steeper than the other as it reflects a stronger relationship between pessimism on the left and a heart rate reactivity to the induction of sadness. Whereas with regard to anger, that relationship is less strong. So it suggests that there may be something specific about stressors that induce sadness that is relevant to optimism, pessimism, by comparison with stressors that induce anger, which are probably more relevant to people who have high levels of anger and hostility. But again, very little work looking at those kinds of distinctions. Okay, so moving to intervention research. It should strengthen the case for causality, right? If you modify the risk factor, experimentally manipulate the risk factor, and it's a causal influence, you should see a reduction in disease. Pretty straightforward. So this kind of work mostly has been conducted in heart patients. It's not practical to reduce depression and anxiety for purposes of heart disease. You need a very large sample. So in heart patients, and the results early on were positive. It did seem as though modification of type A behavior prevented a second heart attack in these patients. However, a couple decade or so ago, the ENRICH trial developed very disappointing results. This was a multi-site trial in which cognitive behavioral therapy in post-MI patients was found to improve depressed mood and to increase social support, but there was no improvement in disease outcomes. So that was very disappointing. And it's been followed by a lot of work that tends to say the same thing. So there have been now many studies looking at interventions to reduce depression or anxiety in patients, clinical depression and clinical anxiety. And these interventions benefit mental health and quality of life, which of course are worthy goals in themselves, but there's limited, inconsistent cardiac benefits. Very variable kinds of interventions have been used, which is one of the problems. Different populations, different measures, and different results. So the overall effect sizes are not significant. So what does this say about disease causation, much less the practical problem of helping these people? Does it say that the mechanisms for initiation of heart disease differ from those for progression? It seems like that's a possibility. A qualification regarding intervention is that cardiac rehabilitation works. So we do have interventions that work, that reduce the effects of stress, most likely, on heart disease in patients. And there are social support interventions that have similar effects in multiple chronic disease populations, including heart patients. So it's not as though we have no tools to use, but these typically incorporate behavior change and stress reduction. So we can't really say that it was the biological pathway that was modified by the rehab or the social support. And personality and psychopathology are not targeted in these kinds of interventions. So we don't know if we're addressing the problem of mental health causing a physical health problem. So with that as a summary of where the field has gone and some questions, here are some developments and possible directions. The first is work looking at the interplay of biology and behavior. This is relevant for a number of behavioral risk factors. I'm just going to talk about obesity very briefly. So here is a diagram I took from a paper by Janet Tomoyama, which I strongly recommend. It's an annual review of psychology paper, where she discusses multiple mechanisms that allow stress to promote obesity. And just, to break that down, she talks about stress lowering cognitive efficiency, including reduced executive function, impaired self-regulation and impulse control, leading to overeating, behavioral effects, such as the effects of stress on the consumption of comfort foods, as they're called, which are typically calorie dense and unhealthy, physiological sequelae of stress, of course, many of them involving the physiology of fat tissue, which is fascinating. So fat tissue may promote the secretion of more cortisol, adding to whatever is being produced as a result of stress. In addition, we actually know that cortisol promotes the accumulation of fat around the midsection of the body, where it's particularly unhealthy. So a back and forth between fat tissue and cortisol seems to be part of the picture for stress and obesity. And inflammation. Fat tissue attracts and interacts with inflammatory processes. And last but not least is the social dimension, where weight stigma and body shaming act as stressors and may exaggerate all of these mechanisms. Another development that I found interesting, alternative models of depression and their implications for intervention. This would be a sort of typical psychometric conception of depression, in which depression would be viewed as a latent phenomenon, a latent construct in the mind, in the brain, and as the cause of depressive symptoms. The point here is that these symptoms correlate with each other only because they are all caused by the same underlying factor, whatever we think of it as. They don't interact with each other. They are common outcomes of a single underlying disorder. Whereas in network models of depression, this is not the case. So this is a diagram taken from a paper by Borsboom and Kramer. And the key here is that you have causal pathways between depressive symptoms, as well as between anxiety symptoms. It's a transdiagnostic model, and also bridging the two so-called disorders. A dynamic view in which symptoms interact with each other. How this plays into treatment? Well, often it's the case that successful treatment of depression involves a reduction in negative thoughts and negative affect, not so much of a reduction in fatigue and sleep problems. So there are residual symptoms of fatigue and sleep problems. So that persists beyond intervention, stressors occur, and the notion put forward by Carney and Friedland is that this exaggerates a vicious cycle. So you have residual sleep problems promoting additional fatigue, impairing executive function, undermining emotion regulation, promoting worry and rumination, which further exacerbate sleep problems, and so forth and so on. It's a very interesting dynamic. It's kind of a post hoc explanation, though, for why depression, when reduced, doesn't seem to prevent recurrent disease. And so, work would need to be done to validate this kind of thinking. So-called kindling hypothesis, that fatigue and sleep symptoms are persisting at a low level, and then they are rekindled by a stressor in this manner. Then very quickly, conception of PTSD as a systemic disorder. So this is a proposition put forward by David Krantz, who suggests we think of the biological correlates of PTSD as PTSD symptoms, specifically hormonal, immunological, and metabolic changes that are associated with PTSD, he is saying should be seen as diagnostic criteria. And that would have many implications for integrated treatments, treating people sooner than they might otherwise be treated. For example, I won't go through this diagram except to point out the key is here, where among the symptoms and diagnostic criteria for PTSD would be things like inflammation, insulin resistance, blood pressure elevations, and so forth. So an interesting notion that we'll see how it turns out in empirical work. Finally, among these recent developments, brain-heart interactions. I was not aware until recently that the term health neuroscience has been coined to refer to the role of the brain in many of the kinds of phenomena we've been talking about. And there have been findings to support this kind of view, not surprisingly, I suppose. So for example, activity of the same corticolimbic regions that are involved in threat, stress, and emotion have been linked to cardiovascular responses to lab stressors. They're also implicated in mental disorders. In other words, you see that activity in people who have exaggerated cardiac responses to stressors. You see that brain activity in people with mental disorders, and treatment seems to reduce activity in the same regions. So this suggests that the same CNS processes may underlie both mental and physical disease. There's been very limited work examining the treatment effects that occur on the brain, stress reactivity, and disease. You see pairs of these, but not looking at all of this comprehensively. Here's an example of a study done by the Pittsburgh group headed by Gennaros et al., Gennaros and his colleagues, in which activity of some of these brain areas was significantly correlated with blood pressure elevations, which were markers of reactivity to a stressor. So just one example of that kind of study. This paradigm has been expanded to include disease markers. So here you see an example of a study in which activity of the anterior cingulate cortex appeared to produce, it was a correlation, atherosclerosis through its influence on inflammation, looking at interleukin-6 as a pro-inflammatory cytokine. So completing the paradigm with the inclusion of disease markers, albeit often, if not always, in a cross-sectional kind of design. This kind of thinking has been expanded to a multi-level approach in work on the role of childhood adversity on physical health. And this diagram is taken from a paper by Nusslock and Greg Miller at Northeastern. And I won't go through this, but it shows the potential for linking macro level events that promote childhood adversity to inflammatory processes that underlie both depression, as has been discussed and will be discussed in this webinar, ultimately leading to problems in the reward centers, and so drug issues, as well as mental and physical disorders. This was my rendering of their diagram. Don't hold them to it. And so you can see the pathways that they're discussing, and some of these arrows I put in because they are supported by research that wasn't addressed in their paper. So that's a very welcome sort of integrative multi-level framework in this area. Now, a quick digression on event-related potentials, which I think may be useful biomarkers for this work that have not been utilized a tremendous amount. So these are electrophysiological brain responses to a stimulus, usually a discrete stimulus. They index various brain functions, so different, what are called ERP components, different waveforms, such as you see in this slide, seem associated with various kinds of cognitive or emotional processing of stimuli. The method has a lot of advantages, not the least of which is cost by comparison with fMRI, and also temporal resolution. And it has possible application in several different ways as transdiag markers. Transdiag markers to replace, measuring how emotional people say they are, or to look at the effects of treatment. Does treatment reduce the marker? And does that reduction in the marker correlate with a future reduction in mental health problems and cardiovascular diseases? So I think there's a compatibility between this tool of electrophysiology and this problem area that we're discussing. So here are some examples of findings. Depression has been implicated in reward non-responsivity using this paradigm, anxiety and error monitoring, and trauma and PTSD with both controlled and automatic attentional processes. Now, there's a particular ERP component, LPP, late positive potential, that might particularly lend itself to this kind of application. You can see there its characteristics in terms of time and location and underlying brain processes or brain areas. It appears to be an index of attentional reactivity attention to emotional stimuli or reactivity to emotional stimuli. And you see here results from my collaborator, Eric Fedorenko, showing a typical response in which the LPP amplitude is greatest for negative or unpleasant stimuli, also elevated for positively valenced stimuli, and lowest for neutral stimuli. So another index that might get at the threat process that culminates in the biological reactivity that lies at the heart of this psychobiological model. LPP has been looked at in depression, among other applications. And so depressives are described as having, quote, abnormal LPP modulation. For example, a smaller amplitude response to both pleasant and unpleasant stimuli. This has been empirically associated with suicidal ideation. It may reflect emotional insensitivity or disengagement. It would be congruent with reward insensitivity, which was documented in other work, and it would be congruent with other things that we know about people high in depression. So the questions would be, is LPP associated with dysregulated biological stress reactivity? For example, blunting of biological response to stressors, which has been seen particularly in depressed individuals and has been linked to heart disease. Is it related to systemic inflammation, given the effects of inflammation when it crosses the brain barrier on positive emotion, reward, and the like? In a possible example of another abnormal LPP modulation in depressed individuals. Again, this is the work of my former student, Eric Fedorenko. He found that subjects who were trauma exposed, who were higher in depression, had a smaller LPP to neutral stimuli. Not expected, possibly a reflection of top-down attentional control being reduced in depressive individuals based on other research. So that would have to be replicated and more directly linked to its underlying cause. Last but not least, with regard to evoked potentials, there is an ERP that is produced by each heartbeat. And you can see there some of its characteristics and the underlying sort of generators of the response. It reflects cortical processing of cardiac signals, and it's been used and demonstrated to work as an interoceptive, a measure of interoceptive sensitivity. The mind, the brain, responding more strongly to the signals set to the brain by the cardiac contractions that occur with each heartbeat. And it's been examined in work in anxiety, depression, PTSD, and the treatment of these disorders. And so if you recall, in this idea of health neuroscience, there is bidirectional influence in which the body and behavior feed up to influence the brain. So interoception would be an example of a process that does that. It may reflect processes whereby stress reactivity is regulated. In other words, interoception may in turn regulate the generation of the signal, for example, cardiovascular reactivity, that is picked up by the cortex in a sort of self-fulfilling or vicious cycle. There's been limited work examining this idea with regard to heart disease using this ERP component in the context of depression, anxiety, or PTSD, or treatment for that matter. It's obviously a complex research program or programs that would be required. And there's some examples, but not a whole lot yet. So some possible applications of electrophysiology. These are results from a study that we actually did to test interoception as a basis for type A behavior. And we found that a medication that reduces cardiovascular reactivity increased type B behavior, reducing therefore type A behavior, conceivably as a consequence of reducing the feedback to the brain through an interoceptive process. So to conclude, with regard to these involving ideas of mechanisms, we've seen interactions, work on the interplay between stress biology and unhealthy behaviors. A life sciences mechanism concept is becoming more prevalent, especially in neuroscience. More multi-level work, such as in the childhood adversity area, multidirectionality, and the notion of common etiology or even overlap of mental and physical health. So I'll end with some quotable quotes. Hippocrates apparently knew he was onto something. Not a whole lot has changed since then. Hopefully some things have changed. So I'll stop there and thank you for your attention. And see if I could turn off the sharing. And I could try to address any questions if there's time. Sorry if I went over.
It's totally fine, Professor Contrada.
I don't
Thank you
hear
so
you.
much for your... Hello? Can you hear me, Professor? Hello?
I'm not sure what's happening. Oh, I see there are questions. First,
Sorry, Professor, can you hear me?
okay. How important is social support compared to personal coping strategies and buffering stress? I think it's probably more important because there's so many ways that social support can address stress. What the person does on their own as a coping strategy is only part of that picture. So the potential is there for more work on social support interventions to maximize that kind of buffering effect. In addition to coping training, but I would say if I had to bet your money, I'd bet on social support. And in terms of prevention, should psychological well-being be considered as important as diet and exercise for protecting the heart? I don't think we know that yet because intervention studies have validated dietary modification and exercise, whereas we've had disappointing results for modifying personality and mental disorders. I don't know if you heard me. Apologize if you didn't.
Hi, Professor, can you hear me? Okay, thank you very much, Professor Contrada, for your amazing presentation and also for your very enlightening
Correct.
answer and for sharing your
Anyway, I'll
insight.
sign off. Thank you for your attention.
Yes, thank you so much, Professor Contrada. I will now hand the floor back to Luana, who will introduce our final speaker of the day. But before that, let's take a quick 5-minute break. Thank you, everyone.
Okay, great. We're going to continue with our final speaker of the day, Professor Carmen Pedraza Benitez. Professor Carmen Pedraza Benitez is a professor of psychobiology at the University of Malaga, specializing in neuroscience research and teaching. She holds both a BA and PhD in psychology from the same university, where she earned the Extraordinary Doctoral Award. Her research focuses on the role of lipid transmitters in neurogenesis and behavior, and more recently, on the interplay between stress, neuroinflammation, neuroplasticity, and the gut microbiome in relation to depressive disorders. She has also led nationally and internationally funded research projects, collaborated with global research teams, and published over 70 indexed scientific papers. Professor Benitez will present her paper with the title Unraveling Stress-Induced Depression, Neuroinflammation, Neuroplasticity, and the Role of Sex and Individual Differences, which explores how neuroinflammatory processes and maladaptive plasticity interact with sex and individual-specific factors to influence vulnerability or resilience to depression. Let's welcome Professor Carmen Pedraza Benitez as she takes the floor.
Thank you very much for your kind presentation. Good afternoon. And it is an honor and pleasure for me to be here today to share our work about stress and depression. Okay. And before begin, let me briefly outline what we cover today. We will explore how stress can shape brain, influence vulnerability to depression, and how factors such as neuroinflammation, neuroplasticity, and individual differences contribute to the complex interaction. To start with, I will give a brief overview where is stress and depression are from a biological point of view, and how they are connected. Then we will look at animal models that help us understand this mechanism more precisely. Finally, I will show some of our findings of what they tell us how the stress affects the brain and behavior. What is stress? Stress is a normal and adaptive reaction selected through evolution for its survival value. It helps us respond quickly to danger, for example, to fight and flight or adapt to new circumstances. However, it is important to note that not all stress is harmful. Problems arise when the stress response stays active for too long, when we continue to perceive the threat even after it's gone, when the lion exists only in our mind. The body remains in a state of alert. The sympathetic nervous system releases stress hormone, especially cortisol, and what should be a short-term adaptive response became chronic stress. This chronic activation can damage many systems in the body, including the immune system, the cardiovascular system, and of course, the brain. What is depression? Depression is not simply feeling sad. It's a multifaceted disorder that affects thought, emotion, and behaviors. Common symptoms include persistent sadness, loss of motivation or pleasure, social withdrawal, sleep and appetite disturbances, fatigue, difficulty concentrating, and sometimes feeling of hopelessness or thought of death. From a clinical perspective, we say a person is depressed when these symptoms last at least 2 weeks and interfere with daily functioning, socially, occupationally, or personally. Depression is also highly heterogeneous, meaning it looks different in each person. Some experience more emotional symptoms, or others more cognitive or physical ones. This variability makes it difficult to treat effectively. At present, over 300 million people worldwide are affected by depression, and 1 out of 4 individuals will experience at least one depressive episode in their lifetime. In addition, depression increases the risk of various medical conditions such as cardiovascular disease, diabetes, asthma, and chronic pain syndromes. In no effective measure are taken, so also why depression could become the next global pandemic. Let's now look at how sex and individual differences shape the risk and expression of depression. Women are about twice as likely to develop depression as men, and stress tend to have a stronger emotional impact of them. After the COVID-19 pandemic, the increase in depressive symptoms was particularly striking among women. However, the symptoms often differ between sex. Women usually show low mood, dysphoria, or an appetite and sleep changes. Men are more likely to express irritability, aggressiveness, or substance abuse as depressive equivalent. Interestingly, although women are more frequently diagnosed with depression, suicide rates are around 4 times higher in men. Another important factor is treatment response. Despite the high use of antidepressants, particularly in women, only about the 25% of patients fully respond to current treatment. Another quarter show partial improvement, while the rest experience little benefit or side effects. This suggests that our current pharmacological approach, largely based on the monoaminergic hypothesis focused on serotonin or noradrenaline, does not fully explain or solve the problems. One key limitation is that historically, most clinical and preclinical studies included only males. It was not until 1993 that women were systematically included in clinical trials, and not until around 2016 that female animals began to be studied regularly in neuroscience research. This lack of inclusion has left an important gap in our understanding of sex-specific biological mechanisms in depression. Overall, these differences show why a more personalized approach is essential when studying and treating depression. And where is the link between stress and depression? Before exploring how stress leads to depression, we need to understand one key concept: allostatic load. Allostatic load refers to the price the body pays for being forced to adapt to chronic stress. It's the process by which the body tries to regain balance and homeostasis after exposure to challenges. When stress is moderate or temporary, the brain adapts through a mechanism we call neuroplasticity, the ability of brain to change its connection and function based on experience. However, when stress is too intense or too prolonged, and we combine with unhealthy habits like sleep deprivation, poor diet, lack of exercise, or recurrent illness, the adaptive capacity is overwhelmed. At that point, the allostatic load becomes excessive and pathological. Changes begin to emerge in the brain, in the immune system, and in behavior. So, what happens in the brain under chronic stress conditions? Stress affects many brain regions, but one of the most sensitive and vulnerable is hippocampus. This structure plays a crucial role in learning, memory, and emotional regulation. Under prolonged or stress, the hypothalamic, pituitary, adrenal acids became dysregulated. Microglia, the brain's immune cells, became overactivated, and inflammatory molecules such as cytokines are released. At the same time, neurogenesis, the formation of new neurons in the hippocampus is reduced. These combined effects alter both brain structure and function, contributing to the emergence of depression symptoms. I'd like to focus on two fundamental processes, neuroinflammation and neuroplasticity, and how they balance determines resilience or vulnerability. Let's define briefly. Neuroinflammation refers to activation in immune mechanisms in the brain, mainly through microglia, which release inflammatory molecules can alter neuronal communications. Neuroplasticity is the brain's ability to recognize itself by forming new neuronal connections adapted to experience, learning, and injury. When inflammatory persists, it disrupts plasticity. The interplay is the core of stress-induced depression, a key focus on our research. To study this mechanism in depth, we use animal models. Laboratory animals can reproduce many of biological and behavioral alterations observed in humans, allowing us to explore neurobiological mechanisms that cannot be directly studied in people. One main goal is to replicate in animals the kind of stressful condition that humans experience. For instance, early life adversity, chronic stress, or traumatic events. We always consider sex and individual differences, since there is a key understanding why not everyone exposed to stress develops depression. Stress is an environmental risk factor for depression. It in part depends on when it occurs in life. For example, early life stress, such as maternal separation and neglect, can interfere with the normal developed brain circuits that regulate emotion and stress responses, leading to greater vulnerability to depression later in life. By contrast, chronic or intense stress during adulthood can also disrupt brain plasticity and trigger inflammation, contributing to depression onset and release. Therefore, it is crucial to understand how stress interacts with both genetic and environmental factors across development. During development, the brain undergoes profound transformation that make it highly sensitive to external influences. These include processes such as neurogenesis, the birth of new neurons, cell migration as neurons move to the final destination, synaptogenesis, the formation of new connection between neurons, gliogenesis, the creation of supporting glial cells, and myelination, the formation of insulating myelin that covers axon and allows neuronal communication. These developmental processes occur at different times, meaning that an stressor during a stage may have very different effects than the same stressor at another stage. That's why the sensitive windows are so important in our research. In our lab, we expose animals to stress during different developmental stages, postnatal, juvenile, and adult periods. Sometimes we applied the so-called two-hit hypothesis, which proposed that an early life stress increased vulnerability to a later stressor in adulthood. This combination allows us to simulate what happens in people who experience childhood adversity followed by adult stress, and to observe how these experiences interact. So how do we model this in the lab? In what version of our protocol, animals are exposed to maternal separation, stress early in life, which mimics neglect or emotional deprivation. Later, during adulthood, they experience mild stressors such as a brief immobilization. When used, 4 main groups: control animals not exposed to any stress, animals exposed only to adult stress, animals exposed only to early life stress, and animals exposed to both early and adult stress in both males and females. After this exposure, we analyze behavior and brain changes. We also use a juvenile stress model, similar to design but applied during the prepubertal period. In this case, animal experience mild physical restraint, which limit movement for a short period, a situation comparable to psychological frustration and helplessness in human, followed later by adult stress. In summary, these two hit paradigms allow us to capture a more realistic view of human vulnerability, where early stress primes the organism for a stronger response later in life. To evaluate depressive-like behavior, we examine several case domains. Anhedonia, or the loss of pleasure. We test this with the saccharine preference test, offering animal a choice between sweetness water or plain water. A reduced preference indicates anhedonia. Social interaction. 6. Social withdrawal is a hallmark of depression. Next building test, we reflect motivation and self-care. With this graph, it indicates fatigue or apathy. Basic coping strategy are learning helplessness when animals stop trying to escape or a situation they perceive as uncontrollable. Anxiety-like behavior using the open file test, where animals that avoid the center are considered more anxious. These behavioral tests help us identify susceptible and resilient animals, similar to individual differences seen in humans. Moreover, it was observed that postnatal stress affects anxiety in males. Affects anxiety in males. In females, the coping strategy show an opposite pattern that we initially expect. We expect to adult stress induce more passive strategy, but we observe the opposite in women under adult stress, but postnatal stress. Postnatal stress also impacts motivation and fatigability in males, since the effects is not evident in females subjected to the Doppler condition. For instance, in our experiments, female mice exposed to juvenile stress often show a stronger depressive pattern. We can see here in the second picture, such as lower saccharine preference and greater anxiety than men. In contrast, males sometimes engage the saccharine consumption after stress, which may parallel how some human males turn to substances or ritual seeking behavior under stress. At the behavioral level, however, how intensive the juvenile stress may affect motivation and self-care behavior. It also induces a reduction in stress coping ability and exploratory behavior, along with an increase in anxiety and decreased motivation and increased fatigability, although in this case the predominant factor is fear. In males, it is mainly juvenile stress, whereas in female is the combination of both juvenile and adult stress that produce this effect. Overall, from a behavioral perspective, we observe a greater impact of postnatal stress in males and of juvenile stress in females. To understand what happened inside the brain, we studied two major systems, microglia and adult hippocampal neurogenesis. Microglia are the immune cells in the brain. Under normal conditions, they monitor the environment, maintain homeostasis, but under stress, they became reactivated, changing their shape, extending branchings, or releasing inflammatory cytokines. We performed detailed morphological analysis, measuring soma size, branching density, and circularity, and also molecular determination assay to assess the activation levels. Interestingly, our data show that early stress has a stronger impact on microglia in females. than in males. Female microglia tend to be more reactive, but not always in the way we would expect. Surprisingly, some parameters indicated a reduction of IVA1 volume, a marker of microglia, suggesting that stress may not always trigger a classical inflammatory response. However, we observe a decrease of PCD95, 95, a protein associated with synaptic integrity, which suggests disruption of neuronal connectivity, another route through which stress may impair brain functions. In contrast, juvenile stress leads to an increase of pro-inflammatory cytokines and activation of microglia. We also analyze adult hippocampal neurogenesis, the process through which new neurons unfold during a lifetime. To trace dividing cells, we use thymidine analogs. A compounds incorporate into DNA during cell division. This, with another marker, allows us to track the fate of newborn cells, determining the age, maturity, state, and integration into the hippocampal network. Combining these markers help us understand how stress alters the balance between inflammation and plasticity. Postnatal stress also affects neurogenesis, also once again in an unexpected direction. For instance, in the ventral hippocampus, the regions involved in emotional processing, females show enhanced maturation and newly generated neurons following postnatal stress. In contrast, in the model of juvenile stress, adult stress impacts both proliferation and maturation of hippocampal cells in both males and females. Together, defining highly delicate interplay between immune activation and neuronal remodeling in shaping stress outcome. In addition to early life and juvenile stress models, we also study adult stress paradigms, such as post-traumatic stress and social defeat, which allow us to examine different types of adversity and the impact on the brain. In the post-traumatic stress models, animals exposed to acute intense stressor, similar to traumatic event, immediately after exposure, we observe a sharp increase of corticosterone, the main stress hormone, in rodents. However, after 24 to 28 hours, we observe a hypocortisolism, a condition, a reduction of corticosterone, similar to seeing humans suffering from post-traumatic stress disorder. Behaviorally, this animal show a striking reduction of pleasure-seeking behavior, such as decreased saccharine preference, which can last for several days, a long time in a rodent's life. And using a principal component analysis, we found that stress affects both comfort-related and discomfort-related behavior, supporting the idea that acute stress produces widespread emotional disruption. We also conducted a large-scale proteomic study, proteomic study following acute and intense stress, and found widespread changes in expression of protein related with inflammation, synaptic plasticity, and neural degeneration. These alterations were already detectable 1 hour after stress, but became much more pronounced at 24 hours. At the cellular levels, acute stress induces neuroinflammatory and neuroplastic changes, increased IVA1 expression and microglial marker, reduced cell circularity, a greater soma area, typical from inflammatory states, decreased BRDU cells indicating a reduce of neurogenesis, particularly in immature neurons. Altogether, this finding suggests that even a single traumatic event can produce those lantern effects in our brain function, behavior, and plasticity, closely resembling what we observe in post-traumatic stress patients. Another model we use is social defeated stress. We simulate chronic social conflict or bullying. In this paradigm, known as resident intruder test, a smaller mouse, the intruder, is placed in the territory of an aggressive resident for several minutes per day, usually for 10 consecutive days. After this period, we observe two behavioral phenotypes: susceptible animals which display strong depression-like behavior, and resilient animals which recover and behave similar to controls. Stressed animals typically show lower saccharin preference, reflecting anhedonia and reduced social interaction. However, resilient animals often display normal social interaction and recover more quickly, which suggests adaptive coping mechanisms. When we analyze the brain of these animals, we find that stress-sensitive mice show reduced neurogenesis, especially the type B and C cells, two kinds of immature neurons in the hippocampus, and in contrast, resilient animals preserve a healthy level of neurogenesis and show more stable microglial morphology. In females, we have adapted this paradigm to mimic intimate partner violence or chronic social stress. And again, we see a clear individual differences. Sensitive females, we can see in this picture, in depressive symptoms, exhibit stronger anhedonic response, whereas resilient assure normal hedonic behavior and level of neurogenesis is similar to control, particularly in regions such as the hypothalamus, which might help buffer the stress response. In recent years, our attention has also turned to the gut-brain axis, focusing on how microbiota, the community of microorganisms in the intestines, interacts with stress and depression. Social defeat stress produces a marked dysbiosis, meaning an imbalance in the composition of gut bacteria. When we compare control and the stressed animal, we see a reduction in bacteriodota and proteobacteria, this one, and an increase in firmicutes. Importantly, some beneficial species are significantly reduced after stress exposure. Interestingly, when we conduct a fecal microbiota transplantation experiment, transferring microbiota from stress or control animal donors into microbiota depleted recipient animals, we observe that the recipient develop behavioral traits similar to those of the donor. For example, animals receiving microbiota for stress-sensitive donors show reduced social interaction, while those receive microbiota from resilient donors show more adaptive behavior. This suggests that microbiota can transfer some aspect of the depressive or resilient phenotype. This line of research opens a fascinating perspective. The microbiota composition may not only reflect stress exposure, but actually contribute to behavioral outcomes. Our mediation analysis further indicated that changes in microbiota can influence neurogenesis and microglia activation, ultimately affecting depressing life behavior. In other words, the microbiota may not only respond to stress, it may also mediate its impact on the brain. Let me now summarize the main take-home messages. Early life stress has a stronger and more lasting impact in adult stress because the developing brain is particularly sensitive to external influences. Chronic stress produces greater and more persistent alteration than brief and moderate stress. Social stress is especially harmful, often more than non-social stressor. These stressors lead to change in neuroinflammation and neuroplasticity, which contribute to the development of depression symptoms. Sex and individual differences critically determine vulnerability and resilience. Finally, the gut microbiota appear to play a mediating role influencing both neurogenesis and microglial function, and therefore the brain's capacity to adapt to stress. To sum up, our results converge in one idea. Stress, inflammation, plasticity, and microbiota form an integrated network that determines mental health and resilience. All these elements are interconnected part of a system, shaping how we respond to life challenges and ultimately our well-being. Before closing, I would like to express my gratitude to my research group, my colleagues, and our collaborators, whose dedication and creativity make this work possible. This research has been supported by national and regional funding programs and by University of Malaga, which provide a stimulating environment for scientific growth and cooperation. To conclude, I would like to leave you with a simple thought. Understanding stress means understanding ourselves a little better. By studying how the brain adapts and sometimes fails to adapt to stress, we move closer to preventing and treating depression, but also to fostering resilience and emotional well-being in our societies. Thank you very much for your attention.
Thank you very much, Professor Carmen Pedraza Benitez, for this presentation and taking the time to be here with us. For sure, your work has an important perspective to today's exploration of trauma, the brain under stress, of course, emphasizing the interplay between stress, neuropsychology, and individual differences. Thank you so much again, and we'll now open the floor for questions from the audience. Just 1 second, we have 2 here waiting. So first, great research and presentation, Professor Carmen. In your view, what are the main biological differences between individuals who develop depression following chronic stress and those who remain resilient?
We find in our research that the resilient animals have better level of neurogenesis and maturation of neurons. When the neurons is mature, integrate into hippocampal circuit, and the neurogenesis is very important to coping with stress because the hippocampus is very important structure to stress. Another part is the microbiota. We find that the resilient animal have different species of phylums of microorganisms in the intestine. Probably the combination between the neuroplasticity and microbiota make an individual more resilient or more vulnerable to depression. Sorry.
Great, thank you so much. The next question, thank you for this presentation. With the postnatal stress model, do you observe psychological effects other than depression and anxiety, like maybe increased aggressivity or increased susceptibility to addiction?
And Postnatal stress, we don't observe any change different to depression to anxiety. But in juvenile stress, we observe in males an increase of saccharine preference. Probably is similar to observing human, particularly during the juvenile period, induce an increase of abuse of substance abuse. Probably is parallelisms between juvenile stress in males and that we observe in humans, and probably increase consumption of alcohol or other substances or drugs.
Thank you. I'm going to put the questions from now on so you can see them. Is there a difference between depression and a depressive symptom of another psychiatric pathology?
Sorry, can you repeat, please?
Is there a difference between depression and a depressive symptom of another psychiatric pathology?
Depression is very heterogeneous disease, and we observe several symptoms or different symptoms. It depends on the individuals. In another pathology, we observe some similar symptoms, but combined with another symptoms. They share some symptoms, but depression has a specific symptom related with this pathology, and another shares some symptoms similar.
Great. In your research, have you observed any specific patterns in how the microbiome influences neuroplasticity or vulnerability to stress-related disorders?
We are now we had several experiments to try to demonstrate that, because it's our hypothesis that microbiota changes neuroplasticity, and neuroplasticity changes microbiota, and these interconnections can change the behavior. But we have now this experiment, and I can't tell the result at the moment, but it's our hypothesis at the moment.
Great. And last question. As the gut-brain axis is an increasingly discussed topic nowadays, how significant do you think the role of the microbiome is in modulating stress-related inflammation and depressive symptoms, and whether do you believe in probiotics and dietary changes?
Okay. And we think that stress changes the permeability of the intestine. And this can induce a lot of neurotoxic effects and increase the inflammation and the cytokines in the body, but also in the brain, because sometimes change the hematoencephalic barrier due to the change in the intestine. And if we have stress and we eat not very good food, the microbiota can induce more neurotoxic effects and more inflammation in the body, and the probiotics can regulate it, but it depends, because some probiotics can induce dysbiosis, and dysbiosis is not good idea. There is an imbalance in the composition of microbiota. The important is the balance and the variability of species in the microbiota to have a good balance between these microorganisms in the body.
Yes, I know there's a lot of research in this area at the moment from different perspectives. So thank you so much for answering those questions and for ending our first day of the 4th edition of NeuroCon, Professor Pedraza. I hope you also enjoyed it, just like us.
Thank you.
And we wish you a great evening. So with that, we conclude the scientific presentation for today. We hope you found the talks insightful and thought-provoking, like an open door for new conversation or even emerging research. On behalf of the NeuroCon 2025 organizing team, I would like to thank again all our speakers for their time and dedication and for coming to our conference. and for you participants for attending the conference Trauma and the Brain Under Stress. Before ending the day, I would like to mention the 2 remaining days that we have left for this edition. Day 2, which is tomorrow, will focus on the search for effective strategies for resilience and intervention, bringing together researchers and clinicians who explore how we can promote recovery and adaptation following trauma. Then on day 3, on Saturday, we'll shift our attention to how trauma affects behavior, mental health, and society across the lifespan, integrating perspectives from neuroscience, psychology, and social sciences. Before we close, I would like to remind to all participants that they're going to receive a certificate of participation for attending at least 60% of the conference. And I would like again to thank you all for being part of NeuroCon 2025. And we look forward to seeing you tomorrow at 9 a.m. Central European Time, 10 a.m. for Bucharest, Eastern European Time. And I wish you a wonderful evening.
Thank you.
Thank you, Professor.
Bye.